COVID-19, the pandemic that never should have happened, and how to stop the next one. Written by Debora Mackenzie. For James, Jessica, and Rebecca, who make everything possible, and in grateful recognition of the scientists and journalists who do their best to find out what's going on and try to save us from it. Preface. In November 2019, a coronavirus from a common little bat jumped, somehow, to a human, or maybe a few of them. It just happened that the virus could spread easily among people already, or it evolved fast, as these viruses can. By December, a cluster of people were hospitalized with severe pneumonia in Wuhan, China, and it wasn't the flu. Not enough was done to contain this new virus until January 20th, when China told the world it was contagious. By then, there were already so many cases in Wuhan, the city had to be locked down 3 days later to control the epidemic. But it had long since spread all over China and to other countries. The virus was named SARS-CoV-2 because it was so similar to another one we had barely managed to beat back in 2003. As you know, the disease it causes was named COVID-19. CO for corona, VI for virus, D for disease, and 19 for the year it appeared. A lot of people just call it the coronavirus. 3 months after Wuhan was locked down, some 2 billion people worldwide were also in some form of lockdown, and everyone, everywhere faced infection with the virus, with few effective treatments and no prospect of a vaccine anytime soon. COVID-19 has infected the entire human world. This pandemic has been like a big dog, picking up our fragile, complex society in its teeth and shaking it. Lots of us have died. Lots of us will continue to die, either from the virus itself or from the long-term poverty, political and economic dislocation, and overloaded medical systems that will be the pandemic's legacy. Some aspects of our society will change for the worse, some maybe for the better, but either way, for good. And through it all, we have been deluged with reams of news reports and instant analyses, heartbreaking frontline accounts, revised government instructions, and new medical advice, plus probably the most staggering global outpouring of instant scientific research in history, all trying to predict what's coming next and figure out how to mitigate this disease disaster. But you know all that. And still there is the question, how could this happen? This is the 21st century. In much of the world, we have wonder drugs and flush toilets and computers and international cooperation. We don't die of pestilence anymore. Sadly, as we all know now, yes, we do. But what is especially sad for a science journalist like me who writes about disease for a living is that this pandemic has not exactly been a surprise. Scientists have been warning for decades, with mounting urgency, that this was going to happen. And journalists like me have been relaying their warnings that a pandemic is coming and that we aren't prepared. How did we find ourselves in this situation? In short, there are more and more people, and too many of them have had to put ever-increasing pressure on natural systems to get the food and jobs and living space they need. That means pushing into wilderness that harbors new infections and intensifying food production in ways that can breed disease. COVID-19, Ebola, and worse come from destroying forests. Worrying flu strains and antibiotic-resistant bacteria come from livestock. Yet, we have neglected to invest in the things that discourage infectious disease: public health, decent jobs and housing, education, sanitation. Then, the impact of the new pathogens we unearth is magnified by our ever-increasing global connectedness as we crowd into cities and trade and travel in an ever-denser global network of contact. So once public health fails and contagion appears anywhere, it goes everywhere. We know so much about beating disease, yet fragmented governing structures, lack of global accountability, and persistent poverty in so many places ensure that those failures happen and disease propagates. Despite all that, we know what we need. Much better understanding of potentially pandemic infections, fast detection of new outbreaks, and ways to respond to them quickly. I'll be looking at that in this book. So far, we haven't been able to do that effectively where it is most needed. In 2013, 2 labs, one Chinese, one American, investigated a tribe of bat viruses that are almost certainly the source of COVID-19. They immediately recognized the threat. One lab called them pre-pandemic and a threat for future emergence in human populations. The other wrote that they remain a substantial global threat to public health. Nothing was done. We could have learned more about them, designed some vaccines, looked into tests and treatment, studied ways these viruses might infect human populations, and shut those down. None of that happened. It was no one's job to take on those tasks with this kind of threat, even when it materialized. Yet we needed so much to be in place if one of these viruses went global, which one did. You don't need to be told. Testing, ventilators, drugs, vaccines, protective gear for doctors and nurses, a plan for using old-fashioned quarantine and isolation to stop this kind of virus from spreading, a plan for dealing with the economic impact, measures to contain the virus so we might not even need those things. Experts and governments have been talking intensively about pandemic preparation for nearly 2 decades, and still we weren't prepared. And this kind of virus wasn't, and isn't, even the only viral threat out there, yet we're just as unprepared for the others. I wrote the following for New Scientist magazine in 2013, the year the COVID-like viruses were discovered, about a visit to the World Health Organization's then shiny new Situation Room, and what might happen if H7N9 bird flu, the virus causing concern at the time, went pandemic. As it stands, the World Health Organization's top brass will watch any H7N9 pandemic unfold from their Strategic Operations Center. Information will flood in, body counts will mount, governments will be told that their demands for vaccines and drugs cannot be met. They will issue declarations, hold briefings, organize research, tell people to wash their hands and stay home. Mostly, though, they will just watch helplessly. Sound familiar? Especially the part about washing your hands and staying home? I don't claim to be prophetic. I'm not. Other journalists and scientists have said as much and more. As far back as 1992, the top infectious disease scientists in the U.S. warned about emerging infections, declaring that the threat from disease-causing microbes will continue and may even intensify in coming years. If that sounds like unusually cautious language, even from scientists, it's because they were afraid any stronger language would trigger disbelief. That's almost all that has changed. It's not that they weren't heard. In the years since then, we all started half expecting a pandemic. Pandemics became part of the cultural background noise, reflected with varying balances of science and entertainment and zombies in films like Outbreak, Contagion, and I Am Legend. There was some disease surveillance set up, new international rules written, a lot of virus research. A few countries had pandemic plans, on paper. Yet, when the lockdowns began, in many places toilet paper was more in demand. The only real surprise when COVID-19 finally hit was the sheer extent to which most governments simply had not listened to the warnings. We were unable as a planet to muster our considerable scientific understanding of disease in time to soften the blow, never mind preventing it in the first place. And, as I will explain in the coming chapters, we could have. At least a lot more than we did. Science didn't actually fail us. The ability of governments to act on it together did. Experts had warned about the lack of preparation in addition to the risk of a pandemic itself. The few countries with pandemic plans built them around a very different virus, flu, and regardless, many failed to stockpile or acquire the most basic essentials for making the plans work. I'm not sure their response would have been much more effective if this had been a flu pandemic, which we will have at some point. The World Health Organization, WHO, made it very clear how to contain COVID-19, but few countries followed their advice entirely. A few showed what should have been possible for all countries. The rest did pick-and-choose variations on the WHO's advice or that of their scientific or political advisors. Nearly all countries were more or less too late to limit the damage as much as they might have, and the pain of lockdowns and economic dislocation in some places seemed to rival the disease. But you know that. So, besides the question of how this could happen, the other big questions are, can this happen again? And can we do better next time? The answer to both is yes. Some real pandemic planning is now in order, because the COVID-19 pandemic may not even be the worst we could see. And even COVID-19 could still have some tricks up its tiny sleeves. First, let's look at the immediate future from the virus's perspective. Eventually, after considerable death and disruption, most people in the world will have been exposed to or vaccinated against COVID-19 and will be, we hope, immune to further infection with the same virus as a result, at least temporarily. So, with fewer people around that it can still infect, new cases should slow to a trickle. The virus might even quietly die out, as its sister virus SARS did in 2003 when we blocked enough chances for it to spread. Or it might adapt to its new situation. RNA viruses like this one can evolve quickly, although the COVID-19 virus isn't quite as volatile as some. Like flu, it might mutate to evade the immune defenses our bodies will eventually learn to mount and start another global rampage, perhaps a bit less deadly this time, or perhaps a bit more. The comforting myth that viruses become more benign as they adapt to us is simply not true. It all depends on what works for the virus, and it can go either way. We will look at that later in the book. Or it might circulate and surge sporadically, perhaps pouncing on new susceptible humans, becoming yet another disease of childhood. This pandemic has moved fast since it started. You may already know something about which of those scenarios is playing out. There aren't, broadly speaking, a lot of different things a disease can do, bound by the implacably quantitative laws of epidemiology, the science of epidemics. Until then, horrific as it has sometimes been, we can be grateful it hasn't been worse. COVID-19 does not have a massive death rate. Best guesses, as I write this, are that it's less deadly than we initially feared, but still maybe 10 times more deadly than ordinary flu. SARS was 10 times deadlier than that. Fortunately, it never learned to spread like COVID-19, and, with luck, COVID-19 will never learn to kill like SARS. Think about what this pandemic would have been like with 10 times the death rate. And, as many of us have painfully learned, COVID-19 mostly kills older people. Speaking as one myself, I don't wish to be cavalier about this, but the brutal fact is that losing people in old age does not cause as much economic or social disruption as losing people of working and childbearing age. And even that will pass. In a year or 3, with luck, we may have drugs and vaccines to protect everyone, including the elderly. So why write a book about this when there's still a lot we don't know? Because we already know enough to say some important things, and we need to do that while memories of these hard times are raw enough for people to hear them. The first thing to say is that this was predicted and could have been, to a large extent, prevented. As for prediction, I am just one of many journalists who has been warning about the threat of a pandemic since the 1990s, and some were at it earlier. Since at least 2008, the U.S. Director of National Intelligence has warned the President that a pandemic of a virulent, novel respiratory virus was the most serious threat the country faced. In 2014, the World Bank and the OECD, the Club of Rich Nations, called a pandemic the top catastrophic risk, outweighing terrorism. Bill Gates has been warning that we aren't ready for a pandemic for years. Second, this pandemic won't be the last one. There are simply too many potentially pandemic germs out there to predict which will emerge next. But before COVID-19 happened, we knew coronaviruses were among the leading possibilities. They were on a WHO watch list. Even with such warnings, we didn't do enough preparatory work on drugs and vaccines for coronaviruses like COVID-19 to allow us to easily adapt and produce them now. And we still haven't for many other viruses that pose a threat, including H7N9 and its kin. We need to do that now. We also need to do some serious pandemic planning for when the next one happens. The Center for Health Security at the Johns Hopkins Bloomberg School of Public Health was among the institutions already trying to do that. Among other efforts, they were running computer simulations of hypothetical pandemics as a training exercise for public officials. A month before the first cases appeared in Wuhan, they ran one called Event 201, starring a fictitious virus that was nearly a dead ringer for COVID-19. I can think of few better illustrations of how we knew this was coming. Let me emphasize that this was a total coincidence. This was a what-if scenario playing out in a computer model of U.S. society, featuring a made-up virus. They chose a coronavirus for the simulation partly to show how disruptive even a relatively mild virus can be. They succeeded. The result of the simulation was what we are living out now. Overwhelmed healthcare, disrupted global supply chains, needless death, economic dislocation, and a table full of officials from government and industry sitting there saying, "If this were to happen, there's not much my sector, department, office could do." And the people who wrote that simulation were going easy on the officials. Maybe so they'd sit through the entire afternoon and not be so horrified they'd quietly slip out at the coffee break, trying to forget what they'd seen. There are much worse viruses out there that could trigger a pandemic that would kill more people at younger ages. It will not be much comfort to those who have lost or will lose loved ones to COVID-19, but so far, believe it or not, we've been lucky. In addition, what almost no one realized before COVID-19 happened, I don't know how many realize it now, was what a pandemic could do to our complex, just-in-time society, and that economic domino effects would cascade through our tightly coupled global support networks. What we need to remember, though, is that we will have another pandemic, and it could be worse. So we have to do better. And we can. The hard-earned good news is that COVID-19 has shown us what we need to do. We cannot let a virus catch our interconnected global community this stupidly flat-footed again. We cannot let it break those interconnections either. At least, not all of them. If this pandemic teaches us anything, it is that up against a contagious disease, we are all in this together. One big early lesson was that no country can really seal off their borders anymore, or go it alone. Our society is global. Our risk is global. Our response and our cooperation must be global. I can't think of a time when this pandemic will be over enough to provide a better vantage point for looking at these things. When the virus does grind to a halt, or we tame it with vaccines, it seems all too likely that we will drift back into a status quo of spending on wars and weapons, and on recovering from the economic damage COVID-19 is doing, not on preparing for the next virus. We will need to forget this nightmare, and to judge from past pandemics, we will. Yet, at this moment, the subject has our undivided attention. We can already say a bit about how this happened and why, and what our options are to start doing better. Many scientists know this, and governments, we hope, will learn. But a lot of other people need to think about this too, whatever you do in life, in the kind of detail that will allow you to help make the changes we need. In any disease emergency, certainly in a pandemic, it is vitally important to tell everyone the whole truth, what we know and what we cannot know, and not hold back for fear of scaring people. That is a mistake that governments and other authorities make repeatedly with bad news stories like diseases. What is happening might be scary, but saying so might galvanize people to take more effective action. Sometimes fear is necessary. That's why we have it. But it shouldn't have to come to that. This is where you come in. Learning from this pandemic and preventing the next one will take political action of all kinds, from everyone. The more people understand what we need to do, the more likely it is to be done. People vote, people march, people pressure. People decide to study virology, or public health, or nursing, or vaccine engineering, or communications. Public activism drove the development of HIV drugs and made them affordable. It drove the introduction of sanitation, the massive success of vaccination, the beginning of the end of smoking. We can do it again. We have to. To find out what is happening with COVID-19 right now, read the news. For exposés and analyses of what this and that government or politician did wrong in dealing with it, also read the news, and the stories that will pour out over the coming years. I know I will. In this book, I'm going to give you the big picture. We'll take an in-depth look at what happened and whether we could have stopped it, before looking at the recent past to learn the natural history of some of the more amazing natural phenomena that make us deathly ill. We'll see how previous pandemics and threats of pandemics should have prepared us and learn the lessons we failed to apply before and after COVID-19 emerged. Then we can talk about what we need to do better before the next one hits. I hope that, eventually, we will do more than talk. A note on the virus. The WHO, in its wisdom, decreed that this disease would be known by the unlovely name COVID-19. Many people and many languages have just stuck with calling it the coronavirus. That is a much prettier word, but strictly speaking, it refers to a whole family of viruses, to which the one that causes COVID-19 belongs. I will be using the word coronavirus for that family. The virus is officially called SARS-CoV-2, a name chosen by a committee of virologists expressly to underscore how novel it isn't, and how similar it is to the virus that caused the disease SARS in 2003. That virus was renamed SARS-CoV-1. That makes the official name confusing, so I hope the virologists won't mind if I try and call it the virus that causes COVID-19, or even the COVID-19 virus, where at all possible. Because it is, and the word doesn't immediately hit the unspecialized eye as referring to another disease. Chapter 1. Could we have stopped this whole thing at the start? Every disaster movie starts with someone ignoring a scientist. Popular poster at the April 2017 March for Science. So how did we end up with the COVID-19 pandemic? Could we have stopped it once it started? Could we have stopped it from starting at all? If your house burns down, you ask two things. First, how did a fire get started in the house to begin with? Second, and most urgently given that it did, and we saw it happen, why didn't we put it out before it spread? We'll look at the first question later in the book. Let's look at the second now. What happened to unleash a COVID-19 pandemic on the world? The first inkling I, like many others, had of the gathering storm that became COVID-19 was a post on the online forum ProMed. The machine-translated report from Financina, a Chinese online news site, read, On the evening of 30 December 2019, an urgent notice on the treatment of pneumonia of unknown cause was issued, which was widely distributed on the Internet by the red-headed document of the Medical Administration and Medical Administration of Wuhan Municipal Health Committee. It was December 31st, and in our suburban French village, just over the border from Geneva, the sun was coming up. I had family in for the holidays and had solemnly promised to stop working. But, I told myself, that didn't mean I couldn't take a peek at ProMed, just to make sure I didn't miss anything important. ProMed, the Program for Monitoring Emerging Diseases of the International Society for Infectious Diseases, a scientists' organization formerly called ProMed Mail, is the world's leading online reporting system for new or emerging infectious disease. Despite its importance, it's a non-profit, run mostly by volunteer work, on a shoestring, with grants and donations. It was set up in 1994 as infectious disease specialists shaken by the emergence of AIDS in the 1980s uneasily realized that other new diseases might be out there and that we needed an early warning system. It consists of moderated daily reports of worrying medical events from contributors everywhere. Doctors, vets, farmers, researchers, ordinary citizens, even agriculture labs. Crops get diseases too. It's all in understated sans-serif plain text. Old-fashioned Helvetica. Direct and to the point, like the scientists who mostly read and contribute to it. everything is classified by disease and place and date. The moderators, most of them veterans in their areas, tell you what they make of the reports, and I often cut straight to their comments. ProMed is one of the things humanity did right to prepare for disease emergencies like COVID-19. For disease researchers, public health people, and science reporters like me, as well as anyone fascinated by the daily reality show, ProMed is required reading. When I ducked into my office that day, hoping it was early enough that my family wouldn't notice, the giant Cenacorp's financial bulletin was reporting people with severe, undiagnosed pneumonia in the central Chinese city of Wuhan, in Hubei province. Many had connections to a seafood market. There were already 27 cases. A red-topped bulletin, rendered red-headed by the machine translation, must be an emergency alert, I guessed. The reporter from Financina had verified it by calling the official hotline of Wuhan's Municipal Health Committee the next morning. It was true. The story went out. And it was worrying enough to make someone send it to ProMed. It wasn't hard to see why. Pneumonia is not a disease caused by a specific germ, like measles or flu. It just means any infection that inflames your deep lungs, the part with the air sacs called alveoli. Those sacs are what your lungs are all about. You suck air into them, and oxygen pours across the alveoli membranes into the oxygen-starved blood on the other side. The carbon dioxide waste in that blood, meanwhile, pours into the alveoli, and you exhale it. If those delicate membranes are damaged by an infection, they can start leaking fluid, and the sacs can fill up. That stops oxygen from getting to the membranes and entering your blood. If this gets bad enough, you effectively drown in your own fluids. A respiratory infection, be it virus, bacteria, or fungi, may invade your nose, throat, or the deeper bronchial air passages and give you a cold or a bad cough. But if it gets into the alveoli, that's pneumonia, and it can kill you. The fact that this pneumonia was undiagnosed was the red flag that got ProMed's attention. Normally, white blood cells defend your alveoli from the bacteria that are always there, pulled in by the billion on every breath. Winter flu viruses knock out this key part of our immune system, and then the bacteria can grow, causing pneumonia. Therefore, most winter pneumonia is first treated with antibiotics, which kill bacteria. In Wuhan, this apparently wasn't working, nor presumably were diagnostic tests for flu or the other usual suspects. The Municipal Health Commission was holding a special meeting, said the report. But they made a point of saying they thought it wasn't the SARS virus. SARS emerged in China in 2002 and rampaged through 29 countries in 2003, causing severe pneumonia and killing 774 people. Good, I remember thinking. SARS may not get talked about much anymore outside the countries that were affected, except by us disease buffs, but it was vicious, packing a 10% death rate. It was stamped out with an enormous international effort and luck, with only the classic techniques of isolation and quarantine, mainly because it was clumsy at spreading among people. But if this new illness wasn't SARS, what was it? The market connection was worrying. A seafood market in China is also a wet market that sells live animals, and many sell exotic wild creatures. The SARS virus came from bats and is thought to have jumped to people in a wet market. Granted, there have been other reports like this on ProMed. In 2013, there was an undiagnosed viral pneumonia in health workers in Anhui province in China. In 2006, people in Hong Kong had undiagnosed pneumonia after visiting several parts of mainland China. The ProMed moderator asked for more information in both cases, but further posts never appeared, so presumably no notable disease resulted. This time, though, there was a worrying comment by Marjorie Pollock at the bottom of the post. Pollock is a doctor and epidemiologist, a 30-year veteran of the U.S. Centers for Disease Control and Prevention, CDC, and the doyen of ProMed's international team of moderators. She was involved in one of its proudest moments, alerting the world on February 10, 2003, to the mystery pneumonia in Guangdong later named SARS, nearly 2 months before China opened up about it. What she wrote that holiday morning gave me that queasiness you get when you're trying very hard to dismiss a feeling of foreboding. Besides the news report, she observed, there was a lot of online comment about this. Twitter and its Chinese counterpart, Weibo, weren't around when SARS broke out, but online chat rooms were. The type of social media activity that is now surrounding this event is very reminiscent of the original rumors that accompanied the SARS-CoV outbreak, wrote Pollock. More information on this outbreak would be greatly appreciated. And, she added hopefully, if results of testing are released. What was different from SARS, she noted, was the transparency of the Chinese authorities. In February 2003, Chinese officials discouraged press reports on the undiagnosed pneumonia and did not immediately report it to the World Health Organization, WHO. They didn't start fully reporting cases until that April, by which time SARS had spread across China and East Asia and to Canada. In the ensuing 17 years, there has been an astonishing revolution in China's politics and prosperity, so this new outbreak was occurring under very different circumstances. Chinese authorities told the WHO about it on December 31st. It later emerged that the first case occurred in November, but a respiratory infection during flu season had not seemed unusual, until hospitals started getting an unusual cluster of severe cases. The day after that, New Year's Day, the seafood market, which it turned out did sell wildlife, was closed. But by January 3rd, Pollock still had no test results. There were worrying reports that people had been arrested for discussing online whether the mystery pneumonia might be a resurgence of SARS. Hubei authorities were cited as saying this was not true, as no person-to-person transmission has been found so far. That last part became a recurring theme. On January 8th, ProMed reported that China's Center for Disease Control and Prevention, China CDC, had identified the infection as a coronavirus, the same family of viruses as SARS, but repeated that there was no person-to-person spread. I hadn't planned to go back to work yet, but I wondered if I should start looking into this story. It seemed unlikely to be significant without person-to-person spread. Animal viruses sometimes manage to jump to people and even kill them, but fail to transmit between humans, like the notorious H5N1 bird flu. Without that, this outbreak might just fade, I thought hopefully. But on ProMed, Pollock was sounding increasingly suspicious. So was Jeremy Ferrer, the head of the medical research foundation, the Wellcome Trust, and before that, head of Oxford University's medical research lab in Vietnam, where he dealt with SARS and H5N1 imported from China. On January 10th, he tweeted that If critical public health information is not being shared immediately with @WHO, something is very wrong. Something was. According to later press reports, doctors in Wuhan sent the public health lab at Fudan University in Shanghai a sample of the virus from a 41-year-old man who had been hospitalized with pneumonia on December 26th. He was a vendor at the now-closed Huanan Wholesale Seafood Market and became severely ill. The Shanghai lab had it sequenced by January 5th. Unknown to them, the China CDC already had a sequence, but they had not made it public. Later, the Shanghai lab told Hong Kong reporters that what they discovered made them immediately contact the Wuhan health authorities and warn them to take action. The virus was from the same family of bat viruses that had spawned SARS. On January 7th, China announced a coronavirus was causing the pneumonia. But when no further action was taken, the Shanghai lab posted the sequence on a public database, the first sequence published for the virus. China CDC then posted its sequence. The Shanghai lab was shut by authorities the next day. The sequences allowed other labs to design specific tests for the virus. Other countries started screening travelers from Wuhan and finding infected people. Neil Ferguson and his team at Imperial College London are among the world's most respected mathematical epidemiologists. They construct complex mathematical computer models that describe how diseases are observed to behave and then use them to predict how new ones will spread. In January, they used a large database of airline passenger statistics to calculate how many people in the catchment area around Wuhan typically travel internationally. It stood to reason that the percentage of travelers who were found to be infected should be the same as or less than the percentage of the population back home that was infected, as there was no reason to think people with the virus would be more likely to fly abroad than people without it. But in fact, the percentage of travelers who were infected was much higher. So, they inferred, there must be more infected people in the Wuhan region than was being reported. Imperial crunched the numbers. It's more complicated than simple percentages, and reported on January 17th that there were probably 1,723 cases, give or take, in Wuhan. Wuhan was officially reporting 41. There was no need to suspect underreporting. The most likely explanation was more straightforward. Official numbers counted only people who had a positive test for the virus, and in the early days of the epidemic, the only people being tested were those sick enough to go to a hospital. Other countries, however, were testing every traveler with a fever who had just been in Wuhan, even if they were only mildly ill. The missing cases might simply have been not serious enough to go to the hospital. They would not, after all, have excited suspicion. Mild cases look like flu, and it was flu season. Still, looking at Ferguson's numbers, that seemed like a lot of cases for a virus that wasn't transmitted person to person. Or, as the Imperial team dryly put it, past experience with SARS and MERS-CoV outbreaks of similar scale suggests currently self-sustaining human-to-human transmission should not be ruled out. MERS, a virus with an even higher kill rate than SARS, around 40%, jumped to humans in 2012 and is, like SARS, a close relative of COVID-19. Yet the official word was still that human-to-human transmission was limited at best. On January 10th, researchers at the University of Hong Kong found a family over the border in Shenzhen that became infected when they traveled to Wuhan. As the team published later, one family member did not go to Wuhan, but became infected after the others came home. And doctors in Wuhan had also seen the sickness spread in families. The researchers must have shared this information. On January 15th, Japan reported a case in Kanazawa who had just been in China but had not visited a wet market. The report noted that according to the WHO, there are currently cases in which the possibility of limited human-to-human transmission of this disease, including among families, cannot be ruled out. However, there is no clear evidence of sustained human-to-human transmission. Sometimes, viruses new to people can jump to one or two more people, but get no farther. MERS does that. On January 18th, the Wuhan neighborhood of Baibuting staged a potluck dinner with 40,000 people in honor of the kitchen god and in a bid for a Guinness World Record for the number of dishes served. The mayor of Wuhan told a television interviewer later, after gatherings of people in Wuhan had been banned, that the party was allowed because they still thought that human-to-human spread was limited. Then, a local case turned up in Thailand. Sticking my neck out on the chopping block, I suspect there may already be significant ongoing transmission of this novel coronavirus, Pollack wrote on ProMed. However, most cases were not being reported because they were mild and unrecognized. About that, she wrote, "I obviously hope I am correct here." By January 20th, cases were being reported across China, Japan, Thailand, and South Korea. Pollack's gloves were off. "It is becoming more difficult to conclude," she wrote testily, "that there has been limited person-to-person transmission as the case numbers are climbing." Chinese scientists were also losing patience. Also, on January 20th, Yi Guan, a virologist at the University of Hong Kong who helped uncover the SARS virus, told the Chinese magazine Caixin that the Wuhan outbreak was behaving like SARS. It was spreading between people. The same day, China's president, Xi Jinping, finally went public, telling people to take measures to stop the virus spreading during the coming Lunar New Year holiday. Zhong Nanshan, an epidemiologist called the hero of SARS for helping discover the SARS virus in 2003, and then telling the public it was out of control when Beijing said otherwise, was heading the government's investigation. After Xi spoke, Zhong told China Central Television that the virus spread from person to person. There were more surprises. The South China Morning Post in Hong Kong later reported that, according to classified documents they saw, the earliest case developed symptoms on November 17th, not December 1st, as later reported. It had taken China a month and a half to spot a problem and tell the WHO. The doctors involved knew it was contagious. Early patients were put in isolation. And Zhang Jishan, head of respiratory and critical care at Hubei Provincial Hospital, told reporters in February she knew on December 26th when 3 members of one family had pneumonia. She made staff wear N95 masks. What happened next shows how bad things already were in Wuhan by late January. To understand that, we have to look at the main ways of fighting an epidemic when you don't have drugs and vaccines. Containment and mitigation. Containment is by far the most effective way to limit an epidemic, if you get to it before there is a large number of cases. The classic method of epidemic control, used for centuries, is to isolate people with symptoms and then quarantine their contacts for the time it takes for them to incubate the infection and start showing symptoms. Maybe they won't have it. Good. But if they do, the quarantine ensures they don't pass it on. Nowadays, you can test people for the pathogen and only quarantine those who test positive if you really trust your test not to produce false negative results. In either case, the chain of transmission is broken. Do that enough, and you can snuff out a virus. That's how the world defeated SARS. However, this won't entirely work if the virus can spread before people show symptoms, as neither the person infected nor the people they contact will suspect a problem. And it is hard to do if more than a few people are sick. You have to trace and quarantine all the people each case might have infected, which can add up quickly with a virus as easily transmitted as COVID-19. You won't get everyone, so some new cases will continue to crop up, meaning more people to trace. It's hard work. As it wrestled the COVID-19 epidemic to a halt in spring 2020, China eventually used 6-person teams for each case to track contacts. The European Center for Disease Prevention and Control estimates it takes 100 person-hours to track one case's contacts. If you can break all the chains of infection from every case, the disease can be contained. But you have to start early, before there are too many cases to track. If a disease is spreading generally in the community, it becomes impossible. Not only are there probably too many cases, but people might have no idea who they caught the virus from. That person could still be out there, spreading the virus, no matter how many known contacts of that case you quarantine. At that point, the classic approach is a switch to mitigation. A lot of us know about that now because, with a few notable exceptions, most countries outside China didn't act in time to contain the virus and ended up mitigating. You ban large gatherings, close schools and workplaces, and generally reduce interaction between people to slow the spread of the disease. A set of measures known as social distancing. At the extreme, as so many of us now know, you lock down and keep people inside. You don't entirely stop the spread of the virus, but at least it doesn't happen so fast that the sick overwhelm your hospitals. That means the number of cases you get per day or per week does not rise as high or as fast, the now famous flattening the curve. And even though you are in theory only slowing the spread, you also save lives, as more people who need intensive care can get it. In the course of the COVID-19 epidemic, China discovered that outside Wuhan and Hubei province, a mix of mitigation and containment actually worked best. First, contact tracing and quarantine to break chains of infection, and then, if necessary, varying levels of mitigation to slow the spread of the virus, which, because fewer people were catching the virus from each person who had it, also made containment more feasible. But on January 22nd, Wuhan was already at the point where lockdown was deemed necessary. To get to that point, there must have been considerable person-to-person spread. But with the official story being that the virus did not spread from person to person, officials could not make any visible efforts to isolate cases and trace contacts, back when it might have been possible to contain the virus. Now it wasn't. As a result, China imposed a cordon sanitaire around Wuhan, a term from pre-vaccine days meaning health barrier. They were invented for cities with the plague, so no one would enter or escape carrying the disease. English uses the French term because in 1821, France revived the concept, by sending 30,000 troops to seal the Spanish border to keep out the yellow fever raging in Barcelona. No one could enter or leave Wuhan, a city of 11 million, without special permission, beginning 10 a.m. local time on January 23rd. That was extended to all of Hubei province a day later. Transport within the city was shut down. But there was a huge problem. Lunar New Year was only 3 days away. This is China's biggest yearly celebration, when 400 million people travel to family celebrations all over the country. The biggest human migration on Earth. Moreover, Wuhan is a hub for travel within China. Mass travel had already begun, and at news of the impending shutdown, people flooded into train stations and airports. Authorities later announced that 5 million people had left the city before the cordon sanitaire could be enforced. Chris Dye of the University of Oxford and colleagues confirmed, using geographically coded mobile phone data, that 4.3 million people left Wuhan between January 11th and the start of the travel ban on the 23rd. Many were carrying the virus. There was no way to call it back. Back in Europe, my visitors had gone home, and I was now visiting family in London, with plans to hit the city's New Year's sales. Those plans were dropped when I heard the confirmation that the virus was spreading person to person. I borrowed a desk and emailed my editor and as many scientists as I could. My first report for New Scientist, filed January 28th, started with the words, "The new coronavirus may be about to go global." That's how far things had already gone. And it wasn't speculation. Gabrielle Leung at Hong Kong University is a leading expert in public health and a veteran of SARS. He and his team had also used travel data to calculate that dozens of infected people had long since traveled from Wuhan to China's bustling metropolises: Beijing, Shanghai, Chongqing, Guangzhou, Shenzhen. On January 27th, he told a press conference that according to his mathematical models, without substantial draconian measures limiting population mobility, even more restrictive than China had already imposed, epidemics outside China were inevitable. His model forecast 200,000 cases by the following week. 3 days earlier, Chinese scientists had published clinical details of the first 41 patients in the leading medical journal, The Lancet. Chinese doctors complained that the information should have been shared with them earlier, as they started to encounter cases. But it clearly could not have been published while the official story was still that this was nothing like SARS. Clinical presentations greatly resemble SARS-CoV. The number of deaths is rising quickly, they wrote. We are concerned that the novel coronavirus could have acquired the ability for efficient human transmission. In other words, better than the clumsy SARS virus. Scientists are good at understatement, but that deserves a prize. The day after the paper appeared, there were officially 2,000 tested and confirmed cases across China, and, we can now calculate, probably at least 8,000 milder ones. The Chinese scientists were clear about what was needed to manage the epidemic: reliable, quick tests for the virus. They also noted the discovery in 2013 by the Wuhan Institute of Virology of very similar viruses in bats that were already capable of infecting human airway cells. Because of the pandemic potential of 2019 nCoV, they warned, the virus would have to be carefully watched to see how its transmission and impact changed as it adapted to humans. Everything was there: efficient spread, need for tests, pandemic potential. At that point, countries around the world should have started intensively preparing for the virus to hit. Some did. Most did not. Despite apparent openness, it seems China delayed reporting the illness, the virus, and especially the all-important person-to-person spread. Possibly, with memories of SARS still raw, authorities were afraid to frighten people with the news that it might be back. Darker stories have emerged that support this view. On March 11th, Dr. Ai Fen, head of the emergency department at Wuhan Central Hospital, told the Chinese magazine Yanwu, People, that on December 30th, 2019, the hospital lab had sent her a test result from one of the mystery pneumonia cases. It said, SARS coronavirus. A PCR diagnostic test matches genes from an infection to genetic sequences from known disease germs. It's very possible such a test would have identified the then unknown COVID-19 virus as SARS. Many of their gene sequences are similar. In fact, the official committee of virologists tasked with naming the new virus decreed on March 2nd that the two are the same species. The SARS virus they renamed SARS-CoV-1. CoV for coronavirus. The virus that causes COVID-19 officially became SARS-CoV-2, like the second installment in a movie franchise. SARS-2, this time it's everywhere. Back in December, however, Dr. Ai didn't know any of that. She told Yanwu that the diagnostic report made her break out in a cold sweat. SARS was a nightmare for China, officially infecting 5,327 people and killing 349. Many of them doctors and nurses infected while caring for patients. The hospital sent part of the sample that tested positive for SARS off to Shanghai so the virus could be properly sequenced. I took a picture of the report on her phone with SARS coronavirus circled and sent it to other doctors in Wuhan, including an ophthalmologist, Li Wenliang. He passed a warning on to colleagues about patients with pneumonia quarantined in the emergency department. The news spread fast. The hashtag #WuhanSARS started trending on Weibo, China's substitute for the banned Twitter. It was censored. The hospital told Ai that night not to spread information about the pneumonia cases so as not to cause panic and damage stability. The hospital's disciplinary committee reprimanded her. Staff were told not to exchange messages about the disease, I told Yanwu, and astonishingly, not even to wear protective masks and gowns for fear of causing alarm. After all, there is no need for such protection with a virus that is not supposed to spread between people. Zhang Jishan at Hubei Provincial Hospital bought her staff protective clothing to wear under their normal white uniforms. They didn't get official protective gear until after January 20th, when China admitted the virus was contagious. The Japanese newspaper, Mainichi, echoes Ai's story. In late January, it reported that at 1:30 a.m. on December 31st, the night of Ai's test result, 8 doctors in a group chat discussing the threat of an epidemic that result might pose were summoned by authorities and told to write self-critical essays about spreading rumors. They did. The crackdown silenced doctors. And that day, researchers at the University of Toronto have discovered terms relating to Wuhan and pneumonia started being censored on the popular messaging and live streaming platforms WeChat and YY. If I had known what was to happen, I would not have cared about the reprimand. I would have fucking talked about it to whoever, wherever I could, I told Yen Wu in a translation carried by The Guardian. As the epidemic worsened, Li Wenliang was hailed as a whistleblower. On February 7th, he died of COVID-19. I am not a whistleblower, I modestly told Yen Wu. I am the one who provided the whistle. The mayor of Wuhan ultimately had to resign and accept responsibility for missteps, although before he did, he blamed Beijing for controlling what he could say about the virus in public. Those controls don't seem entirely gone. Ai's March interview in Yanwu reportedly keeps mysteriously disappearing from Chinese websites. It has been kept alive by Western coverage and Chinese netizens. Meanwhile, the virus Ai Fen was told to shut up about has gone everywhere. On March 11th, WHO Director General Tedros Ghebreyesus declared it a pandemic. So that, as far as I can piece together at this time from a range of reports, is what happened. It is of course probable that more will come to light, and accounts could change. But now we can start to ask the crucial question. Could this all have been prevented? Could the Wuhan outbreak have been stopped from spawning a pandemic? This is one of the first big outbreaks that has been analyzed as it happened, using modern technology for rapidly sequencing viruses from different patients and working out which virus is descended from which on the basis of small shared mutations. And what stands out is that the first few sequences from patients in China, says Andrew Rombaugh of the University of Edinburgh, who specializes in the evolution of emerging RNA viruses like this, were genetically identical. The longer a virus circulates in a species, the more it acquires random small changes in the gene sequence. If this virus had jumped several times from different animals, or circulated for long in people, there would have been more genetic variation in the early infections. So, says Rombaugh, I would say that it was definitely a single jump, and it was probably not before early November, which matches the timing of the first known cases. It could have been a jump from one animal to one human, or it could have been a few animals, all the same kind with the same infection, to a few humans. We don't have details of the earliest cases, he says, so we can't tell. But this does tell us there was no hidden epidemic happening over a larger area or a longer time, or there would be more variation. That means those first cases in Wuhan were all there were. In theory, if Wuhan had enacted stringent containment the moment they spotted that cluster, apparently in late December, then actively looked for other infections and contained them while there weren't many, they might have stopped the infection from spreading far. It would have been even better if they had spotted it earlier. To answer the question of whether they could have stopped the virus from spreading entirely, we need to know how much action would have been needed and whether authorities would have agreed to the disruption it would have caused, knowing what they knew at the time. Andy Tatum and Sheng-Ji Lai and a team at Southampton University in England have measured how authorities might have done it. Cases in China increased exponentially, as diseases do when there is nothing to stop them, until the cordon sanitaire was thrown around Wuhan. After that, and as similar travel bans and social distancing orders were imposed across China, case numbers stopped rising. The impact was stunning. China's epidemic actually peaked in mid-February, a turning point predicted by epidemiologists outside China on the basis of changes in reported case numbers as controls were imposed and confirmed by a WHO delegation to China in late February. By late March, China was reporting no new cases. The problem was now everywhere else. In a dizzying analysis using a mathematical epidemic model and the 7 billion anonymous location records per day logged by China's Baidu cell phone network, Tatum's team quantified how people moved between China's 340 major cities as travel restrictions went into effect after January 23rd. They measured how that travel related to the data on the spread of the virus. Given that, they then worked out how the virus would have spread if travel was the same as Baidu had logged during the same weeks in previous normal years, with no travel bans. They calculated that with unimpeded travel, provinces outside Hubei would have had 125 times more cases by the end of February. China's vigorous, multifaceted response is likely to have prevented a far worse situation, which would have accelerated spread globally, they wrote. There would have been much more of the virus in the world, what epidemiologists call amplification, if China had not wrestled its epidemic to a halt. That would have made matters worse for everyone. But if Wuhan had imposed travel bans before those 5 million people left for the Lunar New Year holiday, could it have stopped the virus entirely? Tatum's team found that if China had imposed the same control measures a week before January 23rd, it would have prevented 67% of its epidemic. And implementing the control measures from early January, when Wuhan knew enough about the infection to shut the seafood market, would have cut China's epidemic to only 5% as many infections. Such a small epidemic might well have been contained, especially if other countries were also alerted to watch for, test, and contain any infected people who crossed their borders. Technically, we certainly could have attacked it effectively at that point and maybe contained it, says Tatum. It's easy to say this with hindsight, of course. There was so little we knew about the virus at that point. That would have made it hard to act rapidly. Rambo thinks more could have been done. The authorities in Wuhan spotted the outbreak as an unusual cluster of pneumonia, but then spent weeks saying there was no evidence of human-to-human transmission, when in fact it was doing exactly that. They knew enough to act, and they missed their window. All that would have been needed, he says, would have been surveillance to spot the outbreak early, then intensive containment and contact tracing to break all the chains of transmission before there were many cases. In fact, those were tools China already had. In 2003, the SARS coronavirus initially spread out of control in China and eventually in countries around the world, because doctors' initial warnings about the outbreak were stifled. At first, simply by local bureaucratic inertia. To stop that from ever happening again, in 2004, China installed a contagious disease national direct reporting system in every hospital. Doctors were required to enter the diagnosis into the system whenever they encountered certain key infectious diseases, including pneumonia of unknown origin. The New York Times reported on March 29th. A suspicious cluster would show up on a screen at the China CDC in Beijing without anyone having to get past any reluctant bureaucrats. If something worrying appeared, central officials could launch intensive case-finding and containment efforts. In an online drill, in July 2019, 8,200 health officials tracked and contained a simulated infection brought in by a traveler who had been registered on the system. There was a compelling reason for doing this, besides avoiding a rerun of SARS. Several strains of bird flu that can infect and kill people have emerged in China over the past 25 years. We'll be looking at those later. The one saving grace of these bird flu viruses so far is that they cannot transmit between people, although research has shown they can evolve that ability. If one became transmissible, it might be catastrophic. A cluster of cases suggesting the emergence of a transmissible strain would have to be contained with extreme urgency. Reflecting that, doctors were instructed to enter any case of bird flu they encountered in the National Direct Reporting System within 2 hours of diagnosis. The frequency with which individual bird flu cases have been diagnosed across China over the past decade, to judge from ProMed, suggests the system has been working. Luckily, no worrying cluster has yet emerged. Perhaps when tests showed that the unusual pneumonia cases in Wuhan in November and December 2019 were not a new kind of flu, health officials relaxed. According to leaked internal reports, in December 2019, doctors were told not to report such cases to the automated alert system, only to local health officials, who were reluctant to pass on bad news. They were also reluctant later as the local party congress was held in Wuhan that January. Case numbers did not rise while it was in session. It was as if someone took the batteries out of the smoke alarm that sounded too many false alarms, so it missed a real fire. Word seems to have reached Beijing of the mystery pneumonia only on December 30th, after doctors leaked reports online, the same day Dr. I saw the diagnosis of SARS. That could be why China alerted the WHO on December 31st. After that, according to reports in the Chinese press cited by the New York Times, Wuhan officials downplayed the seriousness of the disease. They set a case definition that allowed doctors to report cases of pneumonia to the automated system only if the patient had had some connection to the now-closed wet market or to a known patient. A strange case definition for a virus that isn't supposed to spread person to person. In Wuhan, the virus was spreading freely, so increasingly, people who got it did not have the requisite connections to the market or known cases. Thus, Wuhan's official case numbers stopped climbing. It's worth pointing out that this happened elsewhere too. Later, some U.S. states and European countries would test people with COVID-19 symptoms only if they had contact with China or a known case, even though the virus was already circulating elsewhere, including locally. As a result, they turned out later to have far more cases than they had realized. Finally, Zhong Nanshan investigated and reported the real situation to authorities on January 19th. The next day, after claiming no new cases in weeks, Wuhan suddenly reported 157 and was facing a cordon sanitaire. If Wuhan had used its automated system and alerted China CDC, could it have done enough early enough to have contained the disease? The system was designed to trigger a full-blown containment response. The cases in December should have been enough to do that. Would local officials have followed through with something that was not a drill? This raises a perennial dilemma of public health, as I heard from Sylvie Briand, head of infectious hazard management at the WHO, when we were discussing problems like this some months before she was plunged into the COVID-19 crisis. Containing a new infectious disease before it has spread far nearly always means reacting before it seems like a big deal, she says. There may be only a few clinical cases, but you know several times that number are already infected and incubating the disease, especially if it is very contagious and spreads early in the course of infection. COVID-19 ticks both boxes. You have to contain such things early before they escalate. This can be difficult, as at that point officials often see the threat as too trivial for such disruption, scoffing that more people die falling downstairs, forgetting that unlike infections, stair accidents don't then multiply exponentially. Yet, people made such objections in the early days of COVID-19, and if you do manage to contain the disease, then nothing happens. Officials may wonder why they spent all that money fighting a threat that disappeared, even though that was the point. I still get letters when I write about some new disease, saying something like, "Oh, well, SARS was supposed to kill us all and it never did, so why should we believe this?" Well, because with SARS, we eventually listened to the warnings and managed to contain it. We were also lucky. Wait until the threat is obvious, though, and you are usually too late. First, they accuse you of overreacting, said Briand, echoing many frustrated public health experts I have heard over the years. Then the epidemic suddenly explodes, and they say you didn't act fast enough. This is especially the case when you cannot contain a virus just by quietly isolating the few people who have it and the few dozen people they contacted closely enough to pass it on. Officials might be okay with something that minor, but it might not be so easy. Using a massive set of data on real social interactions in the UK, Matt Keeling at the University of Warwick and colleagues found that using the official UK definition of contact, being within 2 meters of someone for at least 15 minutes, you have to trace and quarantine 36 people per case of COVID-19 just to catch and isolate 4 of every 5 people that case infected. That's a lot. And contact tracing might not be enough. As we have seen, the Chinese subsequently discovered that the key to stopping COVID-19 is using social distancing as well as containment. The variable that matters, and about the only piece of epidemiology jargon you really need to know to get all this, is R0, the basic reproductive number. This is the number of people each infected person passes the virus on to, on average, at the start, when everyone is susceptible. And we all were susceptible to start with, as this was a virus no one had encountered before. That value for COVID-19 was originally calculated at between 2 and 3, making it more communicable than most seasonal flu, although later calculations found it might sometimes be higher for occasional people who seem to spread it massively, called super spreaders. Rosalind Ego at the London School of Hygiene and Tropical Medicine and her team calculate that for a virus with a basic R0 like that, contact tracing and isolation alone only work if there is little or no transmission before the virus causes symptoms. Otherwise, an infected person will have too many untraceable contacts because the contact occurred before they knew they were sick. And even if you find those contacts, they will have had more time for their own infections to incubate and may already have spread it before you can quarantine them. COVID-19 spreads as much as a day or two before you get sick. The many cases with very mild symptoms, or none at all, also pose problems for containment. It's as if a virus with a high enough R0 is just too slippery to pin down easily. So the answer is to reduce the number of people infected by each person with the virus. That's what mitigation does. With less person-to-person contact, fewer people catch the virus from any given case. So you have to quarantine fewer people to break transmission. If a virus has an R0 around 2.5, Ego and team figure you need to reduce contacts by around 60% to get the R value down to 1, the level at which the epidemic stops growing. So even if Wuhan had thrown itself into containment at the start, it may not have stopped the epidemic without social distancing as well. Epidemiologists would very possibly have known too little about the virus at that point to make a case for such drastic measures. Even much later, with far less excuse, some Western countries were slow to admit the need for such disruption. Social distancing is the magic ingredient in control, says epidemiologist David Fissman at the University of Toronto, another SARS veteran. I have no reason to think they could reasonably have known that massive social distancing was needed in response to what at first appeared to be just a disease cluster in Wuhan. That's the trouble with a new disease, he says. We all learn a lot week by week and are all making mistakes. That's the nature of the beast, I think. Tatum agrees. You only have to look back at ProMed to see lots of unexplained small outbreaks that lead nowhere, like those earlier reports of undiagnosed pneumonia from China. We can't throw a city into lockdown for every one of those. How do we distinguish things like that from the real threats, so that we risk mass disruption only, or at least mostly, for things that aren't going to fizzle out? We do need to get better at early detection and identification of those outliers that have the potential to cause major outbreaks, says Tatum. But of course we can't even try to decide which outbreaks really have legs if we don't know the outbreaks are happening in the first place. That's where China's smoke alarm should have worked. Zheng Guang, the chief epidemiologist at China CDC, is quoted as telling the Communist Party paper Global Times that local governments only partially based their decisions on what the scientists told them, instead favoring social stability, the economy, and whether people could happily enjoy Lunar New Year. You can't cause much disruption if that's your aim. A preference for secrecy and stability won out over the scientists' epidemic models at the typical crisis point in public health. When you need strong action, even though it doesn't look to observers or politicians facing the year's biggest holiday, like much is wrong. So, the big question. Could China have stopped the epidemic from becoming the pandemic? The epidemiology suggests that they might well have been able to slow it down, although it might have been hard to stop completely, even if the automated system had been allowed to do its job in December. Just the effort, though, would have had an incalculable impact. It would have meant telling the world that a dangerous, contagious pneumonia had emerged in Wuhan. If, over at ProMed, Marjorie Pollack had been able to post that in December or even January 1st, and the WHO had announced it, the world's virologists and epidemiologists would have run for their labs and models and started furiously posting results, as indeed they did a few weeks later once the news was out. The world's developers of vaccines and drugs and diagnostic tests would have gotten to work. Other countries could have started testing people who had traveled to Wuhan earlier. As more cases appeared, China might have been able to impose the social distancing that would have made the difference, perhaps before 5 million people carried the virus out of Wuhan. Those things happened anyway, but an earlier warning would have given everyone a few weeks' head start. We've all seen now what exponential looks like. A short time at the right time matters. There is no question that when China finally did act, it was awesomely effective, if socially and economically painful. Dai's team found that normally 6.7 million people travel out of Wuhan in the month after New Year's. This year, there was almost no movement. That bought other cities and the world time to prepare. Eventually, 136 Chinese cities also shut down their public transport and 220 banned mass gatherings. Dai's team found that cities that did those things sooner rather than later had a third fewer cases during the first week of their outbreak. Curves were flattened, and the number of cases each person infected was slashed. Their models showed that the Wuhan travel ban alone, or the shutdowns in other cities alone, would not have reversed the climbing epidemic curve. But both together did, and cut the cases China would otherwise have had by 96%. Wuhan required people to report their temperature daily, and in some cities that were not locked down, stores took people's temperatures before allowing them in. Anyone with a fever could go to a fever clinic for testing. People with cases too mild for hospitalization were isolated in repurposed stadiums and conference centers. Contacts of infected people were traced and quarantined. An international team, led by the WHO, went to study China's response to the epidemic in late February. They reported that China had successfully managed to bend a steadily rising epidemic curve sharply downward. It stopped the virus spreading in the community in every province outside Hubei. Most transmission was within families. It was, by any standards, an amazing achievement. Bruce Aylward, the Canadian epidemiologist who led the WHO team, was jet-lagged enough to betray more than the usual slight hint of his Newfoundland accent when he briefed the press the day he flew back from Beijing. But he said he was convinced the decline in case numbers was real. Doctors had spoken of scheduling ordinary patients again. Lines outside fever clinics had disappeared. A big trial testing an existing antiviral drug against COVID-19 was having trouble finding participants. China's initial delay may have let the virus get away, but its subsequent massive crackdown bought the world time, said Aylward. If the spread of COVID-19 out of China was terrifyingly fast, don't even try to imagine what it would have been without the anchors China slammed on its own epidemic. We now know what works against this virus. We know what to do, Aylward said. He dismissed claims that only China could have imposed the containment and social distancing needed. The rest of the world could follow their model, adapting measures to their own conditions. He just wasn't sure the rest of the world understands the need for speed. Most of it did not. The virus had already gotten a head start in Italy, the UK, the US, and elsewhere by the time a serious response was launched. In late March, no Chinese province outside Hubei had officially reported more than 1,500 confirmed cases, but 15 U.S. states had. And most Chinese provinces have more people. Some places, however, contained the virus without the disruptive lockdowns needed in China and the West. Hong Kong, South Korea, Singapore, and Taiwan probably gave the world its best model for how to react, by imposing containment early enough and backing it with widespread testing for the virus. Their success suggests what might have happened in China if it had let its contagious disease national reporting system trigger a massive containment effort in response to the first case cluster. That second wave of countries also leveled with people. In an astonishing public statement, Prime Minister Lee Hsien Loong told Singaporeans on Facebook as early as February 8th that, despite a strong containment effort, the virus would probably spread in the community, and outlined the self-isolation measures that would be needed, so we will be mentally prepared. Fear can make us do things that make matters worse, like hoarding face masks or food, or blaming particular groups for the outbreak, he said. On the other hand, he described students who, as Singapore imposed quarantines on exposed people, were already delivering food to shut-ins, and business federations, unions, and public transport going the extra mile to keep things running. This is who we are, he declared. At a time when some countries seemed in denial about the virus, it was a moving performance. Public trust, say veterans at the WHO, is essential for responding to a crisis. These countries also had experience with a similar disease. In 2015, South Korea had an outbreak of MERS, which they got under control using hospital infection control and quarantine. And Hong Kong, South Korea, Singapore, and Taiwan were all hit hard by SARS. They knew the need for speed. Hong Kong traced and quarantined contacts, closed schools, canceled big events, quarantined arrivals from affected countries, and encouraged working from home. At the end of March, it had only 715 confirmed cases, 94 asymptomatic, and 4 deaths. The measures actually cut the transmission of flu at the same time by nearly half. As in other epidemics, ordinary people's behavior, masks, and social distancing made the difference. At university lectures in Singapore in March, a maximum of 50 students were allowed. They sat at 2-meter distances, and a photo was taken of who sat where in case contacts needed to be traced later. Public spaces were not closed, but anyone entering one had their temperature taken, increasing public confidence as much as catching cases. South Korea had companies making COVID-19 tests by early February. National labs double-checked the test results as people were tested, effectively doing the usual validation trials of a new test on the hoof to save time. The U.S. Food and Drug Administration insisted that trials be done on U.S.-made tests before they were used on the public, adding to an already disastrous delay in testing. On top of that, South Korea had invented drive-through testing by late March. Positives were isolated and contacts quarantined. By April, case numbers were falling, without severe social distancing. The story was similar in Singapore and Taiwan. The difference was the early start that China had missed. Digital privacy experts have valid concerns about the expanded electronic surveillance involved, but the virus was contained. You didn't need a history of tangling with coronaviruses to do the right thing, though. The small Italian town of Vo in Lombardy kept the virus under control by testing everyone and then imposing isolation and quarantine as needed. This should have been possible in far more countries in that first onslaught of contagion, yet many utterly failed. If nothing else, these successful responses proved that containment, started early enough, worked on COVID-19. They confirmed that earlier action in China might have limited the epidemic. But mistakes were far from unique to China. Wuhan had its Guinness record potluck. But on March 7th, as the pandemic took hold in France, and we all knew the virus was contagious? More than 35,000 people dressed as Smurfs gathered in Lauderneau, France. The next day, France banned gatherings over 1,000 people. In late March, 70 University of Texas students were among hundreds who crowded onto beaches for the traditional spring break, despite warnings. 44 of the 70 later tested positive for COVID-19 and undoubtedly gave it to others. All these reactions seem to be simple. Psychological denial. The refusal of people who have rarely been at much risk from infectious disease to believe they really needed to take a so far largely invisible threat seriously. 5 million people left Wuhan before the lockdown, but even that painful lesson was not learned in time to avoid it elsewhere. More than 6 weeks later, Italian authorities locked down northern provinces that were the initial hotspots for the virus. The news leaked the evening before, and people fled, carrying the virus all over Italy. The whole country was shut down the next day. In many countries, social distancing was partial or delayed, to the point where curves were barely flattened. Testing was delayed or restricted, endangering healthcare workers and patients and preventing containment. Even as the WHO stressed that containment worked with this virus, some countries abandoned it almost immediately, including Switzerland, where the WHO is located. And ideology trumped public health in many places. A U.S. administration focused on threats from foreigners rushed to close borders after the virus had already arrived in the U.S., and despite science and experience showing this does little to stop viruses. Those things are still playing out as I write, so this will not be an analysis of what countries did beyond the very early days to respond to COVID-19. Those analyses will be needed. For now, we can say that few covered themselves in glory, and we don't yet know the long or even medium-term outcome even for those countries that did well at delaying the first wave of the disease, as the virus still circulates and people remain susceptible. The accusations and political fallout will rage for a generation to come. For now, we can ask whether more openness and earlier containment in China might have prevented the pandemic. This is not to point fingers or throw stones. Most of us in that respect live in glass houses. But so that the next time this happens, wherever it happens, we might do better. The answer seems to be that stopping COVID-19 entirely might have taken faster action than any government could have managed. But earlier action was possible, and that might have slowed the epidemic enough to make COVID-19 much less damaging and perhaps, just perhaps, kept it from reaching pandemic proportions. According to the Chinese Communist Party's official newspaper, China's Supreme Court admitted as much on January 29th, when they ruled that authorities in Wuhan were wrong to censure the 8 doctors for their online chat about a SARS-like virus back in December. The information would have pushed the public to take preventive measures more promptly, which could have been a fortunate thing given the current efforts needed to contain the virus. Xi's government has even turned Li Wenliang into a posthumous hero. The first official case in Italy was detected on February 20th. Italian public health officials did the right things, isolating, contact tracing, locking down towns with the most cases. But it was too late. The virus was already too widespread, and hospitals were eventually overwhelmed. In fact, Italian epidemiologists later discovered that the first traceable case in the country fell ill on the 1st of January, At the time, no one suspected a thing. If every country had known what China knew by early January, if it had sounded the alarm sooner, and it told the WHO we had a problem, what might we all have done to stop the virus? We will be looking at ways all of us might try to do better next time. Through pandemic planning, through global viral surveillance and response when we find something worrying, through a binding international agreement to monitor and control pathogens, this time with teeth. Through scaring the daylights out of ourselves by looking at what a worse pandemic might do. First, let me explain why I'm so sure this will happen again. Let's look at where these viruses come from. Chapter 2. What are these emerging diseases, and why are they emerging? A new disease every day, and the old ones are coming back. Loudon Wainwright III, Hard Day on the Planet. Ever since the HIV pandemic, people from health experts to screenwriters have been predicting what the next one would be. Various kinds of flu, a super transmissible Ebola with wings, a souped-up version of the common cold, a bioweapon, or a therapeutic virus gone wrong. There were scares and near misses with bird flu, mad cow disease, Ebola, SARS, and MERS. Then the swine flu pandemic in 2009 that turned out relatively mild, although it still killed. Now there's COVID-19. Why is this happening, and will it continue? And more to the point, what will hit us next? There are more viruses where COVID-19 came from. We should start by saying what we mean by pandemic and disease events generally. An outbreak is one or a few cases of an infectious disease that is unusual, so it gets noticed. An epidemic is a larger version of that. More related cases of a disease than usual spreading in a group of people. An epidemic can be a regular event, for example, the spread of flu through a city in the winter. Endemic means a disease that rumbles on all the time, like tuberculosis or gonorrhea. A pandemic is when an epidemic goes global. Some health authorities impose other criteria, like that it has to be severe or uncontrollable or new, but those are not consistent or universal. In fact, there aren't fixed criteria for when an epidemic is big enough to count as a pandemic, except for flu, and even those have been changed lately. We are sure there will be more pandemics, and probably sooner rather than later as our population climbs and we increasingly crowd into cities without routine surveillance of the world's scarier viruses or agreed global means for working together to contain them. And as intensive global trade and travel continue to transport the illnesses that emerge to people everywhere. The chaotic global response to COVID-19, just the fact that it got away in the first place, should make that situation obvious. We can't precisely predict which disease will be next, or when, although anyone who studies infectious diseases could, and in fact did, tell you years ago coronaviruses were prime suspects. There's even an official short list of the diseases we're worried about, but aren't ready for. To understand this predicament, though, we need to look back at some recent history. In 1972, one of the world's then leading experts on human infections, Macfarlane Burnet, co-wrote the fourth edition of a medical textbook called Natural History of Infectious Disease. And in it, he wrote something quite astonishing. The most likely forecast about the future of infectious diseases, he opined, is that it will be very dull. He must have enjoyed the shock value of that statement. Scientists always talk up their subject area, especially when trying to entice students into it. Burnet had just won a Nobel Prize for helping work out how our immune systems attack germs, but not us. He knew the value of studying infectious disease. But the point of studying infectious disease is so you can beat it. And he figured it had been beaten. The comment was an in-joke, a somewhat smug whoop of victory, and also advice to a young doctor. Specialize in something else. We've got this. After all, in 1972, smallpox was all but eradicated. Most childhood diseases, even the super-infectious measles and the dreaded polio, could be entirely prevented with vaccines and had been in richer countries. Formerly deadly bacterial foes, diphtheria, anthrax, TB, typhus, syphilis, gonorrhea, could be killed with antibiotics. Cheap, easily obtainable drugs stopped you from getting malaria. Infections still plagued poor countries, but surely development would fix that. In the 1970s, the Yale and Harvard medical schools downsized their infectious disease departments. Burnett acknowledged, of course, because he knew colleagues would cavil if he didn't, that there was always a risk of some wholly unexpected emergence of a new and dangerous infectious disease. But this struck him as unlikely. Nothing of the sort, he assured the reader, has marked the last 50 years. How about the subsequent nearly 50 years, then? Let's think. The deadly bacteria of Legionnaire's disease appeared 4 years after he wrote that. The U.S. recognized the AIDS pandemic 4 years after that. Then Lyme disease, SARS, MERS, Ebola, Marburg, bird flu, swine flu, another pandemic, dengue, chikungunya, Zika, sin nombre hantavirus, Nipah, Hendra, lethal versions of normally harmless E. coli bacteria, gonorrhea that resists all antibiotics, ordinary urinary tract infections that resist all antibiotics, extensively drug-resistant TB, West Nile, mad cow disease in cows and people. Oh yes, and a COVID-19 pandemic. I wonder what Burnett would have made of the year 2020. COVID is a lot of things, but it isn't dull. What an eminent scientist thought in 1972 might seem like ancient history, but it matters to the COVID-19 saga. After infectious disease faded as a leading cause of death and people everywhere started living to previously rare old age, the big killers, in rich and increasingly in poor countries, became conditions linked not to pathogens, but to genes, environment, and lifestyle. Cancer, heart attacks, strokes, Alzheimer's, traffic accidents, the complications of smoking and obesity. There is very recent evidence that bacteria may be involved in big killers like Alzheimer's and heart attacks, but that's a different matter. Tackling those challenges didn't require the community-level public health that was historically designed for communicable disease, which involved quarantines and vaccination drives, not admonitions to eat more vegetables. The new killers certainly didn't require investment in new vaccines or antimicrobial drugs, pathogen surveillance, or local agencies that could monitor and contain epidemics. Nearly all of those capabilities atrophied, even in the richest countries. Despite increasing alarm among researchers and global health experts about emerging infectious disease for almost 3 decades now, the mainstream attitude, especially in rich countries, has been complacency. Perhaps because, as always in public health, problems tend to be invisible until it's too late. The old infections seem to be gone, or problems only for the poor or marginalized. New infections seemed merely theoretical. In response, medical industry shifted. Vaccines used to be made by government agencies as a public good, not for profit. The vaccine that eradicated smallpox, for example, was largely made by the Soviet Union and New York State. By the 1980s, vaccines were privatized, and in many cases, profits have been too low to encourage new investment. Most flu vaccines are still made using chicken eggs, a slow and sometimes problematic process from the 1940s. Investment in public health decreased in many countries. In the U.S., there was a brief infusion of cash into preparedness for perceived bioterror threats after the anthrax mailings of 2001. But funding for the Public Health Emergency Preparedness Agreement among state and federal agencies fell from nearly $1 billion in 2002 to $675 million in 2019. The minimal importance accorded public health was reflected in widespread cuts after the financial crisis of 2008. There has been a surge in hepatitis, Legionnaires, and diseases transmitted by sex or drinking water across the U.S., which public health experts attribute to health departments losing a fifth of their employees during that time. This is now hampering efforts to contain COVID-19. In Europe, too, investment in public health plummeted after 2008. In 2019, a British think tank calculated that public health spending in England had fallen by £870 million just since 2014, and that this may have caused 130,000 deaths, and a rise in chronic conditions like diabetes that incidentally also make you more likely to die from COVID-19. The same thing happened with infectious disease monitoring and research in developing countries, where a network of labs largely left over from the colonial era disappeared, seen by former colonial powers as expensive anachronisms in the 1970s. Among those decommissioned was the British lab in Uganda that identified Zika and 30 other new viruses between 1930 and 1970. What if that lab had survived, increasingly with Ugandan scientists in charge to recognize HIV in the 1970s? As we all know now, early action can make huge differences in a pandemic. To appreciate the short-sightedness of this dismissal of infectious disease, let's look at some actual ancient history. In the 10 millennia since we invented agriculture, infection has been by far the biggest killer of humanity, despite impressive competition from war and famine. According to virologist Ab Osterhaus of the Research Center for Emerging Infections and Zoonoses in Hanover, in 1900, infectious disease caused fully half of all human deaths. Malaria alone is thought to have killed half of all humans who ever lived. Those statistics don't contradict the deaths involved different human populations over different times. In the 1800s, tuberculosis, known as TB, infected 70 to 90% of Europe's city dwellers and caused more than a third of all deaths, spawning a score of consumptive characters in Victorian novels. Yellow fever killed most of Napoleon's army in the Caribbean, so he unloaded the Louisiana Purchase on the U.S. and abandoned the unhealthy New World. Many, if not most, children until very recently died before the age of 5, nearly always of infection. In a few places, they still do. Both illnesses and deaths by infectious disease in the industrialized world plummeted after 1950 and declined in many developing countries too. By 2004, infectious disease caused less than a quarter of all deaths worldwide, mostly in poor tropical countries. In rich temperate countries, it was barely a few percent. Many things contributed to this astounding decline. Besides drugs and vaccines, there were sanitation and hygiene. There was also vastly better nutrition, as chemical fertilizers and crop breeding boosted agricultural yields and refrigeration and railways distributed fresh food, with the added bonus of banishing disease-ridden livestock like milk cows with TB from cities. That's the big picture. There are countless little ones. I'm just old enough to have had measles at 3, and I'm told I almost died of the common bacterial complications, saved by a large, and I clearly recall painful, midnight injection of what my mother said was penicillin. A few years later, my little brother got the new measles vaccine. Mothers who listen to the lies of the anti-vax campaigners today have never seen how measles, typhoid, and polio can carry off children. Afghan mothers have. In 2006, as aid agencies tried to remedy years of atrocious health care under the Taliban-led government, mothers and children waited for days outside clinics offering childhood vaccinations. They had seen the alternative. So in the 1970s, infectious disease did seem to be on the run. When I was taking medical classes as a research student in the 1970s, my medical colleagues were given Burnett's message not to waste their time on germs. Curing cancer was the future. U.S. President Richard Nixon declared war on it in 1971. When Peter Piot, now head of the London School of Hygiene and Tropical Medicine, was a student in Belgium, his professors advised him not to specialize in infectious disease. Luckily, he ignored them, helped discover the Ebola virus in the Congo, and later led the global fight against HIV. Because germs are not gone. As Jeff Goldblum stammers in Jurassic Park, life finds a way. Where there are billions of humans to parasitize, some parasite will find us. Technically, pathogens are parasites, living off the work our bodies do to marshal the energy and tissues that maintain us. And the most insidious are the tiny viruses, most little more than a protein shell, maybe with a film of fat, enclosing a clutch of genes, made of either DNA, like our genes, or RNA, the mirror image of DNA we use to translate genes into protein. Viruses carry no energy-capturing or processing equipment of their own, but use their few proteins to invade and hijack our cells, so they can use them to replicate and spread. During the 20th century, we defeated most of the viruses we knew about, mostly with vaccines. However, we didn't realize there were a lot of viruses we didn't know about, which could jump to us from other animal hosts and cause havoc. The buzzword here is spillover. What Burnett didn't realize about the wholly unexpected emergence of a new and dangerous infectious disease was that the past 50 years, during which he thought no new diseases had appeared, were no guide to the next 50. The first big shock was AIDS. Recognized in the U.S. when gay men started developing rare cancers and pneumonia because their immune systems were suppressed. In 1983, this was traced to the human immunodeficiency virus, HIV, which invades white blood cells of the immune system. By 1984, HIV was found to be widespread in heterosexual people as well in Central and Eastern Africa. For a virus that works slowly and is relatively hard to catch, as we all know, it requires the mingling of body fluids. HIV went pandemic shockingly fast. Some 40 million people are now living with it worldwide, and it has killed 32 million since it was recognized. HIV shows better than anything else why Burnett's victory whoop was premature. HIV is a chimpanzee virus that jumped to people around 1920 in southeastern Cameroon, probably when people ate chimp meat or got chimp blood in a cut. Researchers believe this sort of viral transfer happens frequently in people who interact closely with animals. Most such viruses are too ill-adapted to people to settle in and cause an infection, and our immune systems clear them out quickly. A few would have successfully infected us, but when humans were nearly all subsistence farmers, living few and far between in smallish villages and rarely traveled, those viruses would have killed a few people, immunized any survivors, run out of victims, and died out in people. HIV had probably been jumping into the occasional human and not getting much farther ever since its predecessors jumped from monkeys into chimps long ago. But around 1920, the group M strain of the virus hit the big time when someone carrying it took a boat downstream from Cameroon to the regional boomtown of Leopoldville in the Belgian Congo, now Kinshasa, capital of the Democratic Republic of the Congo. How do we know all this? In 2014, virologists led by Oliver Pybus at Oxford in Britain and Philip Lemay at Leuven in Belgium studied some 800 HIV viruses from blood samples in old Congo medical records. The oldest was from Leopoldville in 1959. Their genetic sequences differed slightly, showing they had already been circulating and acquiring small mutations. Those mutations allowed the team to work out which virus was descended from which and how much time that took, and then construct a family tree. They were all descended from a common ancestor that infected someone around 1920. Today, Kinshasa is the second-largest French-speaking city in the world after Paris, and already in 1920, Leopoldville was no village. It was the capital of the brutal Belgian colonization of Central Africa, with 15,000 inhabitants. With men pouring in from all over the region to find jobs, the sex trade was brisk. It was also brisk along the rail line to the copper, cobalt, and uranium mines in the southern Katanga region. Tens of thousands of men migrated from around Kinshasa to work in Katanga, and the sex trade followed. The team found the most genetic diversity in the HIV samples from Katanga and Kinshasa, meaning the most infections were there. There was another surge in virus diversity after Congo gained its independence in 1960. Initially, it was largely due to the reuse of needles, a good way to spread HIV. But then wars and upheaval after independence led to a steep increase in poverty. Jacques Pepin of the University of Sherbrooke in Quebec has calculated that the number of regular customers per female sex worker in Kinshasa shot up from a few long-term regulars to up to 1,000 different men a year, leading to a huge surge in infection. Haitians and other foreigners working in Congo left, some with HIV. So Group M HIV went global. It was simply in the right place at the right time, right, at least, for the virus. AIDS raised some unsettling realizations, and in 1992, the U.S. Institute of Medicine, IOM, issued a widely read report on them. Human numbers were at an all-time high, as was global trade and travel. The word globalization had just become common. International disease surveillance was diminishing, just as infectious diseases could travel anywhere more easily than ever. Profit and liability concerns had cut incentives for companies to make drugs and vaccines for poor countries, the IOM wrote. This all added up to a danger of emerging infectious diseases and the potential for devastating epidemics, they concluded, like the one that had just emerged. Prejudice against the gay men who made up most of the early cases certainly slowed the response to AIDS unforgivably. But even if that had not been the case, it would have still been true that a previously unknown, horrendous virus suddenly arrived and spread and took the medical world completely by surprise. How many more of those were out there? Yet, the scientific and medical communities, the public, and politicians all seemed complacent, not just about infectious disease in the U.S., but globally. Complacency, the report warned, can also constitute a major threat to health. Just because we have suppressed some infectious disease, the IOM wrote, people seem to think we can readily suppress any of them. But old diseases can reemerge, and new ones can emerge. The good news was that we could do something about this. Anticipation and prevention of infectious diseases are possible, necessary, and ultimately cost-effective. How right they were. The cost of this COVID-19 pandemic runs into trillions of whatever currency you may name, and indeed beyond what can be accounted in money. In 2016, the U.S. National Academy of Medicine, in a report trenchantly entitled The Neglected Dimension of Global Security, a framework to counter infectious disease crises, calculated that dividing the expected cost of future pandemics up into cost per year amounted to $60 billion a year, a figure we might now regard as an underestimate. They figured you could prevent them for $4.5 billion a year. Back in 1992, the writers of the Emerging Diseases Report realized that, while all diseases are unique, some features of the AIDS story are typical. It is human ecology, more than anything else, that drives our illnesses. And economic globalization, changes in food production, and population growth were all profoundly changing our ecology. The other important realization was that our infectious diseases mostly start in animals. The rinderpest virus, a major disease of cattle that was eradicated after a long campaign in 2011, evolved in us into the measles virus in the 11th or 12th century. Flu comes from ducks, smallpox from rodents, malaria from birds, mumps, we think, from pigs. It's no accident those animals are mostly livestock or farm pests. We started living in large numbers and cheek by jowl with animals when we started depending on agriculture around 10,000 BCE. With crops supplying rich, reliable food, our numbers exploded, and most of us settled near the fields, rather than continuing to wander as hunter-gatherers. Viruses need hosts. To maintain itself in a human population, a virus needs a constant supply of fresh, non-immune humans, so it can move to a new victim before its current host either dies or develops immune reactions that finish off the virus. That requires a nearby, constantly renewed human population. Measles needs several 100,000 people, the size of some medieval communities, to persist. When we started living in groups that big, pathogens that had been exploiting herds of livestock and other hangers-on began exploiting our numbers. Now we are unprecedentedly numerous, and we are once again encountering a new source of viruses, the wild. HIV was a good example, but there are many others, not least COVID-19. Peter Daszak heads the EcoHealth Alliance, a nonprofit that conducts research aiming both to prevent pandemics and promote wildlife conservation. An Englishman in New York, he became captivated by wildlife diseases in 1995 after discovering a previously unknown pathogen causing diarrhea in a zoo's collection of giant hissing cockroaches. A natural showman, he once carried a pocketful of them into a TED Talk. Until then, wildlife biologists hadn't been much interested in disease. it wasn't considered important to species survival. They reasoned that as a disease kills a species off, new victims become scarier, so the disease fails to find new hosts and dies out long before the species does. After the pesticide DDT decimated birds worldwide, chemical pollutants got more attention. Then, in 1997, a British lab found that a parasite can in fact drive a species to extinction on two conditions. It parasitizes more than one species, and one of them tolerates the parasite and keeps it going, even if the other host species disappears. North American gray squirrels have displaced native red squirrels in much of Europe, partly because the grays tolerate the squirrelpox virus. The reds do not. In 2002, the Eurasian West Nile virus exploded across North America, causing occasionally fatal human infections, but also slaughtering native birds, especially in the crow family, because they had no resistance. But sparrows, originally Eurasian, kept the virus going because they can carry it with no ill effects. In 1998, Daszak was part of the team that found that just such an effect was allowing a previously unknown family of fungi, chytrids, to cause a massive worldwide die-off of amphibians that had driven some species extinct. So, wildlife biologists started learning about wildlife diseases. Eventually, it became clear that these diseases were also affecting humans. In 2008, Daszak and his colleagues calculated that of 335 novel pathogens that had emerged in people since 1940, 60% jumped to us from animals, and 72% of those, like Ebola and West Nile, came from wildlife. The official term is zoonosis, from the Greek words for animal and disease. The team also found that the rate at which zoonoses were appearing was rising, as was the percentage of them that came from wildlife as opposed to domestic animals. Again, the basic problem is our own growing population. When Burnett was writing, there were nearly 4 billion people in the world. Now there are twice that. More people demand more land and timber and more jobs, and for some that means catching wild creatures for ever more numerous city dwellers, for uses from pets to medicine. And especially, more people demand more food, so farmers scratch new farms out of forests and turn wild animals into new delicacies. The rest of us crowd into cities along with disease-carrying insects and other humans. Daszak and his colleagues mapped where the most new diseases had been observed and found hotspots in tropical and subtropical developing countries, where economic development was creating concentrations of humans close to many species of wildlife. This makes sense. The number of species of all kinds increases steadily as you get closer to the equator. There is just that much more, ultimately solar energy flowing through the system. More species mean more pathogens. As species disappear under the onslaught of deforestation and other ecosystem destruction, they at least take their pathogens with them. But in degraded ecosystems, the remaining animals can also carry more pathogens than they might in healthier surroundings, because they are stressed or hungry, and germs take advantage. Some biologists suspect a more insidious effect. When pathogens are hosted by several species, some hosts may limit the pathogens' numbers, while others do not. When an environment is degraded, only one kind of host is often left, and those survivors tend to be the weed species that live fast, die young, and don't invest much energy in fighting pathogens. As a result, there might be a greater load of pathogens in the hosts left in a depleted ecosystem than in the original diverse one. There has been an increase in Ebola outbreaks since 1994, and researchers suspect they are associated with deforestation, which both displaces and stresses the bats that host Ebola and attracts more humans into bat country. The biggest ever outbreak of Ebola raged through Guinea, Liberia, and Sierra Leone during 2014, killing at least 11,000 people. It started in the village of Meliandou, in Guinea, where the original dense forest had been largely replaced by cacao, coffee, and other farms. That left forest bats looking for a new home. Fabian Leandertz of the Robert Koch Institute in Berlin and a team of investigators visited Meliandou after the epidemic, and they found that the village children played in the huge hollow stump of a rainforest tree near the village, the only remnant of the old forest. A colony of insect-eating bats lived in the stump, of a species that can carry Ebola. 2-year-old Emile Wamono managed to contract Ebola, says Leandertz, although he doesn't know if the child was playing with a dead bat, as has been reported. His family might have known, but like Emile, they died. Most disease surveillance doesn't happen in these high-risk environments, though. It happens where the money and scientists are, in rich, temperate countries, even though new diseases like COVID-19 are far more likely to emerge in these hotspots. There are many hotspots in China, and also India and Indonesia, partly because of large human populations. The EcoHealth Alliance says the answer is close surveillance of hotspots for early clusters of disease, research to identify new, potentially zoonotic pathogens in wildlife, and efforts to conserve that wildlife so it will stay healthy and deep inside wilderness areas away from people. In the next chapter, we'll look at how that failed with COVID-19. But for now, let's look at how a pandemic like COVID-19 might happen again if we fail to contain some of the other viruses experts think are especially threatening. Some of them are worse than the one we are fighting now. In fact, disease experts all seem to agree on two things. Another pandemic is coming, and no one can predict which pathogen will cause the next one. However, in 2016, the WHO and a panel of scientists decided that some pathogens do bear more watching than others. They made a blueprint for R&D, research and development, to equip humanity with vaccines, drugs, and diagnostic tests for the most worrying of these pathogens before they go rogue, and created a list of 9 priority viruses for which they figured these should be developed fastest. The list has already been updated several times, not least to accommodate COVID-19, which was unknown when the WHO and a panel of scientists made the original selection. To be fair, though, they didn't completely fail to predict this pandemic. The first list did include coronaviruses. We knew the risk. Most of the priority pathogens, however, are not previously unknown viruses lurking in wildlife in a hotspot. All but one were chosen because they already cause human disease, and they have been traveling and adapting, which is worrying, especially as we don't have remedies. Their names, at least, are older and lovelier than COVID-19. Crimean Congo hemorrhagic fever, Rift Valley fever, Lassa fever, Zika, Nipah, Ebola. The one exception was dubbed Disease X, an instant hit with newspaper headline writers. It simply means a previously completely unknown pathogen we can't even guess at now, like the ones in wildlife Daszak and his colleagues warn about. It is on the list so research can be done into ways to respond to surprises, such as vaccine platforms that can quickly be adapted for a completely unexpected virus. We'll look at that later. Meanwhile, here are the viral most unwanted. Coronaviruses. Get 2 entries on the latest list. One for COVID-19 and one for the 2 we already knew about, SARS and MERS. The Coalition for Epidemic Preparedness Innovations, CEPI, set up in 2017 in Oslo to fund vaccine R&D for potential pandemics, had 5 vaccines in the works for MERS, the only severe coronavirus circulating in humans before COVID-19 appeared. As of this writing, it has 9 for COVID-19, all at very early stages. 2 more viruses on the WHO list belong to a family called Bunya viruses. Crimean Congo hemorrhagic fever virus lives in ticks across Asia, Africa, and southeastern Europe. It usually causes just a mild fever in people, but can also cause severe disease, killing up to 30% of cases with, according to the European Centre for Disease Prevention and Control, ECDC, fever, dizziness, sensitivity to light, and sharp mood swings in which the patient may become confused and aggressive. There is an old Soviet vaccine of unknown efficacy used in Bulgaria, but it isn't widely approved, partly because it is made using mouse brain, which can cause problems. A European research project aims to find a better one. CEPI has 2 in very early trials. Meanwhile, the virus is invading new territory as global warming moves the ticks north. It appeared in Western Europe in 2010 and has taken up residence in Spain. Rift Valley fever is a Bunya virus carried by mosquitoes, mainly to cattle, but people can get it from mosquitoes or infected meat. It is found across Africa, but it spread to the Arabian Peninsula in 2000. It is often mild, but occasionally causes inflammation and bleeding in the liver, encephalitis, inflammation of the brain, and blindness. Half of severe cases die. Livestock can be vaccinated against it, which is promising. Lassa fever, from another family, infects 500,000 people a year across West Africa, and again, most have mild or no symptoms. However, a few get severely ill, and 5,000 a year die. It is carried by the common multimammate rat. Yes, that means it has more teats than other rats, so you would think it was unlikely to spread beyond the rat's habitat. But worryingly, it has occasionally shown that it is capable of some human-to-human spread. Besides, better management of Lassa might help manage other risky pathogens in the same region. In the West African Ebola outbreak in 2014, early cases were initially mistaken for Lassa, which helped the far more contagious Ebola spread. The WHO wants diagnostic tests to fix that. CEPI has 6 vaccines for Lassa in animal tests. And there's a further concern with Lassa. It has relatives. In 2008, one that was previously entirely unknown killed a 36-year-old woman in Zambia. At the time, virologists warned how frighteningly little we know about viruses in Africa, where humans have lived longest and which therefore should, in theory, have more pathogens adapted to us than anywhere else. 5 of the 8 named entries on the WHO's priority list are originally African viruses. One is Zika, a flavivirus, a family that already counts 2 notorious diseases, dengue and yellow fever. All 3 are carried by Aedes mosquitoes, named with the Greek word for odious. One notorious Aedes, the aggressive tiger mosquito, is migrating outside the tropics with global warming and the global trade in used tires, which harbor puddles where it breeds. That mosquito migration has already spread emerging disease, chikungunya, a painful but usually non-lethal Aedes-borne virus from East Africa, had a mutation that adapted it to tiger mosquitoes in 2005 and began a series of explosive outbreaks around the Indian Ocean. It reached Italy in 2007 and the Americas in 2013. Zika was discovered in monkeys in Uganda in 1947 and then spread in monkeys to Southeast Asia. Until 2006, there had only ever been 14 known human cases. What it did next was completely unpredicted. In 2007, Zika caused a big outbreak on the island of Yap in Micronesia, followed in 2013 by French Polynesia and other Pacific islands. The virus's genes showed it came from Southeast Asia, either in an infected human or infected mosquitoes. The insects regularly hitch rides on airplanes, causing cases of airport malaria in countries that do not have malaria locally. Zika had been fairly mild the few times it was seen in people, but on Yap, some cases developed a potentially paralyzing nerve disorder, Guillain-Barré syndrome, an occasional complication of several different infections. Then, in 2015, it appeared in Brazil and rapidly spread across South America and into North America. This time, it was accompanied by severe birth defects in babies born to infected mothers, especially microcephaly, in which the head is abnormally small. Re-examined medical records revealed it had done the same in the Pacific, but no one had made the connection. Just as they had done with HIV, Oliver Pybus and team at the University of Oxford sequenced the Brazilian viruses and discovered they came from Polynesia. In fact, they were all so alike that, as with COVID-19, Pybus concluded that they probably descended from just one introduction, perhaps only one infected person. That carrier's infection could have resulted from just one mosquito bite. One bite. By late November 2016, Zika had left 3,700 babies in the Americas with birth defects. Pybus also found that Zika arrived in the Americas in 2013, 2 years before it was noticed. But as with any exponential epidemic, at first there were vanishingly few cases. It might have happened when Polynesian soccer fans traveled to watch the FIFA Confederations Cup games in Brazil in June 2013. No one really knows why Zika suddenly started causing large outbreaks. It did not undergo any obvious mutations that might explain it, Pybus found. It may be that everywhere else it has been, it mostly lived in monkeys, but occasionally infected humans, and children got it early, had a very mild disease as children often do, and developed immunity. After one generation of this, no adult would be non-immune. On Yap, there were no monkeys, and no one was immune, so it hit everyone, and adults got a worse disease, especially if they were pregnant. As for why Zika suddenly moved west, Pybus suspects it simply started getting more chances. Flights from Polynesia to Brazil increased 50% between 2012 and 2014. To spread the virus across the Pacific Ocean, either infected mosquitoes have to make the air journey, or an infected human does. For humans to carry it, they have to be bitten by mosquitoes at both ends of the trip. One to give the human the virus, and the second to get it and pass it on to another human. Both kinds of events are made more likely by the fact that more people than ever before are now flying between countries in the southern hemisphere, including while it is peak mosquito season in both places. The UN's International Labor Organization reports that since 2000, the number of people migrating for work within the global south, as opposed to migrating north, has grown from 60 to 82 million a year. Eventually, and as epidemiologists predicted, Zika cases in the Americas subsided as enough people had been infected to cause herd immunity. That happens when people who haven't had an infection and thus have no immunity become so rare that it is hard for a virus to reach someone new and susceptible before it dies out in its existing host. Herd immunity wanes as new people with no immunity are born and accumulate. So epidemiologists expect Zika to return. They don't know when. It might be years. It might also migrate elsewhere. 2 billion people on the planet live with tiger mosquitoes. Experimental Zika vaccines had gotten as far as human safety trials by 2016. But they need to be given to people at risk of catching Zika to test if they work, and there is now too little Zika circulating to test them. Ironically, until it returns, we won't have a vaccine. This is a perennial problem with emerging diseases. Meanwhile, managing Zika and other mosquito-borne illnesses like malaria, chikungunya, and dengue requires mosquito surveillance and control, and the 2015 epidemic revealed how little capability many health agencies now have to do that. Rich countries that don't have malaria but used to have large anti-malaria programs abandoned them in the 1980s, and people and expertise went with them. In 2015, the U.S. CDC found it had only 12 medical entomologists, scientists who can identify and manage mosquitoes that carry disease, to face the Zika invasion. The story goes that it pulled one retiree off a sailboat in the Caribbean to come back to work. Then there's the one disease on the WHO priority list that is most likely to keep the scientists awake at night, other than flu, and we'll look at that later. Few people have heard of Nipah virus. Frankly, this one truly scares me. Scientists who work on emerging diseases meet in Vienna every 2 years, and in 2016, I went along to talk to them about their research. As we chatted over good Viennese coffee, I conducted a straw poll. Which of these emerging diseases we're hearing about here scares you the most? The hands-down winner was Nipah. If you watched the last scene in the movie Contagion carefully, you know about Nipah. The virus is carried by Malaysian flying foxes, the world's biggest bats. Their species name is Vampirus, but they are fruit eaters, with a 5-foot or 1.5-meter wingspan. In 1998, forest trees in Malaysia failed to fruit because of a drought caused by the cyclic climate variation El Niño, plus smoke from human-caused forest fires in Indonesia. That drove big, hungry fruit bats to farms in peninsular Malaysia, including a village called Sungai Nipah, where they ate farmers' fruit and dropped half-eaten pieces into pig pens, as well as urine and feces. Pigs, being pigs, they ate the lot, and then developed a severe brain inflammation. People who cared for the sick pigs developed it too. The virus spread across Malaysia to Singapore, infecting 276 people in the two countries, of whom 106 died. 1 million pigs were culled in an effort to stop the spread of what was assumed to be a contagious pig disease. Then scientists figured out it was bats. In 2001, Nipah turned up in Bangladesh and nearby India. It turned out fruit bats were drinking the sweet sap toddy that farmers were tapping from palm trees and contaminating it. The virus now causes a winter outbreak somewhere in the region every year, with death rates up to 75%. In 2018, it turned up 1,600 miles away from Bangladesh, across the Indian subcontinent in the southwestern state of Kerala. The virus in Malaysia rarely spread person to person, but the Bangladesh virus does, although only to a few successive people before it dies out. The potential to spread more effectively may be there, though, infectious disease expert Daniel Lucy of Georgetown University explained to me. Most worryingly, he says, it sometimes causes pneumonia and appears to spread in coughed-out droplets. As we all know, diseases like that can cause trouble. Kerala is widely considered to have the best public health in India. It has also done a good job of flattening its COVID-19 curve. It isolated and treated people who caught the Nipah virus and contained the outbreak, although 17 people died, including healthcare workers. A very similar virus, Hendra, is carried by fruit bats and has spread to people via horses in Australia. Horses can now be vaccinated against it, which suggests human vaccines may be possible. In addition, the University of Queensland has developed a treatment. Antibodies are the proteins produced by your immune system that latch onto a particular pathogen and attract immune cells to destroy it. Various tricks enable immunologists to produce a line of cultured cells that all make the same antibody, called a monoclonal. The advantage is that production of a monoclonal antibody can be scaled up by making bigger cell cultures. You usually don't produce your own antibodies to a new pathogen until a week or more after you were infected. And if the initial disease is severe, that can be too late. An injection of monoclonal antibody that attacks the virus can help you fight it earlier. One that attacks Hendra virus, and should also attack Nipah, passed safety tests in people this year. In 2018, the Queensland team sent the antibody to Kerala, but the outbreak was contained before they could use it. Kerala had only one case in 2019, a 23-year-old woman who recovered. The state is keeping the antibody in reserve, though we don't know yet how well it will work on Nipah. It will be good to find out. Monoclonals are among the most promising treatments for viruses we might be able to brew up in a hurry. They are being investigated for COVID-19. Once again, the perennial problem with developing remedies for emerging diseases is that they are just emerging. Virologists fear Nipah could evolve to cause epidemics, but for now, it strikes only small numbers of people randomly, so tests of therapies are hard to organize. CEPI has 4 vaccines in animal experiments or human safety trials, but to test whether a vaccine works, it has to be used in an outbreak. No one knows where one will strike next, but it could turn up in new places. African fruit bats also carry the virus. In 2014, Dajak and his colleagues found that people in Cameroon living in areas undergoing deforestation and who butchered fruit bats for food had antibodies to Nipah, showing they had been infected. Finally, there is Ebola. The epidemic that raged throughout 2014 in Liberia, Guinea, and Sierra Leone took the disease world by surprise. The virus, also carried by bats, was originally discovered in Congo and had previously caused mostly small, containable outbreaks there or nearby. No one expected it in West Africa, though it later emerged that the virus had been detected there earlier, but no one had paid much attention. It started in December 2013, but wasn't recognized as Ebola until March. It continued to spread as Guinea's government initially resisted reporting cases for fear of discouraging foreign investors. The WHO, reluctant to offend a member state and hamstrung by bureaucracy, also dragged its heels. When it hit the region's cities, the disease raged out of control, eventually infecting 28,616 people, 50 times more than any previous Ebola outbreak, and according to the most careful observations, killing 70% of them. By August 2014, when the WHO declared an emergency, the epidemic curve was exponentially headed for unthinkable heights. Finally, the world, and the WHO, with a revamped effort led by Bruce Aylward, who later led its COVID-19 mission to China, responded and contained the epidemic with the same tools used for COVID-19: isolation, contact tracing, and quarantine. Also, as with COVID-19, changes in ordinary people's behavior were crucial. Friends stopped embracing, and families stopped touching virus-laden corpses at funerals. As with COVID-19, there were no drugs or vaccines for Ebola. After the U.S. anthrax scare in 2001, there was some funding to develop them, as Ebola was considered a potential bioweapon. The funding ended after a few years. Yet, by early 2015, companies had taken the prototypes developed then and pulled off a world first, testing a vaccine in the middle of a raging epidemic. One was nearly 100% effective, but it had taken a year to get it manufactured and approved so it could be deployed in Africa, by which time the epidemic was almost over and it could only be tested in a few places. That vaccine and another one were, however, deployed in the next Ebola outbreak in 2018 in the conflict-ridden east of the Democratic Republic of the Congo. That epidemic had almost been halted as of April 2020, almost unnoticed amid the rising COVID-19 pandemic. By then, the vaccine tested in 2014 had been given to nearly 300,000 contacts, and contacts of people with Ebola, in a massive containment effort that was 97.5% effective at blocking transmission of the virus. The WHO was heavily criticized for its slow response to the 2014 Ebola epidemic. But its role had always been to advise countries on medical treatment, set standards for medical products, and organize long-term efforts like vaccination campaigns. It was supposed to coordinate the response to international outbreaks, too, but it was never designed to be a global emergency response agency. By 2016, it had undergone a major restructuring to become one. That has stood us in good stead with this pandemic. So, after dropping the ball on infectious disease in the 1970s, we have at least been talking about the renewed threat of them for years, as far back as that 1992 report that alerted the world to the growing threat of emerging disease. Yet, it took a near disaster with the world's largest ever Ebola epidemic in 2014 to reinvent the WHO as the emergency response agency for epidemics we, astonishingly, never had up to that point. The Ebola emergency also launched CEPI and the WHO R&D roadmap and its pathogens list. Here's a rare, optimistic thought. Think what COVID-19 might inspire us to do. Yet it should be noted that, as a bat virus still unaccustomed to humans, Ebola spread relatively slowly in West Africa. Researchers have since found, to their horror, that as it spread, the virus adapted to people and may have gotten better at transmitting. That would make it much harder to contain. Viral evolution is one of the larger unknowns humanity faces as it goes forward into the future, where we are all more aware of how vulnerable we are to pandemic disease. We will look at that in more detail later, especially how that might affect some of the viruses on this list as we turn toward the future. First, we have enough to handle with the viruses we've got. Let's look at where COVID-19 came from. Chapter 3. SARS, MERS, you can't say we weren't warned. Experience is that marvelous thing that enables you to recognize a mistake when you make it again. Franklin Jones, 20th century U.S. journalist, quoted in 2006 by epidemiologist Zhong Nanshan in relation to SARS. Have you heard of an epidemic in Guangzhou? An acquaintance of mine from a teacher's chat room lives there and reports that the hospitals there have been closed and people are dying. Stephen Cunyon, an infectious disease expert and former head of preventive medicine for the U.S. Navy, received that email from a friend on February 10, 2003. He couldn't find any further information, so he passed the email on to ProMed. The same day, ProMed got a notice from the Hong Kong Health Department warning travelers of a pneumonia outbreak in Guangdong, the southeastern Chinese province of 100 million people next to Hong Kong. Guangzhou is its capital and biggest city. ProMed posted both messages. The next day, the WHO asked China about it. The health ministry in Beijing replied that the province did have a pneumonia outbreak that had started the previous November. There had been 305 cases and 5 deaths. That was the first the world heard about what was eventually called severe acute respiratory syndrome, or SARS. In the first half of 2003, it traveled to 29 countries and territories, infected 8,096 people, and killed 774, many of them healthcare workers. Then it was stamped out. SARS comes up repeatedly in any discussion of COVID-19, as it was in many ways a forerunner. The COVID-19 coronavirus has been officially declared the same species as the SARS virus, named literally SARS-CoV-2. It spreads more readily and is less lethal, but otherwise, it is much the same. And looking back at reporting I did for New Scientist about SARS, I'm astonished at how little else seems to have changed. To understand what unleashed COVID-19 and what needs to happen to prevent the next pandemic, we need to understand SARS. It was, after all, a very clear warning of what is happening now. And then we got 2 more warnings, and we still did very little. The WHO already had an inkling something was happening. In late 2002, a Canadian government system that monitors global press reports for mentions of disease picked up reports of pneumonia in China. But the rules in force at the time meant WHO couldn't inquire further about information it had not received officially from a government. It couldn't ask China for details until February 11th, after the official Hong Kong warning. The same day, Guangzhou made its first public statement about the outbreak, which had already led to local panic buying of herbal remedies and vinegar, a traditional disinfectant. The health department said it was caused by a common bacterial infection, mycoplasma, and was under control. ProMed called this speculative and posted a press report that many of the people hospitalized were doctors and nurses. On February 18th, the China Center for Disease Control and Prevention, China CDC, said the outbreak was chlamydia, another bacterial infection, and under control. Again, ProMed was politely dubious. Both of the bacteria mentioned so far were good news in a way because they could be treated with antibiotics. But both could also be co-infections alongside a primary infection with a virus, for most of which there are no drug treatments. On the 20th, ProMed posted a press report by a foreign-owned news service that quoted a doctor in Guangdong who did not wish to be identified, saying a virus could not be ruled out. There was little the WHO could do. The rules at that time were that it could not even tell the world about an outbreak unless the country that had it gave permission. And it could not officially get information about an outbreak from any source but that country's government, leaving it unable to act on information it got anywhere else. Then our increasingly interconnected world took things up a notch by moving the outbreak across a border. On February 22nd, Liu Jianlun, a doctor who had been treating the pneumonia in Guangdong, developed symptoms while staying on the 9th floor of the Metropole Hotel in Hong Kong, where he was attending a wedding. He warned hospital staff to isolate him, knowing what he had, but they had no official warning of the danger and took insufficient precautions. Some were infected. Liu died 10 days later. Meanwhile, 7 other people who stayed on the same floor of the Metropole developed pneumonia and carried the virus to other hospitals in Hong Kong and to 3 other countries. Liu was a super spreader. No one ever figured out exactly how they were infected. SARS traveled in coughed-out droplets like COVID-19 and persisted the same way on surfaces. Some suspect the 9th floor elevator buttons. Johnny Chen, an American businessman on the 9th floor, developed pneumonia a few days later in Hanoi. His carers also fell ill. Carlo Urbani, a 46-year-old Italian infectious disease expert working for the WHO in Hanoi, realized this was a new disease, warned the WHO, and started infection control measures at the hospital. He later developed SARS and died. There is a memorial plaque to him at WHO headquarters in Geneva. The virus cultured from his lungs, known as the Urbani strain, is still used in virological research. Other people from the 9th floor traveled to Canada and Singapore. Those countries eventually had some 250 deaths each. Vietnam had 63, China had 349, Hong Kong 299. SARS had a 10% death rate, higher than any estimates for COVID-19. It, too, hit the elderly harder, but scaled up. Half the people over 60 who got it died. Both viruses seem to kill the same way, a runaway reaction of the immune system called a cytokine storm, named after the signaling chemicals the body uses to turn on the immune reaction called inflammation. Normally, inflammation is the way our bodies fight invaders, but in some people, some pathogens can unleash too much of it. Now that the outbreak was outside China, the WHO could act at the behest of the other affected countries. On March 12th, it issued an alert, warning countries and airlines to watch for cases and citing the outbreaks in Hong Kong and Vietnam and Guangdong, even though authorities there still officially attributed it to chlamydia. The WHO noted that investigation of the cause in Guangdong is ongoing. Soon, there were cases in Taiwan, Singapore, Thailand, and across the world in Canada. But China still reported only 305 cases, the same number as a month earlier. At the same time, it asked the WHO for technical assistance. A team arrived in Beijing on March 23rd. Immediately, China's case numbers jumped to 792, a suggestion that authorities were being more open now with other experts in the room. But the team was kept in Beijing, and not allowed to visit the epicenter in Guangdong until April 2nd. At that point, things came to a head. The principle of state sovereignty was enshrined in the WHO's founding treaty when it was set up, along with the UN itself in the wake of World War II, and ruled in disease management as in everything else. The International Health Regulations, a 1969 treaty with antecedents going back to the 19th century, prohibited the WHO from doing much without a member state's explicit permission. But as fears about emerging diseases rose after AIDS and the 1992 Institute of Medicine report, a new idea was taking hold: global health security. The idea was that in a highly interconnected world, diseases could go global fast, so sometimes, for the greater good, an international agency should have the right to interfere in a sovereign state to ensure threatening outbreaks are contained. Implicit in this was the belief, born of repeated experience the world over, that what governments do in their own interests might not be in the interests of the world as a whole, especially when it comes to disease. In 2003, the Director General of the WHO, Gro Harlem Brundtland, a doctor and the former Prime Minister of Norway, decided to interfere. Brundtland is still revered by many at the WHO, partly for how she handled SARS. She seemed to have a taste for combat. She once jabbed me in the chest, hard, and then walked away when I asked her at a press reception for her response to some criticism. All she heard was that I had repeated the criticism. I asked one of her aides if she was always like that. "Oh, yes," he said. From the beginning, the SARS virus had demonstrated relatively limited spread in droplets, and all cases could be traced to other cases, meaning containment could work. But on March 30th, more than 200 cases suddenly appeared at the Amoy Gardens apartment complex in Hong Kong. David Heyman, at the time head of infectious diseases at the WHO, told me there were fears it had become airborne, which would make it much harder to control. So on April 2nd, 2003, Brundtland advised the world to cancel all but essential travel to Hong Kong and Guangdong. Fears of airborne spread subsided when the Amoy Gardens outbreak was traced to faulty plumbing. But the WHO issued further travel advisories for Beijing and Toronto in late April. None were lifted until each city had largely contained its epidemic, after a week for Toronto, but around 2 months for the other cities. It was unheard of for the WHO to issue advice with such direct financial implications for countries without their blessing. The advisories meant considerable lost business. Toronto estimates it lost $265 million. It sent delegations to complain to WHO headquarters in Geneva. China's health minister reacted more strongly to the travel advisory, publicly urging people the next day to visit Guangdong. Over the next few weeks, authorities limited visits within China by WHO officials and seemed to be understating case numbers. Brundtland was openly critical. Then, on April 9th, Zhang Yang-yong, a retired surgeon at a Beijing hospital, told Beijing TV stations that claims the epidemic was under control were nonsense, saying there were more than 5 times the official number of cases just in Beijing. Western media reported it, and Chinese citizens spread the news on cell phone networks. The next day, Zhong Nanshan, then the head of the Respiratory Disease Research Institute in Guangdong, told the press, "The origin of this disease is still not clear, so how can you say it has been controlled?" He suspected a virus and later wrote that, in fact, a Chinese lab had identified the coronavirus as early as February 26th, but kept it quiet, as official sources blamed bacteria. Then, on April 14th, a Canadian lab sequenced the SARS virus from a patient whose infection could be traced back to China. Further claims that bacteria were responsible were no longer credible, and the WHO confirmed the virus as the cause of the pneumonia. Yang John Wang, of Seton Hall University, who has researched the period, writes that on April 17th, the top committee of the Chinese Communist Party called for a change in policy, and China's president, Hu Jintao, instructed officials to stop withholding information about the epidemic. 2 days after that, officials admitted that Beijing had 346 SARS cases. The reported number had been 37. Outside China, the world had swung into action. Heyman set up daily conference calls between doctors, epidemiologists, and virologists around the world to compare notes on the best treatment, speed up the development of tests to diagnose the virus, and work out how it spread. The worldwide conference call became a durable model, Heyman told me in March this year. The same groups were convened for COVID-19, this time online. Then, as now, what was crucial was old-fashioned epidemiology. Cases were isolated. Their contacts were traced and quarantined. Workers in affected hospitals self-isolated if they developed a fever. Hong Kong barred contacts from leaving the territory, and police went after quarantine breakers. Singapore monitored quarantine with then-novel internet cameras. Toronto eased up on quarantine too soon and almost lost control, but got it back. However, at the time, senior health experts told me that while this containment might slow the epidemic, the virus would inevitably get into cities that simply did not have the resources or the social order required to contain it. SARS was here to stay. On April 26th, I wrote in New Scientist that rich countries, in pure self-interest, must ensure that any eventual vaccine went to both rich and poor, because sooner or later SARS is coming to a person near you. But my sources were wrong, even though their fears were entirely reasonable. Sometimes luck takes a hand. The virus never reached Kinshasa or Calcutta. On July 5th, there had been no new cases for 3 weeks, and the WHO declared SARS contained. What had also happened was that after abandoning its efforts to conceal SARS, China launched mass mobilization to contain the virus, confining Beijing students to dorms and spending more than $1 billion refurbishing hospitals and finding and isolating cases. Sound familiar? The abrupt shift from downplaying the outbreak to a no-holds-barred response was eerily similar to what happened with COVID-19. Then, as now, it worked. And it would have been a lot easier, and lives around the world might have been saved, if it had happened earlier. Since then, more of the underlying story has come out. Wang wrote in 2004 that Guangdong health officials initially recognized the new disease as a virus and alerted authorities. But the law made any infectious disease outbreak a state secret until the health ministry announced it, so they couldn't tell anyone else. Then there were bureaucratic delays at the ministry, some because of the Lunar New Year holiday until February 11th. Then the news blackout resumed during the National People's Congress in March, just as it did during the Party Congress in Wuhan with COVID-19. Lower-level officials soft-pedaled reports to senior officials, Wang found, for fear of looking bad. Again, there are parallels, he says, with COVID-19. Having faced a harrowing near miss on SARS, you'd think we'd be doing better by now. And in fact, in the aftermath, China installed the automated alert system we talked about in Chapter 1, meant to allow doctors to alert central authorities to certain diagnoses, notably undiagnosed pneumonia, bypassing bureaucrats to make sure the blockages that delayed reporting SARS didn't happen again. Yet it was sidelined when COVID-19 emerged by the same bureaucratic culture of suppressing bad news. There were a few quickly contained outbreaks of the virus the year after SARS was beaten, including escapes from virology labs and some outbreaks described as having been from a wild source. Both types were troubling. Labs remain a worrying source of dangerous viruses, although scientists and regulators tightened up precautions after the SARS incidents. In April 2020, some alleged that the COVID-19 virus might have escaped from the Wuhan Institute of Virology, where China's first highest-level containment lab, the kind used to study the most dangerous pathogens, opened in 2015. No evidence for this was offered, but there are concerns with all these labs that despite the showers and filters and hazmat suits, a scientist might be infected with a virus that sometimes causes few symptoms and then carry it outside. And the possibility remained that the SARS virus, or something very like it, still lurked in the wildlife it had presumably come from in the first place. That, in fact, was discovered by the virologists at the Wuhan Institute, initially in 2005 and definitively in 2017, and they warned the world about it. We'll discuss that later. But although some SARS virus remained in a few lab freezers and wildlife, it was clear that SARS was gone from people. A triumph, if a close shave. What was crucial in controlling SARS, says Heyman, was that unlike COVID-19, the virus could not be spread by oral or nasal droplets until late in the infection, well after symptoms started, because it did not build up in the nose and throat until then. Thus, if you isolated every exposed person with a fever, you had contained it. With COVID-19, people with symptoms have already been spreading virus around for a day or two. Viruses that spread before they cause symptoms are very hard to contain. Look at HIV. Because SARS didn't spread as readily as COVID-19, no severe social distancing was needed to slow its spread enough to cut the number of contacts that had to be quarantined and make containment possible. There were also no asymptomatic cases. So SARS never spread far in the community. And it never got into any big, chaotic cities in poor countries that could not have contained it. That did not happen this time. The number of flights from China to such places has increased tenfold or more since then. That is partly due to increased travel globally and the vastly increased prosperity of many Chinese. It is also partly due to the Belt and Road Initiative, China's massive program for investment and infrastructure across Eurasia and Africa. Simply put, in 2003, we dodged a bullet. ProMed, WHO leadership, global collaboration among experts, shoe leather epidemiology, and eventually massive Chinese action, led finally by its doctors and scientists, eradicated SARS. They were helped by the fact that the virus was simply clumsier at spreading among humans than COVID-19. What stands out now is the speed and efficiency with which, in retrospect, the world acted. The virus didn't get opportunities to establish itself in countries outside China that delayed taking action to contain it, as happened with COVID-19. As the virus arrived, there was no disputing the need for containment or talk of relying on herd immunity. Because of this swift action, SARS never circulated widely enough to be called a pandemic. Maybe the virus's high death rate scared everyone into line. Maybe its inability to spread before symptoms started and absence of many mild cases just made it easier and less disruptive to follow the epidemiologist's advice. And there was more public trust in experts 17 years ago. But did we learn our lesson with SARS and apply that to its sibling, COVID-19? In its World Health Report in late 2003, the WHO listed the 5 top lessons from the epidemic. Lesson 5 was that the health systems should protect healthcare workers, who made up between 1/3 and 2/3 of SARS cases in heavily affected countries. Most nurses were, and are, women. And among healthcare staff, women were 2.7 times more likely than men to get SARS, whereas outside of hospitals, it infected both equally. Yet even now, in some rich countries, doctors and nurses are dying and must face COVID-19 with insufficient masks, gloves, and gowns. Lesson not learned. Lesson 4. The world's scientists, clinicians, and public health experts are willing to set aside academic competition and work together for the public health good when the situation so requires. To say that has happened again with COVID-19 would be a massive understatement. The outpouring of scientific and medical collaboration has been astonishing, as has the sheer quantity of research, posted almost before the ink is dry on the data, on preprint servers like bioRxiv or medRxiv. This also means it's posted before the usual expert reviewers have formally decided it's okay, which can call for caution. But in many cases, other scientists have piled on and reviewed this research anyway. I'm constantly amazed at how easily all the technical people communicate, said Bruce Aylward of the WHO after returning from investigating COVID-19 in China in February. For me, covering the story, it's been amazing watching a global scientific community deal 24/7 for months with a truly global crisis. And with both viruses, it was doctors and scientists in China and elsewhere who told the world how serious things were. I'm not sure we had to learn this lesson. We already knew. Lesson 3 was that travel restrictions can help, the WHO claimed, despite conceding that temperature checks in airports caught only 2 cases of SARS. This is tricky. Modeling by several research groups has suggested closing borders doesn't actually achieve much. With COVID-19, the WHO advised against it. Closed borders certainly impeded the response to Ebola in 2014. On the other hand, countries the world over have famously closed their borders as an extension of their lockdowns to slow the spread of COVID-19, and travel restrictions were crucial in China. Let's say lesson learned. Lesson 2 was that global alerts work. After the WHO issued its alert on SARS in March 2003, affected countries redoubled efforts and got the epidemic under control, and others kept imported cases from spreading. The International Health Regulations Treaty was massively revised in 2005 because of SARS and enshrines this by having WHO declare a public health emergency of international concern when an extraordinary threat looms. With COVID-19, they made that declaration on January 30th. Lesson learned. Lesson 1 is worth quoting in full. The first and most compelling lesson concerns the need to report promptly and openly cases of any disease with the potential for international spread. Attempts to conceal cases of an infectious disease for fear of social and economic consequences must be recognized as a short-term stopgap measure that carries a very high price: the potential for high levels of human suffering and death, loss of credibility in the eyes of the international community, escalating negative domestic economic impact, damage to the health and economies of neighboring countries, and a very real risk that outbreaks within the country's own territory will spiral out of control. Strengthening of systems for outbreak alert and response is the only rational way to defend public health security against not only SARS, but also against all future infectious disease threats. And the WHO meant that to apply to all countries. Even though the burden of sounding the alarm fell to China in 2003 and again in 2020, the whole world needs this lesson. China certainly was more open about many things from the start on COVID-19 than it was about SARS in 2003, except for the crucial detail of its being contagious. Lesson not learned. So that's 2 learned, 2 not learned, and 1 not needed. Clearly, the lessons unlearned from SARS have been deadly. Case in point, I wondered in New Scientist in April 2003 whether, if Hong Kong hospital staff had known more about this new pneumonia in February, they might have used better infection control and not let it spread further. Or, if China had acted sooner, whether it could have limited SARS to Guangdong. We're wondering those kinds of things now about COVID-19. If nothing else, though, you would think we would have some coronavirus drugs and vaccines by now, just in case SARS or something like it ever came back, which, of course, it now has. But China's bureaucracy is not the only system failure in this saga of global disease mismanagement. Western capitalism has its glitches as well. The silver cloud of eradicating SARS has a dark lining. Vaccine labs and antiviral drug developers set to work as soon as the SARS virus was identified, and their findings are being dusted off now to fight COVID-19. But, those experts say, funding to continue the research dried up after 2005, precisely because SARS had been eradicated. So our knowledge and tools are nowhere near what they could have been if that work had continued. With no virus circulating, it is, if nothing else, hard to test whether a drug or vaccine works because normally you do that by treating infected people or by vaccinating people and watching to see if they get infected. You can look for alternative measures of success or failure, such as durable immune reactions to a vaccine in humans, or convincing results curing, with drugs, or protecting, with vaccines, animals exposed to the virus experimentally in a high-containment lab. But no one bothered doing this, says David Heyman, because with no SARS virus circulating, there was no market for any SARS drugs or vaccines they developed. Only big pharmaceutical firms have the know-how and money to get a drug or vaccine through the big, complex safety and effectiveness trials they rightly need before governments approve their use. Without a market, the companies cannot invest in these expensive trials because they won't make their R&D investment back by selling the eventual products. At one time, as we saw with smallpox vaccines, some pharmaceutical companies were state-owned and could undertake work for the public good. But since the 1980s, those have disappeared, and pharmaceutical development is all done by private companies that are required to turn a profit. It's not because they're mean. It's because we decided as a society to do it that way. influenced by ideas that as much as possible should be done by the market rather than government. With SARS gone, it was too big a financial risk for a private company to invest in SARS drugs and vaccines. There was no guarantee they would ever be needed. The same market failure stifles R&D for other vital medicines that, for various reasons, cannot be sold in large enough quantities or at high enough prices to make the R&D investment back. Most worryingly, new antibiotics. Mechanisms for getting around this problem by rewarding drug developers in ways not tied to selling the product have been discussed, but little has been attempted on a commercial scale. This all makes developing products for any emerging disease difficult or impossible for the private companies that do much of our drug and vaccine development. However, public good is making a comeback. Over the past decade, public-private partnerships have emerged to develop drugs and vaccines for diseases mostly found in poor countries, funded by the Bill and Melinda Gates Foundation and others. CEPI, launched just in time for this crisis, organizes such funding for vaccine R&D for emerging diseases and now for COVID-19. But there was another reason no real effort was made after SARS to develop remedies for coronaviruses. Some virologists decided SARS was never coming back. They made two mistakes. Rolf Hilgenfeldt of the University of Lübeck in Germany was working on a promising approach to anti-SARS drugs when funding for that research dried up in 2006. He says one mistake was based on a major genetic difference between SARS and other coronaviruses. In SARS, a swath of 29 nucleotides found in other coronaviruses was simply missing from one gene. Such deletions are certainly not unknown in viruses like these, which keep their genes as RNA rather than DNA. RNA viruses tend to be less genetically stable, and the gene's function was then unknown. Yet, some argued this major change was what enabled SARS to suddenly spread in humans. And, they reasoned, exactly the same dramatic mutation was unlikely to happen again. Ergo, SARS was not coming back. Other virologists disagreed. I certainly never said that, says Ab Osterhaus, a leading virologist whose lab did experiments in 2003 that clinched the proof that the SARS virus caused the disease. Those who did say it were at least right about the deletion not coming back. The COVID-19 virus does not have it. But COVID-19 spreads even better in humans than SARS did. So clearly the mutation didn't play the role they imagined. But there was also a second mistake. Thinking SARS was gone in wildlife, too. In 2005, the repeated failure to find the virus in civets led some researchers to conclude the virus was gone in nature and had disappeared as a threat. People who fell ill with SARS were initially linked to a wildlife market, as were some of the first people with COVID-19. The SARS virus was found in Guangdong markets in cages that had been occupied by masked palm civets, a member of a family of mammals related to cats, which in China are bred on farms and sold as game meat. Traffic, an environmental group headquartered in Cambridge, England, that monitors trade in endangered wildlife, says some 10,000 civets were destroyed in markets in China in 2003 in an effort to stamp out the virus. Tragically for those civets, virologists now think they had little to do with it. The virus came from bats. A few civets and another mammal, the raccoon dog, in Guangdong markets were found to have SARS or to have been infected with it in the past, and attention focused on civets because far more of them were sold. But, said virologists reviewing the research in 2007, SARS was never found in civets anywhere else, wild or farmed, and the evidence suggests the animals were infected at the market the same as humans were. Nonetheless, the story that civets were the intermediate species that spread the virus to humans became widespread. Several tales are now being told about COVID-19 and pangolins. In 2005, though, Chinese scientists were already warning that the virus could well lurk in other species. Also that year, virologists at the Wuhan Institute of Virology reported coronaviruses that were very similar to SARS in bats, which were also sold at markets. If no action is taken to control wildlife markets, Zhong Nanshan warned in 2006, the SARS virus might once again develop into an epidemic strain. Nevertheless, companies and government research funding agencies went with the more welcome assessment that SARS was gone. And yet, between the disappearance of SARS from humans and the arrival of COVID-19, we got another warning about these coronaviruses, MERS. In June 2012, Ali Zaki, an Egyptian virologist working at a hospital in Jeddah, Saudi Arabia, couldn't identify what had killed a 60-year-old man with pneumonia. The only positive test was a generic one for coronaviruses. But SARS was gone, and the other known coronaviruses in humans cause common colds. If any virologist could identify an unknown virus quickly, Zaki thought, it's Ron Fouchier in Rotterdam. He sent him samples. Normally, scientists can't afford to take time identifying odd viruses that crop up. Stamp collecting, they dismissively call it. You rarely get a publication out of it, and researchers' jobs depend on getting research grants, which are given for research that does result in publications. But one good response to SARS was a program in the EU that funded researchers to do the odd stamp collecting for mystery diseases, just in case they discovered something important. Fouchier had funding from the program, and he discovered a previously unknown coronavirus in Zaki's sample. Worryingly, it was, like SARS, closely related to what by that time virologists knew were bat coronaviruses. Zaki posted it on ProMed. A British hospital immediately discovered the same virus in a man with undiagnosed pneumonia who had just been in Saudi Arabia. Within days, Zaki told me later, the Saudi Health Ministry had sent an aggressive and threatening team to investigate his lab. He took emergency leave in Cairo. He was sacked and informed, he told me, that it was not safe to return to Jeddah. The Saudi Deputy Health Minister, Zayed Memish, told me it was intolerable that Saudi authorities didn't know about the virus until they saw it on ProMed, 3 months after the patient died, and just as preparations were at their peak for the biggest annual human gathering on earth, the Hajj in Mecca. That's a real concern. Memish helped run the exactingly thorough Saudi health controls aimed at stopping anything worse than the ubiquitous Hajj cough from marring the pilgrimage. Zaki and Fouchier, though, told me that the upcoming Hajj made it a good thing the virus had been identified so fast, as they had also been able to discover that it did not spread readily. Zaki was convinced that this would not have happened so quickly if he had told only the Saudi authorities. The virus was named Middle East Respiratory Syndrome, MERS, as cases were soon found all over the region. It was in local bats, but people got it from camels. As of November 2019, there had been 2,494 cases worldwide. 4/5 of them in Saudi Arabia, and 858 deaths. This virus has a high death rate. In 2015, a man who had been in the Arabian Peninsula brought MERS to South Korea, starting an outbreak mostly within hospitals, 184 cases, 38 deaths. MERS has appeared in 27 countries, usually as only one or a few cases after someone has returned from travel to the Middle East. That isn't much spread in 8 years. The main reason is that the virus never quite seems to have made itself comfortable in people. MERS can spread from one person to another, but chains of infection die out after a few cases. Epidemiologists call it stuttering transmission. In viruses that jump to us from animals, contending with our entirely new immune system can be too difficult, and the viruses that manage to get out and into another person might be too few to get much farther. Moreover, unlike SARS and COVID-19, which latch onto cell surface proteins in the nose and throat, MERS binds to proteins mostly in the deep lungs. That is one reason it is more lethal than the other two viruses. Infections there can kill you. But it also means the virus literally has trouble getting out and into the next victim. Your deep lungs don't cough and sneeze. The worry with such a virus is that it is under enormous pressure to adapt to its new host. And if MERS does, we could get a virus that spreads more readily but is also deadly. To prevent that, you want to keep its opportunities to infect people and adapt to a minimum. This especially applies to protecting patients and staff in a hospital facing a MERS outbreak. Even more than SARS, this is a disease of health care, partly because some medical procedures, such as inserting a ventilator into someone severely ill with pneumonia, can expel it from the deep lungs and into someone else. That has been observed with COVID-19 as well. Hospital infection control staff made huge strides in restricting the spread of MERS, first in Middle Eastern hospitals, then after it invaded South Korean hospitals in 2015. Last year, epidemiologists calculated that increased efforts to diagnose and contain the virus early had averted up to 500 cases since 2016. So unless it evolves, MERS isn't threatening most of us anytime soon. But it is worth knowing about for 3 reasons. 1, it shows that China isn't the only country that doesn't like nasty new diseases being discovered on its territory, or involving foreigners in the response. In years of covering infectious disease, I have encountered all too many examples. BSE, or mad cow disease, started in Britain, and despite science showing it had to be in continental Europe, countries there denied it for years, even though we knew by 1996 that it caused a devastating disease in humans. When I reported the science in 1997, there was uproar in Belgium, and scientists were forced to lie to support the official denial. 2. As the only threatening human coronavirus left in circulation after SARS was stamped out, MERS was actually the subject of some coronavirus vaccine work when COVID-19 hit. Those experimental vaccines are now being adapted. 3. If SARS wasn't enough, the appearance of MERS definitely demonstrated that we should have been working more urgently to prepare for coronavirus outbreaks. How many warnings did we need? In fact, we got a third one. In 2016, piglets started dying on farms 60 miles from Foshan, the town in Guangdong where SARS is thought to have started. It was called SADS, Swine Acute Diarrhea Syndrome. virologists isolated a coronavirus and found it was 98.5% identical to one found in the droppings of horseshoe bats in a nearby cave, the same species linked to SARS and COVID-19. The pigs had probably eaten some. Nearly 25,000 piglets died, and the disease broke out again in 2019. There weren't any infections among the farmers, but in September 2019, scientists at Zhejiang University in Hangzhou found that SADS can infect cultured cells from humans. So here was another bat coronavirus. It was killing mammals, and it might well infect people. Yet we hadn't done much to guard against these things until we were locked in a global struggle against COVID-19. Except for a woman named Shi Zhongli at the Wuhan Institute of Virology and the EcoHealth Alliance. They've been chasing coronaviruses to where they live, in bats. And that could hold the key to finally getting a grip on these viruses. Chapter 4. Don't Blame the Bats. We have met the enemy, and he is us. Pogo, a comic strip by Walt Kelly. The COVID-19 virus comes from bats. So did SARS. So do MERS, Ebola, Marburg, Nipah, Hendra, and Lassa viruses. So does hepatitis C, which an estimated 71 million people are living with worldwide. After biting the head off what he had assumed was a rubber bat a fan threw on stage during a 1982 concert in Iowa, heavy metal singer Ozzy Osbourne needed the long, painful series of injections required to prevent rabies, another bat virus. Today, the treatment is a little easier. And those are just a few of the viruses living in bats that we know cause human disease. In April 2020, researchers reported 6 kinds of coronavirus previously unknown to science in bats in Myanmar. That adds to the 400-odd found already in China. In 2017, a survey of all known gene sequences of coronaviruses found there were 100 clusters, essentially family groups, of the viruses. 91 of those live in bats, making bats the world headquarters of coronavirus evolution. And they carry other kinds of viruses, too. If we want to understand this pandemic, and what we need to do to stop the next one, the connection between bats and viruses needs to be explored, for 3 reasons. 1, if we're going to even keep a watch for the next pandemic, we're going to have to work out what exactly is going on with bats and all these viruses. 2, we must learn which of their viruses might jump to us and take measures to prevent and prepare. And 3, and most importantly, we must generally learn how to act on this kind of information. We had it for COVID-19, and we didn't use it. That's right. A lab in China, in work confirmed by virologists in the U.S., found a virus very similar to the one that causes COVID-19 in bats in 2013, a full 7 years before this pandemic swept the world. Both Chinese and American scientists clearly warned that this kind of virus could well cause a pandemic. And yet, no serious action of any kind was taken. It was no one's job to do that. This is one of the things we need to change. We knew bats in the Americas carried rabies in the 1950s, but no one knew they harbored this plethora of viruses until 1994. That year, flying foxes, a kind of fruit bat, were found to carry a mystery virus that had killed horses and 2 of their human caretakers in Hendra, a suburb of Brisbane, Australia. After that, the more virologists looked, the more they found. Wildlife scientists, fearing bats would be persecuted because of this, have accused the virologists of disproportionately targeting bats for viral discovery. But a 2017 review of the research showed that, even after accounting for different amounts of research effort, bats were still significantly more likely to harbor diseases affecting humans than any other group of mammals. Soon after the SARS epidemic took hold in 2003, Chinese scientists started the long hunt for the source of the virus. As we heard in Chapter 3, it was initially found in masked palm civets at a wet market, but only in Guangdong, never in any other wild or farmed civets. In fact, civets infected with SARS got sick, proving they could not be the home of the virus in the wild, where sick animals don't last long. In 2004, Shi Zhengli of the Wuhan Institute of Virology and her colleagues started looking for the SARS virus in nature. The team wondered if both the Guangdong civets and people got it straight from whatever animal was the real reservoir for the virus, the term for a species that can carry a virus and pass it on, but does not itself get sick from it. Shi's team knew bats could carry viruses without getting sick, and bats and bat products, they wrote, were increasingly turning up as food or traditional medicine in markets in southern China. So they went to bat caves across China and took blood, urine, feces, and throat swabs from dozens of bats of various species. She was nicknamed Batwoman by her colleagues. Sure enough, there were viruses 94% identical to SARS in the insect-eating horseshoe bat, which lives in Hunan and many other Chinese provinces and across Eurasia. The bat viruses were all similar, but had between them more slight genetic variations than the SARS viruses from humans or civets. Although the SARS viruses fit within a family tree of all these viruses. That is what you'd expect if bats are where these viruses live naturally, and just one or a few of such viruses moved into civets and us. None of the viruses they initially found was exactly the same as the SARS virus. For one thing, none had the same binding area on the big spike proteins on the outside of the virus, which in SARS latches onto the ACE2 protein on human and civet and bat cells, the same receptor COVID-19 uses. But they kept looking. In 2009, they partnered with the PREDICT program of the U.S. Agency for International Development, USAID. PREDICT was launched after the H5N1 bird flu scare in 2004, which we'll look at later. It sets up local labs and surveillance in countries with hotspots of zoonoses, and the EcoHealth Alliance is a major participant. Kevin Olival, now EcoHealth's vice president for research, mostly works in Indonesia and Thailand, countries that can use more help building virology infrastructure than China, which has become one of the world's leading producers of world-class research. But there is a PREDICT team working alongside Chinese scientists at a forest site in China's southern Yunnan province. It is only 40 miles from Kunming, a city of 6 million, but it is a zoonosis hotspot with a well-populated bat cave. Olival told me about their research project. The procedure, he said, is to trap bats when they flutter out of the cave to hunt just after dark. The trap looks like a giant harp with 2 sets of vertical cords strung in an open frame. The echolocating bats detect the first cords and do a mid-air turn to fly between them, only to become lodged against the second set. No longer able to stay aloft, they slide down into a big soft bag at the bottom. They just snuggle up in there, says Olival. The scientists and technicians already have lights, bottles, labels, and sampling swabs laid out on a folding table nearby. They take a throat swab, an anal swab, and a blood sample from each bat. Then the bats fly off to resume hunting. As a conservation as well as disease hunting organization, says Olival, we don't want to harm the bats. The samples from Yunnan are analyzed for coronaviruses, but PREDICT has operations like this looking at different kinds of high-risk wildlife and different pathogens in Bangladesh, Brazil, Colombia, Indonesia, Malaysia, and Mexico as well. The findings are analyzed and mapped to predict potential disease outbreaks, and importantly, says Olival, the information is fed back to the communities at risk so they can protect themselves. In China, though, the EcoHealth Alliance was joining a disease hunt that was already underway, and the collaboration quickly paid off. In 2013, Xi's lab found 2 viruses in the Yunnan bats that were 95% identical to SARS and had an exterior spike protein with a sequence they knew would bind to the same ACE2 protein on human cells that SARS used to invade us. The 2 sequenced viruses were dead. Many samples from the bats are taken back to the lab in a preservative, as that makes them less risky and easier to deal with. But they also brought some samples back alive. From one, the team managed to isolate a live virus that could infect both bat and human cells. It was also instantly recognized by antibodies, immune proteins that are highly specific for particular pathogens, from SARS patients in 2003. Bat coronaviruses remain a substantial global threat to public health, Xi's team concluded. In 2017, the team reported more SARS-like viruses from the bats and discovered that, like some other viruses, they swap gene segments around. They found segments with all the exact gene sequences required to build the original SARS virus in bats from the one cave near Kunming, and evidence that the viruses were actively recombining gene segments. After 14 years, the long search was over. They knew for sure where SARS came from. But besides SARS, they found a wide variety of slightly different coronaviruses similar to SARS that are able to latch onto the human ACE2 protein to invade cells. The risk of spillover into people and emergence of a disease similar to SARS is possible, they warned. That, of course, is what has now happened. COVID-19 latches on to ACE2. Meanwhile, virologist Ralph Barrick and his team at the University of North Carolina reconstructed one of the viruses Wuhan had discovered using the gene sequences and found it infected human airway cells in culture just as well as the SARS virus, the Urbani strain. It made mice with human ACE2 proteins sick. Yet, it was different enough that an experimental SARS vaccine didn't protect them, showing that even if we beat one type of coronavirus, even very similar ones could be entirely new challenges. The title of a 2015 publication of the work warned that SARS-like bat coronaviruses show potential for human emergence, and the report spoke of a need for both surveillance and improved therapeutics against circulating SARS-like viruses. In 2016, further work called one of the viruses poised for human emergence. The virus has significant pathogenic potential, Barrick and the team concluded, and if it emerged, we had no vaccines. So we knew there were viruses like SARS out there that could infect humans and cause illness without having to spend time adapting in another species first. We knew this 7 years ago. And since then, more research has only confirmed that. It was even reported in the press. At that meeting in 2016 in Vienna on emerging diseases, where people were worried about Nipah, Kevin Olival told me, and I reported, that PREDICT had helped find a Chinese virus closely related to SARS, but different enough that prototype SARS vaccines won't work against it. It got even more alarming. In 2018, Xi's team reported that the viruses were already trying us out. They found antibodies to the bat coronaviruses in people living near the caves in Yunnan, showing they had been infected, and they had not been exposed to SARS in 2003 or traveled. There were also antibodies to SARS-like viruses in market traders in Guangdong in 2001, well before SARS exploded. But those weren't found until 2004, after SARS was gone, in a retrospective analysis of stored blood samples. With SARS, we were caught blind. But with COVID-19, we knew these viruses were checking us out before this pandemic even happened. It is highly likely that future SARS or MERS-like coronavirus outbreaks will originate from bats, and there is an increased probability that this will occur in China, she wrote in a review of the research just last year. Therefore, the investigation of bat coronaviruses becomes an urgent issue for the detection of early warning signs. Every disaster movie starts with someone ignoring a scientist. It is now too late for warnings. Perhaps the team's saddest paper came out on January 29th, the same day my New Scientist piece was headlined that the new coronavirus looked set to go pandemic. This time, all the authors were Chinese scientists, most in Wuhan, and the new disease was raging in their town. They recapped the work to date. They had discovered SARS-like coronaviruses in their natural reservoir bats. Previous studies have indicated that some of those bat SARS-CoVs have the potential to infect humans, they recalled. The news this time was that the new virus killing people in Wuhan was 96% identical to one of those bat viruses, RATG13, and used the same cellular receptor, ACE2. We warned you, in other words. But good scientists that they were, they got on with what to do now. Future research should be focused on active surveillance of these viruses, they wrote, and broad-spectrum drugs and vaccines should be deployed against this group of viruses in general. Most importantly, strict regulations against the domestication and consumption of wildlife should be implemented. That last comment gets us to the most important question raised by all this. Bats live everywhere. Why have these bat viruses broken out in humans twice in China? Is it the bats? Or the way people interact with bats? It is actually hard to catch viruses directly from bats. Only 6 of the 218 people who lived near the bat caves in Yunnan had antibodies from infection with bat coronaviruses, even though they regularly saw the bats near their homes. Similarly, MERS has been found in Saudi bats, but humans only ever catch it from camels, which apparently carry the bat virus with no ill effects. As mentioned earlier, poor little Emile Wamono in Meliandou in Guinea caught Ebola from a bat and died, triggering the Ebola epidemic in West Africa in 2014. But children in his village routinely caught, roasted, and ate those bats with no apparent problem, says wildlife virologist Fabian Leyendertz, who led the expedition to Meliandou to try and figure out what happened. He doesn't know why Emile was unlucky. Debora Mackenzie of Curtin University in Australia, no relation to the author, told me that no one there has ever caught Hendra virus directly from a bat, only from horses, which might get it by eating the fibrous remnants of fruit the bats spit out, or the afterbirths shed from birthing roosts. Catching Nipah requires either a pig intermediary or sharing a drink of palm sap with a fruit bat. Australian wildlife activists regularly nurse injured bats back to health, and only 2, says Mackenzie, ever got Australian bat lyssavirus, a virus closely related to rabies carried by Old World bats. Sadly, they died. Nowadays, bat rescuers are all vaccinated. Confused rock stars aside, people have gotten rabies by handling bats in the Americas. But today, Britain and Australia are considered rabies-free, even though their bats carry lyssavirus. Bats just don't pose enough risk to people to be counted the same as other rabid species like dogs or raccoons. I know a woman in a picturesque Cotswold town in England who rescues bats. She has a room full of cages and baskets sheltering convalescent bats of nearly every species in Britain, some endangered. She freely handles them, feeds them, bandages wounds. Only one British species, Daubenton's bat, is known to carry bat rabies, she assured me on a visit, expertly lifting one out of its basket. They're cute little things with incredibly soft brown fur. I trust her judgment, but I was happy to leave handling them to the experts. So, how have SARS and COVID-19 gotten into us? Blame has fallen on the wildlife trade, especially as both diseases emerged in winter, the season for hunting and slaughtering animals in agricultural societies. So, by extension, the season when eating game meat has been traditionally considered good for one's health in China. In April 2020, the Executive Secretary of the UN Convention on Biological Diversity called on China to shut down wildlife markets, like the one in Wuhan linked to COVID-19. The message we are getting, said Elizabeth Maruma Mrema of Tanzania, is if we don't take care of nature, it will take care of us. Opinion is now divided, though, on what role that market played in COVID-19. 2/3 of the cases China first reported on January 24th had links to it, and the rest didn't. If the virus came from some animals sold on the market, I still hear people asking why were 1/3 of cases not linked to it. Possibly because many early cases got the virus from other people, not an environmental source, and it just happened to spread to the market early. Markets are, after all, sources of human contact. I am strongly of the belief that the virus as we saw it in Wuhan is pretty much exactly the virus that was in bats. It just happened to have everything it needed to spread in humans, says Rambo. I think the market cases were just part of a bigger cluster. It doesn't mean the market was the source. But the association with the market stood out, maybe because people associated markets and SARS, and in January, only people with an association to the market or another case could be tested for the virus. We don't know how many with no association there were. And just as civets proved to be at best incidentally related to SARS, so it seems are pangolins and COVID-19. Related viruses were found early on in the scaly creatures, the world's most trafficked, highly endangered mammal, and Chinese scientists proposed that pangolins were the intermediate host that spread the virus to people. The pangolin turned out to be a red herring, says Rambo. The SARS-like viruses found in them are far less like the COVID-19 virus than are viruses found in bats. RATG13, the bat virus that was closest genetically to SARS-2, the COVID-19 virus, wasn't identical to it. We estimate they split from a common ancestor between 40 and 70 years ago, says Rambo. But other features of the viruses suggest that the lineage that gave rise to SARS-2 was in bats for almost all of that time. I don't think we require an intermediate host to explain any of the features of the SARS-2 genome. There are two unusual bits of gene sequence found in the COVID-19 virus, and as of May, none of the known bat viruses had them. One of those did turn up in a pangolin virus, but it's possible both of them are in a bat virus in some combination, says Rambeau. The variety of viruses in bats is huge, and it took 14 years of dogged bat sampling to find viral gene sequences that precisely matched the 2003 SARS virus. It is not surprising that researchers haven't found COVID-19's dead ringer yet. Yet accounts of SARS nearly all state with assurance that civets were the intermediate host, despite the lack of evidence the virus even needed one. The same kind of uncritical tale of COVID-19 and pangolins is now becoming entrenched. If that leads to further persecution of pangolins, already at severe risk due to their use in traditional Chinese medicine, it would be tragic. So if the virus came straight from bats, but it's hard to catch viruses from bats normally, how did we get it? If it did make that first jump at a market, there is hope of stopping this from happening again. China shut down live wildlife markets across the country in late February, and activists hope it will follow that up with a permanent ban. That was supposed to happen after SARS. According to Traffic, however, Guangdong imposed a trade ban on wildlife meat in late April 2003, but lifted it by mid-August, after SARS had disappeared, for 54 captive-bred species. Business as usual rapidly resumed. That may happen again. By late March, with cases of COVID-19 in China falling after weeks of lockdown, and the problem perceived as over, China's wildlife markets were reported to be reopening. In any case, what are bats doing there? Peter Lee of the University of Houston downtown says eating exotic wildlife is not traditional among the vast majority of Chinese. He says rural families turn to catching and then raising wild animals as a way to get food and then to make money after the upheavals of the 1960s in China. Since then, a wealthy and powerful industry has emerged, selling ever more exotic meat to China's many wealthy city dwellers. Demand for wild animal meat from the consumers is false, says Lee. The demand has been created by the traders and restaurant owners who claim it is good for health, longevity, sex, brain health. That suggests it may be possible to reverse the fashion, and reportedly it is less popular with younger Chinese. It isn't just fashion, though. Bats are traditionally eaten in southern China, as well as elsewhere in Southeast Asia and, indeed, in Africa. Smoked bats are popular in Ghana, and, Leendert says, they have become common game all over Africa as larger animals become rarer. However, people tend to eat the meaty, large-bodied fruit bats, not tiny insect eaters like the horseshoe bats that carry SARS-like coronaviruses. But maybe we're on the wrong track by thinking of bats as food. Horseshoe bats are used for TCM, traditional Chinese medicine, which is very widely used in China. The WHO reported in February 2020 that herbal medicines prescribed by TCM figured prominently in China's medical response to the COVID-19 epidemic. Yeming Sha, night brightness sand, is dried, powdered bat feces. It's not hard to find. Type it into a search engine, and you'll turn up numerous online sources, one charging $12.38 per 100 grams, lists one of the source species as horseshoe bats. It cools the blood, reduces stasis, and stops pain. It treats eye disorders, malarial-like disorders, childhood fright, painful urinary dysfunction, vaginal discharge, scrofula, and swollen sores. The product description reads, "A happy customer in February posted, 'Already put into use.'" But mostly, Yiming Sha is used for eye problems. The Clinical Handbook of Chinese Prepared Medicines says it clears heats, nourishes the eyes, and improves night vision due to high levels of vitamin A. An online site about TCM explains that bats are blind, fly at night, so their droppings are good for vision, especially at night. In fact, bats have excellent vision for the same reason birds do. They fly. Sampling in Yunnan found bat coronaviruses in fresh horseshoe bat feces. Drying fresh bat droppings collected in the wild might kill viruses in it, but possibly not always completely, especially if the resulting powder is applied to an unprotected body part. There are ACE2 receptors in the eye, and evidence suggests the COVID-19 virus is especially persistent there, and that eyes might be a major route of infection. When I asked TCM practitioners online, they advised applying a water extract of Yiming Sha directly to the eye. According to information collected by Traffic, dried bodies of horseshoe bats are also a folk remedy for cough. Ironic given COVID-19's signature symptom. Perhaps the greatest risk is not from the remedies themselves, but from and to the generally impoverished people who catch the bats or collect fresh droppings. The bat guano used for fertilizer is often from old deposits and may pose less risk. If collectors are infected with a bat virus, they could then spread it to other people, maybe while delivering bat products to a market. One possibility for the so far elusive patient zero in COVID-19. Horseshoe bats live in Hubei and indeed are widespread in China. It is not unreasonable to think that China might reduce the risk of zoonotic disasters by cleaning up wet markets, whether or not those were the source of COVID-19. We know for certain that they are the source of some worrying strains of bird flu. Peter Daszak says it would make sense to at least improve biosecurity there. Currently, the large number of species sold in wet markets are stacked in cages, freely passing body fluids and any accompanying viruses among themselves, bats included. Better hygiene might reduce that. At least one might hope there are better ways of cleaning up markets than were used in April 2020 in Surakarta, Indonesia. After news of the origin of COVID-19 got out, live fruit bats, who do not, as far as we know, carry these viruses, were taken from a wet market and burned alive. But controlling wet markets is one thing. TCM is quite another. It is held in high esteem in China. Much of it is undoubtedly valuable. Artemisinin, currently the world's leading antimalarial drug, was derived from a traditional herbal treatment by one of the great women of science, Tu Youyou, who won a Nobel Prize for it in 2015. All the same, some Chinese think it might be time to reconsider some TCM ingredients. The Chinese Pharmacopoeia is the authority for materials approved as medicine in China. The current 2015 edition includes bat feces, but a new edition is due out in 2020. There has been a lot of pressure exerted on the Chinese authorities to remove bat dung as an ingredient from TCM in the Chinese Pharmacopoeia, says Peter Li. At this point, I don't have confirmation that it will be removed. The larger issue, though, is conservation. If maintaining biodiversity in the wild reduces our risk of zoonosis, as scientists say, then all of China's wildlife trade, not just markets, needs careful consideration. The use of animals for medicine often bypasses wildlife markets, but is driving some species to extinction. And some uses could stem more from commercial claims than real traditional cures. Knowing all this about bat viruses and their transmission, one key question remains. Why bats? It seems humans get these viruses from bats, but how and why do bats get them? For years, this has been explained with a much cut-and-pasted set of proposed explanations. Bats are everywhere. Some live in large communities. They travel long distances. But those things are true of other species, including our own, and we don't naturally harbor things like Ebola or COVID-19. Living in large colonies facilitates the spread of bat diseases to other bats. Witness the white-nose fungus severely threatening some bat species in North America. Why should that also facilitate things that kill people? It now seems more likely to be a result of none of those factors, but instead, something unique to bat biology. Understanding this helps to explain what we have to do to stop pandemics like COVID-19 from happening again. Spoiler alert, it absolutely is not killing the bats. Nearly a quarter of all mammal species are bats. Only rodents account for more. Bats are the only mammal that truly does powered flight, using its muscles for lift rather than simply gliding like flying squirrels. In terms of evolution, this was a spectacular success. Flying meant bats could occupy many niches, spaces in the environment that supply the shelter, food, and mates they need, that nothing else could occupy. Lots of niches meant lots of species, and two wildly different tribes evolved. The big vegetarian fruit bats of Eurasia, Africa, and the Pacific, and the little echolocating insect eaters of pretty much everywhere but Antarctica. But flying has a downside. It takes a huge amount of energy. A bat's heart can beat 1,000 times per minute. While they fly, they burn sugars and other fuel for energy and consume oxygen just as we do when we exercise. But while flying, a little insect-eating bat does that at twice the rate of a similarly sized mouse running flat out. All these chemical reactions generate damaged molecules, called free radicals, that are highly reactive, like fire in your cells. Bats have extremely efficient systems for snuffing these out. This has a useful side effect: long life. Free radicals are thought to cause many of the changes of aging and may be why smaller animals, with higher metabolic rates and more free radicals, live shorter lives. But whereas a mouse lives 2 years, a bat of the same size, with an even higher metabolic rate, but a very good free radical extinguisher, can live for 40. There's another side effect, though. Bats' high-energy turnover produces other molecular fragments, bits of DNA. Such fragments aren't damaging in themselves, but in us, they can only mean one thing: infection by some pathogen that left its DNA lying around. So in humans, any such fragments trigger massive inflammation, an immune reaction that kills cells infected with viruses. However, in a bat, DNA fragments are normal, and a bat would just damage itself if it unleashed inflammation on cells that have them. So bats dial down inflammation. That means they need another way to protect themselves from infection. To do that, they evolved a different method of fighting viruses. They don't. Instead, they mount a kind of nonviolent exclusion. In her free time, Kara Brook of the University of California at Berkeley works as a science educator and conservationist in Madagascar. But her day job is virology. And in February 2020, she published work in which she infected bat cells growing in dishes with Ebola and Marburg viruses, two human pathogens found in fruit bats. The cells mounted a lightning response, rapidly turning on a slew of genes that effectively stopped the viruses from invading the cells. Whereas humans would turn on a complex cascade of inflammation reactions to clear out cells infested with a virus, bats try to stop viruses from ever entering their cells at all. In Brook's dishes, a few cells didn't react fast enough, so they were infected. The virus could replicate, and the infection smoldered on. But it was held at bay as most of the cells stayed virus-free. Such a low-level infection, Brooks calculates, can last a bat's whole life, even if it is a relatively long one. That's why even though many families of viruses live in bats, only one, rabies, seems to cause much disease. Many of the symptoms of our illnesses are triggered not by what the virus is doing to us, but by the efforts of our immune system to kill the virus. That's why so many diseases, including COVID-19 and, of course, flu, start with the same infamous flu-like symptoms. Bats don't do much inflammation at all, and they stop most viruses from doing too much direct damage, so they don't get sick like we do from them. But the viruses, like any evolving organism, fight back. The ones that attack just a little bit faster than the others are the ones that get into an occasional bat cell and replicate. Those viruses become more numerous, or, in evolutionary terms, aggressive infection is selected for. Brooks suspects this is what makes bat viruses extra deadly in us. They have evolved to beat the bat's hair trigger response, so in us they move ferociously fast. In addition, bats' high metabolic rate means they normally have a higher temperature than humans. One of the defenses against viruses is to run a fever, as our viruses are often hurt more by a slight increase in temperature than we are. A fever might just make bat viruses feel more at home in our bodies. The mechanisms bats use to coexist with viruses could teach us a lot about how we might control our own viral infections, says Kevin Olival. And the fact that damping inflammation seems to contribute to bats' longer lifespans, and might also be what stops them from getting cancer, could teach us even more. Meanwhile, apart from studying them, the best thing to do with bats is to just leave them alone. That may seem counterintuitive. If we want to protect ourselves from viruses that normally live in bats, shouldn't we just get rid of bats? Unfortunately, people do routinely destroy bat colonies out of fear of disease, especially rabies, even though disrupting bats is more likely to spread the diseases than stop them, as the uprooted bats that escape fly everywhere. There are already reports of people destroying bat colonies in misguided efforts to fight COVID-19. More to the point, though, you can't get rid of bats, says Olival. The world needs them. They are often keystone species on which many others in an ecosystem depend. Hundreds of species of fruit, for example, depend on bats for pollination, including mangoes, bananas, and guavas. And if fruit doesn't rock your world, you should know that bats are also essential to the agave cactus, used to make tequila. The vital baobab trees of African savannas are exclusively pollinated by bats. Insect-eating bats, like the ones that host the COVID-19 virus, can eat their weight in insects every night, especially nursing mothers. Those meals include disease-carrying mosquitoes. The bats also eat tons of moths that are major crop pests. Bats are calculated to do $3.7 million worth of crop protection a year in the U.S. alone. No polluting pesticides required. Losing them would trigger domino effects through the farming ecosystem that would cost even more. Fruit bats, like the ones thought to host the Ebola virus, are vital for dispersing seeds in tropical rainforests. I often say, no fruit bats, no rainforests, says Andrew Cunningham, a veteran wildlife and animal disease expert with the London Zoological Society. In fact, given the role of rainforests in carbon storage and weather patterns, you could take this further to its logical conclusion and say, no fruit bats, no humanity as we know it. Simply left alone, bats are harmless and highly beneficial, says Bat Conservation International. Of course, it would say that. But in 2006, a team of scientists at the Arthropod-Borne and Infectious Diseases Laboratory in Fort Collins, Colorado, agreed. In a review of the research, they concluded that bats are critical for nearly all biological communities on land. Myths and misunderstandings have led to efforts to extirpate bat populations, with serious consequent effects on insect control and crop production, without coincidental reduction in the already low incidence of rabies virus transmission by bats. This holds true for other viruses as well. There has been public and political pressure in Queensland to manage Hendra virus by culling or dispersing fruit bat populations, Australian scientists reported in 2015. But, they found, the amount of virus in a population of bats didn't depend on their population density, so reducing that density would not reduce the virus. Stress on the bats, though, would increase it. In 2008, researchers found that hunger made Hendra virus more prevalent in flying foxes than any other stress, making the steady loss of trees where fruit bats can live the biggest risk. And climate change and wildfires just cause more of it. The 2015 report suggested that restoring forests of wild fruiting trees to entice the bats away from people and horses would be the best way to prevent Hendra. Bats are not the problem. They don't cause disease emergence, says Cunningham. People do, by destroying and encroaching on their habitat, and by catching, trafficking, and butchering them. This can even infect other animals nearby that, if infected, might be able to carry and even multiply the bat virus, further increasing the risk. In any case, says Olival, besides being ecologically appalling, eradicating bats would simply be impossible. There are too many, and they fly. And then the remaining bats might just carry more virus. When a cave full of bats carrying the deadly Marburg virus was smoked out in Uganda, it was rapidly recolonized by young males from other colonies, carrying more Marburg than the originals. Marburg is a childhood infection in bats. The problem with bat viruses, the researchers note, is not the bats. It is that when one of their viruses does jump to us, we let it get away. In West Africa in 2014, there was one transmission of the Ebola virus from a bat to a human child, and thousands of transmissions between people after that. COVID-19 started with one jump of a bat virus to one or a few humans. Then that was followed by millions of transmissions among us. That second thing, the transmission of virus between humans, is the problem. The answer, says EcoHealth Alliance, is both surveillance, to spot and contain diseases early when they do reach humans, and conservation, to maintain intact ecosystems where bats are unlikely to encounter people or move into farms or towns. If nothing else, surveillance is cost-effective. Over 10 years, says Olival, PREDICT costs around $200 million. Much of it to establish ongoing capabilities to monitor emerging infections in 30 low-income countries. That is a tiny fraction of the trillions in emergency relief the U.S. has allocated as a result of COVID-19, and that in turn is only part of what the pandemic has cost. But PREDICT also illustrates the problems with the surveillance we have so far. The program's funding came to an end in 2019, and field work stopped when the money ran out in September. It was granted another $2.26 million to continue another 6 months from April 1st because the labs it helped set up are, in some countries, the only labs that can detect the COVID-19 virus and, without PREDICT funding, trained staff will likely be lost. PREDICT labs were the first to detect people with COVID-19 traveling from China to Cambodia and Thailand. But that funding was only guaranteed through September 2020. This kind of capricious funding, dependent on varying levels of interest or capacity in the scientific or political world, has prevented the serious day-in, day-out surveillance required to prevent pandemics. PREDICT has at least built countries' local capacity to continue monitoring their own viruses, says Olival. We don't fly in, collect samples, and fly out. The scientific capability they leave behind might be among the best legacies of the program. David Heyman, who headed the WHO's campaign against SARS, believes that is what the world most needs to catch the next pandemic virus that emerges. The question is, what did we do with the warnings we got from PREDICT? The viruses they helped collect in Yunnan allowed Xi and Barak to warn us about SARS-like viruses that could emerge in humans with no further alterations needed. The warning was taken seriously enough that the U.S. decided to renew its funding of PREDICT's work in 2019, including work to investigate the viruses. That hit a major snag, though, in April 2020, which we'll discuss in the next chapter. What about an actual report aimed at protecting ourselves from these viruses, though? The aim of the WHO's R&D roadmap is to develop vaccines, treatments, and diagnostics for its list of priority pathogens, which includes coronaviruses in general. In theory, we could have done that. In practice, until one of these viruses causes extensive disease in people, much expenditure is unlikely, whatever the WHO roadmap says. But we could at least have developed a PCR test that distinguishes between SARS-1, or as some virologists are calling it, SARS Classic, and the related bat viruses in case one did emerge, and put more effort into surveillance for any coronaviruses in humans. The bottom line is, we didn't even do that. Perhaps if Dr. I in Wuhan had had a more specific test on hand and realized that her patients didn't have SARS but something new, the alarm would have been greater and the response faster. EcoHealth and other organizations promote the concept of One Health, communication and coordinated research and monitoring of disease between researchers and clinicians who deal with human and animal health. It's a sensible idea, but it will accomplish little as long as no one in government is tasked with the job of using this information to fund the precautionary responses that would make us safer. Or an intergovernmental forum, come to that. We will return to that later. It's clear. We had warnings, and we didn't act on them. However, there's one disease where we have taken the warnings into account, for which One Health thinking and pandemic planning are well advanced. Good old reliable flu. Chapter 5. Wasn't the pandemic supposed to be flu? In the year of 1918, God sent a mighty disease. It killed many 1,000 on land and on the seas. Blind Willie Johnson. Jesus is coming soon. In January 2004, I went to a meeting at the Venerable Royal Society in London, called to take stock of what we had learned from the SARS nightmare that had ended 6 months before. The coffee break arrived, and people from the conversation groups were chatting in hushed tones about civets. It got depressing. I headed for the coffee in the back of the room. There I saw someone I did want to talk to. Ab Osterhaus is one of Europe's top virologists. His lab had just done Koch's postulates on the SARS virus, a rarely met standard for proving a pathogen causes a disease. And he was leaning against a pillar, looking very, very shaken. I wasn't sure I should say anything, but Ab's a pretty informal Dutchman, so I asked if he was okay. He told me he had just been exchanging emails with a colleague in Hong Kong. It's this H5N1 bird flu, he said. If this adapts to humans, it could be really bad. He searched for a word. Civilization ending, he said. In early 2004, Ab wasn't the only flu expert who was very worried about H5N1. In fact, those experts still are. Yes, the COVID-19 pandemic is a coronavirus, not a flu. They are quite different. But we're talking here about pandemics in general. It is to be hoped that having seen the COVID-19 pandemic, we handle the next flu pandemic better. It would be only fair, because the last flu pandemic messed up the way we are handling COVID-19. Flu, influenza A to be formal, is the one pandemic we know is coming. We know other diseases can go pandemic, and if anyone had any doubts, COVID-19 ended them. You can debate, perhaps, the pandemic potential of some of the viruses on the WHO's priority list. But flu is a different story. Pandemic is what flu does. You can't talk about how pandemics happen and how we respond to them without understanding flu. First, Flu 101. Stick with me for a moment. You'll see why this really matters soon. The virus consists of 8 chunks of RNA, coding for a mere 11 proteins, and a shell studded with 2 of those proteins, hemagglutinin and neuraminidase, thankfully abbreviated H and N. These come in different varieties, which have numbers, and paired together, they identify the type of flu virus. Right now, 2 kinds of flu, H1N1 and H3N2, are circulating in humans. But flu viruses that circulate in ducks, the original host of flu, carry 16 different kinds of H and 9 kinds of N. Plus, there are 2 more of each unique to, you guessed it, bats. like most of the other varieties, they leave us alone. Flu viruses adapt to particular hosts. Our current 2 kinds of influenza A are adapted to us and don't infect birds. There's also an influenza B, which circulates with the 2 influenza A viruses and makes people sick every winter, but it never seems to go pandemic, so let's mostly ignore it here. Likewise, bird flu viruses are adapted to birds and don't normally infect us. Both bird and human flu viruses can infect pigs, as well as the pig's own kind of flu, and humans can catch what emerges. The flu virus is transmitted in the droplets we exhale, like COVID-19. Droplets evaporate and fall to the ground quickly in warm weather, so flu does better in cool weather. Derek Smith of Cambridge University and colleagues worked out how this leads to the annual flu epidemic. Accidents of geography mean that in East and Southeast Asia, cool, rainy seasons are always happening somewhere at different times. So there is always a flu season happening somewhere in the region, and flu is constantly infecting people and evolving. Then, as winter sets in the northern hemisphere, the flu in East Asia breaks out and circles the globe. Then it does the same in the southern hemisphere's winter. Flu basically mounts its own pandemic every year, except we don't call it that because it is routine. The viruses that dominate this yearly tour of the planet are the ones that can dodge our immune systems best and get into the next human quickest. To get to the top of this class, flu plays a crafty game. The big H protein on its surface attracts most of your immune system's attention, and it constantly mutates at 7 different hotspots. It eventually accumulates so many little changes that many of your immune defense proteins, antibodies that would recognize and attack the last flu you got, don't quite recognize this virus. So you get sick again. This is easy for flu. It makes a lot of mistakes when it copies its genes because it doesn't have an enzyme for fixing them. The virus that causes COVID-19 does have that enzyme, so it has at least started out this pandemic with what seem to be much more stable genes. Although it's still an RNA virus, so it can evolve fairly quickly if it's pressured to. Mutation is random, and in RNA viruses, even relatively stable ones, fairly frequent. When a random mutation happens to make its bearer survive and reproduce better than others that don't have the mutation, bearers of the mutation can become more successful and numerous. That is not random. That's evolution. With flu, your immune system still recognizes the unchanged bits of the slightly evolved H and N in the rest of the virus, so you can mount some immune response and keep the infection in check. That's why most ordinary flu is just that, ordinary. Just enough to make most of us miserable for a few days each winter, and usually no worse. This constant change is also why we need a new flu shot every year. Ordinary winter flu isn't always trivial. Just like COVID-19, it is far more lethal in the elderly and people with underlying conditions like diabetes. That's why health agencies recommend a flu vaccine for such people every year. The vaccine you get next autumn needs to immunize you for the flu that will circulate the following winter, which will be a little different from the flu that circulated this past winter. But it takes 6 months to grow enough flu virus to make that vaccine. So twice each year, vaccine companies and flu virologists come to a meeting at WHO headquarters in Geneva and try to predict what precise flu virus will be circulating in a bit more than 6 months' time so they can start growing vaccine. They hold one meeting for the Northern Hemisphere, one for the Southern. It's not easy. The guesswork is based on years of sophisticated observation and scientific analysis. Even so, flu sometimes pulls a surprise. And the vaccine virus the companies spent 6 months growing turns out to have been different immunologically from the flu virus that ends up dominating that flu season. Or they guess right, but growing in eggs sometimes causes the vaccine virus to evolve and adapt to eggs, and what comes out isn't quite what they put in. In Australia in 2017, the H3N2 virus in the vaccine did this and provided little protection. It's not the world's greatest vaccine technology. There are other flu vaccines. There are live, weakened flu viruses you take as nose drops, and normal flu vaccines grown in cell cultures instead of eggs. But there are only a few such vaccine factories. There just isn't enough money in flu vaccines to justify much investment. Not everyone bothers getting vaccinated for a disease that, in many, is mild. Even if they do, it's only once a year, and the companies can't charge a very high price or they'll lose what customers they have. A few years ago, a vaccine maker pulled the plug on a plan to build a new flu vaccine plant in the U.S. They just couldn't make it add up economically, even with substantial financial support from the U.S. government. Flu experts have been warning for years that we need to fix this situation, because every now and then, flu makes a really big genetic change and outfits itself with an H and an N that no one, or almost no one, has ever encountered before. Then, whatever immunity to flu we got from viruses in recent years doesn't work, especially if the new virus is substantially different. Such viruses cause more severe disease, and we put up so little fight against them, they can circulate in seasons other than winter. We call this global epidemic of flu a pandemic. That happened in 1918, when a particularly deadly flu virus started circulating. You will have heard about it, perhaps because of its recent 100th anniversary, or perhaps because so many people are making comparisons to COVID-19. It was called the Spanish flu because it started during World War I, and news of it was censored in the countries that were fighting, but not in Spain, which wasn't fighting. It was lethal. There were tales of people getting on buses or trains feeling not too ill and dying before they arrived at their destination. Opinion is divided, but at least 50 million dead is a safe guess, in a world that had a quarter of the population of today. In any case, it caused more deaths than the war itself. The virus was more aggressive than most flu in attacking the deep lungs and causing pneumonia directly, and also triggered bacterial pneumonia, all of which COVID-19 does too. Except in 1918, there were no antibiotics for the bacteria. The pandemic may have helped end World War I and start World War II. Its third wave in April 1919 took the most conciliatory negotiator, U.S. President Woodrow Wilson, out of treaty talks in Versailles, helping lead to a treaty so punishing for Germany that it is often blamed for the rise of Hitler. The U.S. lost 675,000 people to flu in the 1918 pandemic. More than in World War I, World War II, the Korean War, and the Vietnam War combined. Incredibly, we have actually been able to analyze its structure. Virologists recovered the virus from an Inuit woman who died of it and was buried in permafrost. and reconstructed it in 2005. There is still some disagreement about where the virus came from and where it first broke out. Some experts think it was a bird flu that managed to adapt to humans. Some think it got some genes from earlier human flu. If two flu viruses invade the same cell, their 8 RNA bits replicate and then reassemble in random mixes. If a bird flu and a human flu invade the same cell, some of the viruses that emerge can have totally new H and or N proteins, as well as other components, a mash-up to which we have much less immunity than we normally do to flu. History records flu pandemics back to 1510. The one in 1918 seems to be the most lethal on record. But by 1921, that same virus was ordinary winter flu, not because it mutated massively, but because most people had encountered it, survived, and developed some immunity. It proceeded to circulate every winter until 1957, when it swapped its H and N for replacements from a bird virus, which virologists named H2 and N2, because this was all news to them, and these were only the second H's and N's they'd seen. That pandemic was called the Asian flu, and it killed about 2 to 4 million people, a lot compared to the 250,000 to 500,000 thought to die worldwide in a normal flu year. In 1968, that virus swapped its H2 for what we, of course, called H3, also from a bird. Only 1 million died in the pandemic of what was called the Hong Kong flu, as the change in the virus was not dramatic enough to completely defeat our existing immunity. Both viruses are thought to have evolved in southern China, which agrees with Derek Smith's findings about flu coming from East Asia. Meanwhile, back in 1918, the pandemic virus also killed many pigs, but then they developed immunity like we did. It kept circulating as agriculture modernized and hog herds mushroomed in size. Then, in 1998, swine flu picked up genes from flu viruses normally found in people and in birds, both of which can also infect pigs and hybridize with the pig viruses. That aggressive new triple reassortant virus dominated North American pig farms within a year. In 2004, virologists warned these viruses had pandemic potential because they were also infecting occasional farm workers and sometimes picked up H and N proteins humans weren't used to. By this time, there were 2 flu viruses circulating in people, the H3N2 virus that had taken over in the pandemic in 1968, and a fairly mild descendant of the 1918 H1N1 virus, which we think escaped from a lab somewhere. Seriously, no one quite knows where. Maybe Russia. On the 21st of April 2009, the U.S. CDC reported 2 children in California with H1N1 flu. Except this wasn't the mild human strain of H1N1. This was more like the H1N1 virus found in pigs, except the children hadn't been near any pigs. Then, Canada issued a travel warning about a flu outbreak in Mexico, unusual in April, that had already killed at least 60 people. The U.S. found 2 more kids with swine flu in Texas. It all made pro-med. The morning of the 24th, I emailed my editor at New Scientist. This is exactly what an emerging pandemic would look like. It was. 5 days later, the WHO declared a pandemic was imminent. We knew this because a new virus was spreading human to human in North America that no one seemed likely to have much immunity to. The U.S. CDC was conducting daily briefings for us health journalists and, after a few pointed questions, said as much. That meant it was only a matter of time before it was spreading rapidly on another continent. When that happened, the WHO would officially declare a full-on pandemic. There are no hard and fast definitions for when other diseases, like COVID-19, can officially be called pandemic. But in 2009, that was the definition for a flu pandemic. But unlike COVID-19, we knew about flu pandemics. Once it was declared, vaccine makers would activate the contracts for pandemic vaccine with the 15 countries that had them. Countries that had pandemic plans would activate them, closing schools and handing out antiviral drugs we have for flu, depending on how virulent it was. I started digging. The Mexican outbreak had started in early April, killed dozens of people, including children, and spread widely over Easter. Like Lunar New Year in China, the time Mexicans visit family. It started on a huge hog farm in Veracruz, owned by U.S. giant Smithfield Farms. The company protested that its pigs were all vaccinated and, anyway, had no flu symptoms. Well, yes, of course they didn't. Vaccinated pigs don't show symptoms, but they can still carry and transmit flu. The UN Food and Agriculture Organization announced it would mobilize its experts to protect the pig sector from the novel H1N1 virus by confirming there is no direct link to pigs. Knowing the answer must have made it an easy investigation. The industry mostly seemed concerned about people calling it swine flu. Despite their efforts, most people still do. As far as I have been able to find out, the industry still publishes no monitoring data on flu in its herds. The virologists I talked to were scared. This was H1N1, not just the same family as the H1N1 pandemic virus of 1918, but a direct descendant, passed down from the pigs we infected way back then. It also had some genes that came directly from bird flu, another unsettling similarity to its pandemic ancestor. So far, it seemed to cause fairly mild disease, although some people were dying, and they seemed unusually young. But then again, in the 1918 pandemic's first spring wave, the disease was also quite mild. In the autumn, it turned lethal. The WHO was supposed to declare a pandemic once this new flu started spreading in the community outside North America, meaning, as it did for COVID-19, that there were people whose infection couldn't be traced to people or places already known to have it. But when Japan had a rash of cases, the WHO didn't act. Europe should have been next, yet for some reason cases were slow to materialize there. On May 20th, I reported why. The European CDC had set rules requiring someone to have had exposure to the U.S., Mexico, or a known case to be tested, which basically precluded finding any community-acquired cases. Similar rules kept Wuhan from finding community-acquired cases of COVID-19 in January 2020, and then the UK, the US, and other countries from finding them that February. The next week, 2 Greek students at universities in Edinburgh went to end-of-term parties, then developed fever and coughs on their way back to Greece. Their doctors defied the rule and tested. They had swine flu. The doctors complained that the rules were stopping Europe from finding local cases. I reported it in New Scientist on Friday, May 29th. The rules were changed Wednesday, June 3rd. I honestly don't know if our article made a difference. The Greek doctors were the heroes. But after the pandemic was over, I got an unexpected gift from a flu guy at a health agency that shall be nameless. A commemorative swine flu t-shirt he'd had made for his staff, designed like a rock and roll tour shirt with the dates the virus arrived in different countries. It remains a treasured possession. On June 11th, with cases mounting in Europe, the WHO finally declared swine flu a pandemic. On the day the WHO declared COVID-19 a pandemic in 2020, the agency complained about countries that still wouldn't test people who had no contact with a known case, China, or another early place that had the disease, even though it was clear the virus was spreading far more widely. It seems little has changed. But in 2009, the WHO stressed that its declaration of a pandemic was a reflection of the spread of the new H1N1 virus, not the severity of illness. It turned out Europe, Japan, and the U.S. had been begging WHO not to declare a pandemic. All their pandemic plans were based on a worst-case scenario, a pandemic of a nasty bird flu that had been spreading around the world since 2004. Swine flu just didn't seem severe enough to warrant the upset. Declaring a pandemic would cause panic, they feared, for a virus that seemed to kill about as often as ordinary flu, albeit younger people. Yet while governments were complaining that the pandemic virus was too mild to make a fuss over, vaccine makers had actually been counting on a mild first wave. That would give them time to make a vaccine in time for an autumn wave, which, if this was like the 1918 H1N1, could be dire. In the end, no vaccine was available until the autumn wave in North America was practically over anyway. There seemed to be a real mismatch between the pandemic plans, what we know flu does, and what we could realistically do about it. Doctors I spoke to at the time said the new flu was mostly mild, except when it wasn't, whereupon it was horrendous. Much like COVID-19. I remember a doctor in Winnipeg almost weeping on the phone as he described wards full of desperately ill young adults, many of them First Nations people, who were especially at risk, needing ventilators and artificial breathing machines. Scientists at Imperial College in London actually made some good come of this by doing demanding clinical research in the teeth of the pandemic, as one described it, and discovering a gene that predisposes some people to severe cases. It's amazing how many diseases of pandemic concern are like that. Not so bad, except when they are. Being able to predict who is especially at risk would help protect those people and maybe tell us exactly how these viruses cause benign or lethal disease, so we can design better treatments. The team is repeating the research with COVID-19. However, swine flu pulled a real surprise that shows just how different flu is from COVID-19. People born before the H2N2 pandemic of 1957, when H1N1 still ruled the earth, were more immune than had been initially expected to the H1N1 virus of 2009. You have the strongest immunity to the first kind of flu you encounter as a child, for reasons no one yet understands. Before 1957, the only human flu around was an H1N1 descendant directly from 1918. So was the pandemic virus, but immunologists initially thought the two were too different, and immunity to the old virus wouldn't protect people from the new one. They were wrong. So the old people who normally die in droves from flu and are currently dying of COVID-19 didn't in that pandemic. One reason it's considered mild. Something similar happened in 1918, says Jeff Taubenberger of the U.S. National Institutes of Health. Elderly people born around 1850 were also relatively immune to the Spanish flu, possibly because a flu with similar surface proteins circulated then. You hear stories that younger people died in 1918, but older people did not, because in both cases their immune reactions killed them. But younger people have stronger immune reactions. Nonsense. Older people had experienced that virus before, because flu varieties come and go with successive pandemics. That happened again in 2009. If H2 ever comes back, only people born between its arrival in 1957 and disappearance in 1968 will have much immunity. I hope that's good news for some of you. Fortunately, the swine flu of 2009 never did mutate to become more severe, possibly because it was, well, swine flu, already adapted to mammals like us, and not, like the 1918 virus, largely adapted to birds. After 2010, it settled down as a normal winter flu. It didn't even displace the H3N2 virus that had already been circulating, and the two now vie for dominance each winter, one or the other winning out in different places. Where H3N2 wins, more older people die. Make no mistake, swine flu was not benign. 3 times more children died than in a normal flu season. I think it would be very misleading to describe that as mild, said Tom Frieden, then head of the U.S. CDC. Estimates vary, but at least 200,000 people, and possibly as many as 600,000, died worldwide from swine flu in its first year, some 80% of them under age 65. Normally, the U.S. CDC reports 80% of people who die of flu are over 65. All of this experience affected how we handled COVID-19 and will handle any future pandemic, flu or not. After the autumn wave, the WHO was bitterly attacked, amid widespread claims that responding to the 2009 pandemic, even when we had every reason to fear a replay of 1918, was an expensive overreaction. Some now even put a positive spin on that claim. In March, Zheng Guang, a top epidemiologist at China CDC, told the government newspaper, Global Times, that China overreacted in 2009, which served as a public mobilization drill for all-round control and prevention in the face of a massive outbreak, like COVID-19. But part of the attack on the WHO was led by the kind of people who have come to be called denialists, people who reject scientific information, even observable reality, that doesn't fit with claims that we are all victims of a giant conspiracy between big companies, corrupt governments, and, to them, shadowy scientists and international agencies. Swine flu was not really a pandemic, they claimed, even though it met every definition of one. Some of the accusers seemed disappointed it hadn't killed more. The WHO only called a pandemic, the denialists alleged, so its cronies in the drug companies could make money selling pandemic drugs and vaccines, even though some vaccine companies actually took a loss on them, as a few countries asked for their money back. Individual scientists were accused of supporting the pandemic declaration because they were in the pay of these companies, a claim that did not withstand close examination, but was made easier because drug and vaccine companies, unsurprisingly, fund a lot of drug and vaccine research. If any of it had been remotely true, it would have made a great story for a journalist like me. It was frankly worse than untrue. It was poisonous claptrap, of the kind that has only gotten louder in the years since. For example, when the COVID-19 pandemic started, I heard people I had thought were sensible claim that this was just another scam to make money selling vaccines. Does any listener who has had the disease feel it was a scam? And, sorry, but what vaccines? Worse, though, in the years following the swine flu pandemic, the WHO seemed to become very gun-shy about calling pandemics. It stopped trying to set an official definition for pandemics at all, even a flu. In the early days of COVID-19, journalists kept asking, "Is it a pandemic yet?" WHO spokespersons got very annoyed. They asked, "Why do you care so much about that word?" I will stick my neck out here and respond. Because for years, the WHO has very correctly been warning us about the dangers of pandemics, especially a flu, which we know happen regularly. The word means something. The day after the WHO declared COVID-19 a pandemic, the world's press, much of which had been covering the story on inside pages, moved it to the front page. Some countries called their top-level emergency committees to discuss COVID-19 for the first time. There was an explosion of comment on social media. It made a big difference in how seriously people were taking this disease, and I think we could have used that a week or two earlier. Perhaps the WHO is still smarting from being attacked for declaring a flu pandemic in 2009, even though it was a textbook flu pandemic, and wants to be very careful with the word. If so, the world's reaction to the swine flu pandemic did us all a disservice when COVID-19 arrived. The WHO was also worried that governments would somehow conflate pandemic and flu. That's one reason flu matters so much to the story of COVID-19. When COVID-19 hit, most governments with pandemic plans had based them around flu. Many are actually entitled Influenza Pandemic Plan. COVID-19 is not flu, and that caused problems. Containment, where you isolate cases and trace and quarantine their contacts, was the WHO's main recommendation for COVID-19 early in the pandemic. But that is not possible with flu because the virus spreads faster than COVID-19, so it wasn't a part of these pandemic plans. The lesson here? Plan, but be prepared for the unexpected. To be fair, there was a very good reason governments had pandemic plans based on worst-case scenarios and flu. In 1997, 18 people in Hong Kong were infected with a bird flu called H5N1. 6 died. Virologists were shocked. It was the first time anyone had seen a bird flu directly infect people, and the results were apparently lethal. Hong Kong killed all 1.4 million chickens, ducks, and geese in the territory to stamp it out. H5N1 reappeared in 2001 in Hong Kong, which killed all its poultry again, and 2002. In 2003, a family of 4 from Hong Kong contracted the virus while visiting mainland China. 2 died. In January 2004, the virus ripped through poultry in Vietnam, and 10 people had died of it when I ran into Ab Osterhaus looking shell-shocked at the Royal Society. He had good reason. Overall, Nearly 2/3 of people who have caught this virus have died. It hasn't been able to spread person to person, but Ab was worried it would learn to do that without becoming appreciably less lethal. If someone helping dispose of the millions of sick birds had human flu and got H5N1 as well, a recombinant might emerge with an H and/or an N no human had seen before. Even the N1 protein was subtly different from its cousin on human H1N1 flu viruses. Add a few more bird genes, and it might not be much less lethal than the bird virus. The real nightmare might be if the bird virus itself could adapt to spread in people. By late January, South Korea, Japan, and Cambodia had millions of birds sick with H5N1, and Thailand and Indonesia admitted that poultry die-offs they had been blaming on other diseases since the previous year were actually H5N1. Thailand had sick people. No one had ever seen bird flu over such a wide area. China reported a few dead birds just over the border from Vietnam and claimed it had only just got the virus. Scientists I talked to didn't believe it. In 1999, a goose from mainland China carrying the same H5 as the 1997 virus turned up in Hong Kong, and the paper reporting it was entitled, "Continued Circulation in China of Highly Pathogenic Avian Influenza Viruses." In 2002, scientists at Hong Kong University reported finding a large variety of H5N1 viruses in chickens, which were probably now widespread in the region, China, and justify renewed pandemic concern. So we had reason to think H5N1 was circulating in Chinese poultry. It turned out that after Hong Kong slaughtered all its chickens in 1997, Chinese poultry producers selling to Hong Kong had started vaccinating their birds. That sounds like a good idea. But American scientists told me Mexican poultry producers had tried that too, and discovered that the bird flu virus could circulate at low levels in vaccinated chickens without giving itself away by causing symptoms. So I called the WHO official in charge of flu. I reached him on his cell phone as he sat on a bus heading up to the ski slopes. It was that time of year in Switzerland. He told me the WHO knew of virus samples from early 2003 that precisely matched the current outbreak, meaning this had been going on for a while. He wouldn't tell me which country they came from. On the 28th of January, I wrote that this outbreak had started a year ago and, based on what the scientists had been saying all along, probably in China. But poultry vaccination let the virus spread unseen. The following day, China's Vice Minister for Agriculture called a press conference in response. "It is purely a guess, a groundless guess," he fumed. "We have had strict surveillance." A spokesperson for the Foreign Ministry said the article was completely inaccurate, without proof, and moreover does not respect science. I started getting abusive emails from Chinese students. One accused me, presuming I was British, of complicity in the Opium War. But the day after the press conference, Chinese officials confirmed that there were outbreaks of H5N1 in chickens in Hubei and Hunan, just north of the outbreaks near the Vietnamese border. 2 days later, there were suspected outbreaks in 3 more nearby provinces. The day after that, 4 more provinces had outbreaks, plus the huge western expanse of Xinjiang. 2 days later, 2 more, this time northern provinces. It was as if H5N1 was, improbably rapidly, moving across the country from its toehold near Vietnam. I have it on good authority that our report helped prompt the wave of candor. After all, if we could work it out, others could. Sure enough, on February 2nd, the Times of London reported the following. A large number of poultry markets in southern China have reported cases of the disease, and dozens of traders and butchers in contact with infected chickens have died. Chinese journalists were forbidden to report the deaths. There were no press conferences this time. 2 months later, when I wrote about the further perils of chicken vaccination for New Scientist, Chinese state media reported it neutrally. By then, scientists comparing H5N1 across East Asia had found it was all very closely related, but its surface proteins were changing fast. We have a bucket of evolution going on, New Zealander Richard Webby, a leading flu virologist based in Memphis, told me. This shows that H5 is circulating fairly widely somewhere, under some kind of unusual selective pressure. Scientists who developed flu vaccines for poultry had warned about this in 2003. The vaccine might increase the risk of a flu pandemic in people, they feared, because the vaccinated birds spread the virus silently, and were a novel environment for a flu virus. So the viruses would probably evolve. The fact that flu was in chickens at all wasn't normal. Flu evolved to live benignly in the guts of waterfowl. They poop it out. Other ducks drink it. The virus continues. The virus needs the duck to keep shedding it for a while until, despite being diluted in pond water, it manages to reach another duck. The viruses that didn't make ducks sick, therefore, won the evolutionary race. Chickens are a different matter. Most of the 19 billion chickens alive in the world at any time live in large hen houses. In such pastures of plenty, a bird flu virus left by a passing duck infects chickens, then after a while often develops a highly pathogenic mutation in the H protein that allows it to infect cells throughout the bird, not just the gut. The virus doesn't need to persist in its host and be shed for a while before it gets a rare chance to infect another host. Hosts are everywhere. The virus that wins is the one that replicates massively and then gets into the next chicken faster than the next virus. Chickens die in droves, but sometimes it's adaptive for a disease to be more lethal. In 2004, the chicken industry in East Asia, as in much of the world, had become large-scale and intensive as growing prosperity boosted the demand for animal protein, and the H5N1 virus spreading across East Asia was a highly pathogenic strain. Usually, these viruses kill their victims so fast they run out of them and burn out. But this H5N1 persisted because the vaccinated chickens didn't die. It did, however, have to contend with the chicken's novel immune system, which meant new pressures to evolve. By 2006, Yi Guan of Shantou University had collected enough anal swabs from poultry across southeast China to demonstrate that the virus had been circulating continuously there for a decade, virtually entirely within the poultry trade. There were growing concerns that it might adapt to spread readily between mammals, especially after high-profile tiger deaths in zoos. The tigers weren't the only mammals dying of the virus. Javanese farmers even have a word for the cat disease, said Ab Osterhaus. In theory, every infected mammal was a chance for the virus to adapt to us. epidemiologists, including Ferguson's team at Imperial College London, that did many early analyses of COVID-19, started making contingency plans for if that happened. Plan A was to watch for the first cluster of human cases and contain everyone exposed until the virus died out. If we failed to contain it, and some epidemiologists thought that was a long shot, then Plan B was to protect everyone with a vaccine or drugs. Sound familiar? At the time, it seemed that governments did not understand that these were the only options on offer. Few had plans for deploying antiviral drugs or early surveillance to contain outbreaks. Although, to its credit, at this time China started developing its national computerized early warning system. Plan B required developing a vaccine and, just as important, the ability to make enough vaccine and drugs for everyone. Vaccine companies have done some H5N1 vaccine development, but there was no way to make that much vaccine quickly enough. The threat is still there, and we still can't do this for flu, just as we can't for COVID-19. Although COVID-19 has the excuse of being new, flu is not. In 2005, H5N1 spread beyond China, killing thousands of migrating birds at Qinghai Lake in the west of the country. Yi Guan found it was the virus from southeastern China. Senior Chinese officials attacked his science and made it illegal to collect animal disease samples. I had been dubious of early reports that wild birds could carry the virus. But it had started to become clear that, although this H5N1 killed many kinds of birds, diving ducks, for instance, and swans, dabbling ducks seemed to carry it with few or no ill effects. That was a problem, given the wandering habits of dabbling ducks. Male mallards migrate vast distances to the north in summer, nest on the tundra, and then fly back south. And they see the world. One year they may winter in Europe, the next Africa. Between the two seasons, they dabble in the same Siberian ponds as ducks from China. I ordered something I never imagined I'd need, an atlas of duck migration. And it showed exactly where H5N1 went. Throughout 2006, the headlines came thick and fast as H5N1 turned up in countries west of Qinghai, all descendants of the virus at the lake. There was panic in Britain and Bulgaria and Germany as H5N1 appeared, killing swans here, infecting ducks there. It turned up in northern Nigeria, just where my atlas marked a string of wetlands popular with mallards just in from Siberia. I got vicious emails from birdwatchers, terrified this would mean the persecution of birds. It didn't. But the virus itself has tragically harmed wild bird populations. No one knows how much. H5N1 is still out there. There was a massive outbreak of H5N1 in chickens near Wuhan in February 2020. In March 2020, there were outbreaks of H5N1 and variants of it in poultry in Taiwan, the Philippines, Afghanistan, China, India, North Korea, Philippines, and Vietnam, and in wild birds in Afghanistan, China, India, and Nepal. Among the virus's often overlooked impacts is the cost, often to poor farmers, of destroying millions of birds to extinguish outbreaks. In Southeast Asia, that was estimated to have run into billions of dollars just by 2005. Human deaths diminished after 2006, as people learned to avoid infected poultry. There were 4 deaths in Egypt and Indonesia in 2017, and then one young man died in Nepal in 2019. So far, 17 countries have reported 861 human cases. More than half died. A frightening rate. The H5N1 strain is not the only problem. In 2013, an H7N9 turned up in live poultry markets in China and caused severe disease in people. But most of the viruses did not have the highly pathogenic mutation, so H7N9 didn't give itself away by killing poultry. Since 2013, H7N9 has infected 1,568 people in China and killed 616. 39%. Only 4 cases have been reported since October 2017. This may have been because China started widespread vaccination of chickens for it that year, reducing the amount of virus people encountered, but making its spread invisible. A few human infections with H7N9 seemed to spread person to person after close contact. That was worrying. H5N1 has been circulating widely for 16 years now, yet it has never really done that. Virologists had long wanted to know if it was capable of evolving that capability. So Ron Fouchier, the Dutch scientist who first isolated MERS, primed an H5N1 virus with 3 mutations known to adapt bird flu to mammals. 2 of them were discovered in the bird-derived proteins on the pandemic viruses in 1918, 1957, and 1968, so they had a history of enabling pandemics. Next, he infected ferrets with the primed virus, caged them next to other ferrets in a very high-containment lab, and watched. Ferrets are the standard experimental animal for flu, as they get it much the same way humans do. The first set of ferrets spread it to a second, and so on for 10 successive transmissions. This was it. Mammalian transmissible H5N1. It turned out the virus acquired 2 further mutations in the ferrets that made it spread more easily. So H5N1 was only 5 mutations in total away from spreading in us. None of the ferrets that caught the virus this way died. However, the team had discovered that, because our noses are different, you have to blow a virus into the ferret's windpipe to get an idea of how deadly it will be in people. When that was done, the transmissible virus killed all the ferrets. It had become fully contagious in mammals like us, without losing any of its deadliness. Fouchier described this at a big flu meeting in Malta in 2011. As I listened to his talk, scribbling furiously in my notebook, I felt that weird mix of sensations you get on a story like this, both excited and terrified. This was big. People had started accusing scientists of hyping the threat of H5N1. Maybe it couldn't become transmissible in people, they said. But this one did, at least in mammals. I'll never forget how somber and serious Fouchier looked when I tracked him down at the coffee break and asked him about it. The other flu scientists, I asked, looked scared too. Later, there was an almighty ruckus when the team submitted the work for publication in Science, a leading scientific journal. The top biosecurity committee in the U.S. tried to stop its publication, arguing that a bioterrorist might use the recipe to brew a deadly pandemic. As the work had partly been funded by a U.S. agency, they had a say in publishing it. Fouchier replied that we needed the work to understand what risk the virus posed, especially as it was now widespread in birds across Eurasia and Africa. He also claimed it wasn't such a scary virus after all. But I know what I saw on those faces in Malta. The work was ultimately published. What did temper the scariness a bit is that not all of those 3 priming mutations had cropped up naturally in wild H5N1, although they had in other kinds of bird flu. Maybe for some reason H5N1 can't go transmissible on its own. But here's the really scary bit. H7N9 already has 3 of the 5 mutations that made H5N1 transmit freely between Fouchier's ferrets. The fear is that if H7N9 infects the occasional mammal, which it does, humans, it could acquire the other mutations it needs while it's there, like H5N1 did in the ferrets. It may not need them, though. In 2017, some H7N9 acquired the highly pathogenic mutation in chickens, and Yoshihiro Kawaoka, a flu virologist in Wisconsin, discovered that those viruses would already spread between ferrets and killed some of them, just from being inhaled, without the virus having to be blown into their windpipes. It's the first bird flu we've found that does that. We don't know for sure if the mutations that made H5N1 transmissible in mammals also work for H7N9. The experiment hasn't been done. After the confrontation over publishing the H5N1 work, further work that might make nasty viruses nastier, called gain-of-function research, was banned or discouraged in the U.S. and Europe. Anthony Fauci, the tough-minded head of the U.S. National Institute for Allergy and Infectious Disease, NIAID, has become a popular hero in the U.S. for calmly presenting the science of COVID-19 at televised presidential briefings. In 2012, he resolved the dispute over Fouchier's work by saying any future such experiments first had to be assessed for their risks and benefits by experts in the agency, or it wouldn't fund them. In 2017, gain-of-function experiments in theory were allowed to resume. There is certainly a real risk, and not just from bad actors deliberately making a bioterror germ. Possibly worse is that other scientists with leaky labs might try to repeat the work. If such a virus escaped, it would no longer matter if it might have emerged in nature. We would have shot ourselves in our collective feet. I am personally inclined to believe Fouchier's lab is as safe as they get, as the Dutch inspectors are especially stringent, but I don't know about everyone else. This issue goes beyond flu. Ralph Barrick, who found that the coronaviruses Xi Jinping found in bats in Yunnan could infect human respiratory tract cells, wanted to see what would be needed to make that virus more dangerous in people, like Fouchier and his ferrets. However, this would have been a gain of function, so he initially couldn't do the experiments. In 2019, NIAID funded the EcoHealth Alliance partly so that Xi Jinping's lab, with its top-level containment facilities, could do that work with the bat viruses to see what changes to the external spike protein made them better at infecting human cells. It presumably vetted the risks and benefits first. The process is confidential, so all we know is that the vetting committee felt understanding the threat from these viruses outweighed the risk of escape. But the funding was canceled after unsubstantiated allegations that COVID-19 escaped from the lab. The scientists argue that we need to understand those viruses better, as nature is doing its own experiment. Mother Nature is the ultimate bioterrorist, is the mantra I hear from virologists. The viruses she found naturally in bats were already plenty capable of infecting human cells, and a good example of what Mother Nature can do. After the funding was canceled, EcoHealth Alliance released a statement noting that international collaboration with countries where viruses emerge is absolutely vital to our own public health and national security here in the USA. A flu pandemic is coming. That's what flu does. Maybe it will be fairly mild, like in 2009, but tell that to the people who lost loved ones then, and there were plenty. Maybe it will be H7N9, packing the same 40% death rate it has now. Maybe it will be a total surprise, something brewing on a giant hog farm or in a backyard flock of chickens swapping viruses with the wildlife. But it's coming. Are we prepared? No. As we will hear in the next chapter, we can't make flu vaccine fast enough, in large enough quantities for a flu pandemic. And although flu is the one virus for which we have effective antiviral drugs, it isn't clear we have enough of those either. If we're not ready for the pandemic we can see coming, how can we be ready for the ones we don't? Chapter 6. So what do we do about disease? The world needs to prepare for pandemics in the same serious way it prepares for war. Bill Gates, Massachusetts Medical Society, 2018. The world was not prepared for COVID-19, and it is not prepared for pandemics generally. In spite of all our alarmist outcries in the past for better pandemic preparedness, we are now starting to prepare when the house is on fire. Says Ab Osterhaus, what should we now be doing about that? You'd have thought we wouldn't be lacking in pandemic plans. Countries and experts have been talking about it ever since the world got spooked by H5N1 bird flu in 2004. Yet, when COVID-19 arrived, there were disputes in many countries about whether to lock down, how to do it, whether or not containment was possible, and when to lift restrictions. Instead of arguing about these things ahead of time, governments were vacillating, just as medical staff ran out of ventilators and protective gear, and the economic impact just of our efforts to slow the virus's spread caused mass unemployment, bankruptcies, poverty, even starvation. Very few governments seem to have widely agreed plans for what to do when a pandemic struck. There was almost no coordination internationally, even initially within the European Union. This shouldn't have been a surprise. Christopher Kirchhoff, who led the U.S. military's mission against the 2014 Ebola epidemic, described in March 2020 how a high-level analysis of the response to that epidemic concluded that with a trickier disease, one that, unlike Ebola, spread before it caused symptoms, like COVID-19, the response system of the United States and the international response system would risk collapse. The U.S. tried to improve matters. It spent $1 billion on detection labs and preparedness plans in developing countries, as required by the international health regulations, stockpiled protective equipment, and set up networks of hospitals in the U.S. primed to respond to a pandemic, and created an office in the White House to plan and lead the response, the National Security Council Directorate for Global Health Security and Biodefense. All three, wrote Kirchhoff, were underfunded or shut down under the Trump administration. When the COVID-19 pandemic hit, the pandemic plan written by the Obama administration was largely ignored. But while those political problems are unique to the U.S., lack of preparation and action was not. On March 11th, WHO Director General Tedros Ghebreyesus finally called COVID-19 a pandemic and said he was doing it because we are deeply concerned both by the alarming levels of spread and severity and by the alarming levels of inaction. For weeks, the world, especially the rich West, seemed locked in a slow-motion train wreck, as though countries could not believe the oncoming storm was going to reach them and were paralyzed, not knowing how to respond. There was a lot of denial. Senior officials in North America and Europe were saying this might all still be contained in China, when scientists suspected it was probably already worldwide. And it turned out, those scientists were right. National plans that called unambiguously for certain responses when certain kinds of events happened should have triggered more decisive action earlier. Clearly, many countries did not have them. Even where there were plans, and even if they were followed, they were mostly devised for flu, which, as we have seen, is different from COVID-19 in many ways. Containment doesn't work for fast-spreading flu, but as China showed, it works for COVID-19. The WHO delayed calling COVID-19 a pandemic partly because they feared countries would abandon containment and testing and rush straight to flu-inspired social distancing. And for some countries, it may have been right about that. Many countries at least tried to plan for a flu pandemic, but when a milder-than-feared pandemic hit in 2009, some countries actually rolled back even that preparation. A Global Preparedness Monitoring Board, GPMB, co-chaired by Gro Harlem Brundtland, the WHO Director General during SARS, reported in 2019 that, for too long, we have allowed a cycle of panic and neglect when it comes to pandemics. We ramp up efforts when there is a serious threat, then quickly forget about them when the threat subsides. It is well past time to act. Yes, but what action do we need? There was some hope after the 2014 Ebola epidemic in West Africa almost spun out of control that the near miss would jolt the world into doing more to prepare for major disease incidents. And it did trigger a few things that have been invaluable in dealing with COVID-19, such as the creation of CEPI, which organizes funding for pandemic vaccines, and the beefed-up emergency response capability at the WHO. But we were still caught flat-footed. Work on drugs and vaccines for coronaviruses had been minimal, even though we knew the risk. Some basic research had been done, and some startup companies even had a few experimental vaccines, but nothing ready for prime time. Pandemic plans varied from country to country or state to state or didn't exist. A high-level UN panel warned in 2016 that the world was underestimating the risk of something less readily controllable than Ebola, such as a virulent respiratory pathogen, and that its ability to prepare, never mind respond, was woefully insufficient. COVID-19 is a virulent respiratory pathogen, and they were right. The need for speed the WHO warned of failed to register in all but a handful of places, as we have seen: South Korea, Taiwan, Singapore, Hong Kong, and a few others such as Vietnam and New Zealand. After Ebola, the UK set up a rapid response team that, it proudly said at the time, could investigate and respond to disease outbreaks anywhere in the world within 48 hours. But when COVID-19 arrived in the UK, the response was far slower. An initial plan for quarantine and contact tracing to achieve containment was let down by inadequate testing, then abandoned for a scientifically half-baked plan to allow most people to be exposed in order to develop herd immunity. This was in turn abandoned when scientists explained how many deaths this would entail. It was replaced by social distancing. But the delay, plus weak enforcement, led, by May 2020, to Europe's highest death rate. Meanwhile, limited protective equipment took a high toll of healthcare workers. The GPMB found that the great majority of national health systems couldn't handle the large influx of patients they would get with severe, fast-spreading respiratory pathogen. There was no surge capacity in hospitals, they charged, or in key manufacturing, like making medical masks and gowns. That came true in many places with COVID-19. At least the world's governments have now responded to the COVID-19 crisis by admitting there's a problem. That could be the real silver lining of this pandemic. There is no longer any dodging the fact that humanity is at risk from fast-spreading infectious disease and currently can apparently do little to prevent it or to respond effectively. On March 26th, the G20, the world's 20th richest governments, issued a statement promising to strengthen national, regional, and global capacities to respond to potential infectious disease outbreaks by substantially increasing our epidemic preparedness spending. And they did their homework on what the spending should cover. We further commit to work together to increase research and development funding for vaccines and medicines, leverage digital technologies, and strengthen scientific international cooperation, rapid development, manufacturing, and distribution of diagnostics, antiviral medicines and vaccines, adhering to the objectives of efficacy, safety, equity, accessibility, and affordability. We ask the WHO, who assesses gaps in pandemic preparedness and report to a joint meeting of finance and health ministers in the coming months, with a view to establish a global initiative on pandemic preparedness and response. And this time, no dropping the ball when the crisis is over, they promise. This initiative will act as a universal, efficient, sustained funding and coordination platform to accelerate the development and delivery of vaccines, diagnostics, and treatments. Sounds good, if they stick to their promises. It's a lot of very broad commitments, though. How can they put it all into practice in an ultimately effective way? What exactly should they be working on, considering that, besides flu, we don't know what virus will be next, or even what kind of flu? What is a substantial increase in funding from governments reeling with the costs of the pandemic? The planning effort will at least be aided by the fact that now, with COVID-19, we can see clearly what we should have been doing for the past 10 years. Let's look at the toolbox. First, know your enemy. What germs should we target? And must we focus exclusively on responding to a disease once it emerges? Can we do more to stop it from emerging at all? We looked earlier at the WHO's list of priority pathogens to get a feel for what may be out there. But not everyone thinks such lists are helpful. In 2018, the Johns Hopkins Center for Health Security warned that lists like the WHO's stultify thinking on pandemic pathogens by suggesting those are the only diseases we need to worry about. And some pathogens on the WHO list, they implied, were not truly global risks, but were put there to please regions where they are a problem. Instead, Hopkins called for keeping a close eye on the entire class of pathogens they suspect are most likely to cause real problems. Respiratory RNA viruses. They mutate and evolve faster than any other pathogens and thus can jump species fast. And, contends Amesh Adalja at Hopkins, although we can stop gut pathogens with sewage management and infections like Ebola and HIV by being careful about body fluids, respiratory infections are harder to stop. No one can stop inhaling. 2 years later, COVID-19, a respiratory RNA virus, proved their suspicions right. Hopkins also called for more investigation into what pathogens are out there actually making people sick. Many people don't realize that most diagnoses doctors make are syndromic. Pneumonia, meningitis, fever, and sepsis are terms that describe the disease process, not what is causing it. The actual pathogens behind these are often not even determined, as this is not needed for treatment. Instead, doctors use wide-spectrum antibiotics for bacteria, or with viruses like COVID-19, they just try to keep the patient alive until the patient's antiviral immune response kicks in. Illuminating this biological dark matter, the Hopkins team argued, would focus pathogen discovery efforts on established damage-causing microbes. Aggressively doing such diagnoses in a few sentinel locations, perhaps zoonoses hotspots, might reveal the next big threat early as it starts jumping to people. To do more specific diagnoses of syndromes, hospital labs need new kinds of diagnostic technologies that can distinguish a wide range of pathogens. This is why diagnostic tools is one of the things the G20 said they'd make sure we get. Fortunately, there has been a massive surge in these over the past decade, so we're at least on the right track. Diagnostics manufacturers are now making automated panels of tests that can recognize the DNA or RNA of, say, a dozen respiratory or gut viruses, a huge improvement over old methods based on growing pathogens in culture to identify them, which is slow and insensitive. Making this kind of capability available more widely, including in countries that cannot afford it now but have hotspots of disease emergence, would illuminate a lot of pathogenic dark matter and give us a much stronger idea of exactly what pathogens we are contending with. For now, the most widely used diagnostic panels on the market are designed for routine hospital practice and mostly look for the usual suspects that cause most human infection. In sentinel sites looking for surprises, it would be good to have something that can spot the unexpected and unknown. That might seem impossible. How do you design a test for the unknown? But one system, put on the market in Europe in 2014, could do just that. The Iridica system was based on replicating the DNA or RNA from the pathogen in a sample and then putting it through a small mass spectrometer which precisely determines its molecular weight down to the last atom. Using a database of known weights from different pathogens, the molecular weight can identify the species, and even whether bacteria are carrying an antibiotic resistance gene. Or if it doesn't match any known species, says Rangarajan Sampath, chief scientist at FIND, a nonprofit in Geneva that promotes diagnostics development, it can tell whether it is a hitherto unknown flu or coronavirus or a member of other virus families. It was initially sponsored by DARPA, the U.S. Defense Research Agency that, DARPA people always mention, invented the Internet. It was originally intended to scan for biological weapons. I heard about the prototype at a biodefense meeting in Stockholm in 1998. In 2009, an experimental prototype of the technology was the first to spot the new flu from Mexico in the U.S. It was set up to recognize not just flu, but each of its 8 RNA elements, and it spotted that this new virus had elements from bird, swine, and human flu viruses. But doctors and regulatory agencies for medical technologies have been slow to warm to automated diagnostics. Iridica was finally put on the market in Europe in 2014 and was on track for approval in the U.S. Then, in 2017, the pharmaceutical giant Abbott, which owned Iridica, simply stopped making it. It had been a tough sell to hospitals with budgets stretched by government cuts and the growing health demands of an aging population. The real problem was that identifying the pathogens causing their patients sepsis or pneumonia wasn't obviously cost-effective if there was often no pathogen-specific treatment to use as a result. "It deeply saddens me," says Sampath. "There is still no viable alternative," he laments, "especially for rapidly diagnosing pathogens causing sepsis, which is often lethal, and where knowing the pathogen fast really can save a life. It would be invaluable in places like zoonosis hotspots, where real novelties can turn up, as it can rapidly rule out virtually all known pathogens and pinpoint an unknown pathogen's family. There is a vicious circle in trying to promote more specific diagnosis. As we noted earlier, there's no point testing infections routinely if there isn't a specific treatment for the pathogen. But since we don't test, the Hopkins group argues, we don't know what pathogens we should be developing treatments for. Astonishingly, there are no specific treatments or vaccines for any respiratory RNA virus besides flu. At least we might soon have a few for COVID-19. Moreover, there is global surveillance only for flu. Countries determine what varieties they have circulating and send samples to a global network of labs organized by the WHO, which is how we keep tabs on flu evolution and make new vaccines every year against what we think will circulate next. One perk for participating countries is that, in theory, they get access to any pandemic vaccines that result, although in an emergency, with vaccine manufacturing countries tempted, despite international agreements, to hang on to whatever vaccine they make, it isn't certain the guarantee will work. Hopkins wants surveillance extended to respiratory RNA viruses other than flu, with sampling from around the world, especially in suspected hotspots. They wanted to include coronaviruses, Nipah and Hendra viruses, and enteroviruses, the most common family of viral infections in humans, which are mostly symptomless or mild, except a few, one of which is polio. They even want to watch rhinovirus, the only more frequent cause of common colds than the 4 mild coronaviruses that circulated in people before COVID-19. Because even common colds can go bad. A cold is a syndrome, not a specific germ. At least 200 viruses cause them. In 2005, a novel adenovirus, Ad14, appeared on U.S. military bases after they stopped vaccinating for adenoviruses, which are common causes of colds among recruits. This one caused severe pneumonia in 140 known people in the U.S., many of them young and healthy, and there were probably many more cases that were not tested. 10 of the 140 died. By 2008, most people were exposed and immune, and it became just another winter cold virus. But viruses don't always settle down and behave like that, and we don't know about most of them. Some think we should find our plagues before they find us. Of course, we should try and spot new diseases after they emerge in people so we can shut them down fast. But Peter Daszak observes that with both novel disease outbreaks and their economic impacts increasing fast, it would make sense to deal with the underlying drivers, changes in human ecology and human-animal interactions, to stop emergence from happening at all. To enable that, the proposed Global Virome Project wants to genetically sequence and map the estimated 500,000 viruses in animals and birds that belong to families of viruses that we know can infect humans. It would cost $3.7 billion over the next 10 years, says project leader Dennis Carroll, who also launched the PREDICT program that helped discover the bat viruses in Yunnan. He contrasts that to the trillions the COVID-19 pandemic will cost. Knowing where the potentially dangerous viruses are, he says, will help us focus preventative efforts, such as reducing interactions between people and the species or the places that we know have worrying germs. But critics object that although such a survey would be great science, it isn't much good for preventing the next pandemic unless we also know what the viruses can do and then do something about them. These efforts will not necessarily translate into better pandemic preparedness given the sheer numbers of viruses that will be cataloged without a clear means of prioritizing them, and the fact that most identified viruses will pose little to no threat to humans, says the Hopkins team. No amount of DNA sequencing can tell us when or where the next virus outbreak will appear, agreed Andrew Rambeau and colleagues in a critique of the idea in 2018. The 2014 Ebola epidemic was, at that point, the most sequenced viral outbreak of all time, and that didn't stop another in the Democratic Republic of the Congo in 2018. Indeed, by 2013, virologists had sequenced and reported SARS-like bat viruses and warned of their pandemic potential. That prediction didn't stop COVID, says Adalja. People think the risks of these things are hypothetical. As we all know now, that one wasn't. Echoing the Hopkins group, Rambeau and colleagues say it would be money better spent to do disease surveillance in people, to spot new infections as they emerge, using sequencing to spot the viruses and serology, testing blood for antibodies, to see what infections people have had before. And this, they say, would be best done by a global network of trained local researchers. There, Carroll agrees, although he also wants this network to monitor, respond, and prevent viral spillover while they are still evolving in animal populations. Case in point, bat viruses. Even scientists who disagree on where in the process of viral emergence we need to look agree on one thing. We need more people everywhere looking, preferably, in their own backyards. We do have some eyes on the world already. The Canadian system that first spotted SARS is still watching global online chatter for mentions of disease and sends WHO about 3,000 signals per month, online mentions of things that might bear watching. The WHO follows up on about 300 of these and investigates 30 in more detail, on average, one a day. But veterans of the international health scene, like David Heyman and Seth Berkley, head of Gavi, an agency that helps poor countries buy vaccines, say more countries should do their own monitoring and share the results. Eavesdropping on global online chatter is an interesting way to keep tabs on things, but to seriously monitor disease, local public health people with a good idea of local diseases and the ability to investigate would be optimal. This is not a new idea. It just hasn't been acted on. The International Health Regulations, IHR, were originally a binding international treaty based on earlier rules drawn up in the 19th century that required countries to notify each other about a few diseases: cholera, plague, yellow fever, and, before it was eradicated, smallpox, that posed an international risk through shipping. After SARS, the IHR treaty was revised. The 2005 version obliges countries to save lives and jobs endangered by the international spread of any disease. They are supposed to coordinate their monitoring and response to disease with each other, and rich countries are meant to help poor ones do sufficient surveillance to spot anything dangerous. They have done a bit, but not enough. When Ebola broke out in West Africa in 2014, the first thing that failed was surveillance. The outbreak began in Guinea in December 2013, but it wasn't identified as Ebola until March, by which time it had spread widely. After that, the response failed. It was August, and the virus was out of control in 2 cities before the WHO declared an emergency. The WHO was criticized for the second delay, which happened partly due to organizational rigidities it has since tried to fix. But the fundamental problem was the first delay, and that was failed surveillance. The IHR requires countries to tell the WHO about any outbreak that is serious, unusual, or could trigger international travel or trade restrictions. That applied to COVID-19, and China did tell the WHO about it. But there are no provisions allowing the WHO to inspect the situation on the ground to see if the declaration is true. For instance, whether the infection really wasn't spreading between people. Most concerns, however, have focused on countries much poorer than China that don't have the capacity to detect and diagnose a sudden cluster of infections and tell the WHO about them. Many such countries are in exactly the tropical or subtropical hotspots for disease emergence that need closest watching. It was to investigate such alerts that the UK developed its 48-hour response team. When the IHR Treaty was updated in 2005, it required all countries to put their own surveillance capacity in place by 2014. It then extended the deadline to 2016. Did countries make it? They didn't, says David Heyman, who steered the negotiations that revised the IHR in 2005. Rich countries have been more interested in funding international response capabilities, like the WHO's new emergency unit. There's been much less help for poor countries to take charge of their own pathogen surveillance. It's almost as if rich countries are interested in riding to the rescue in emergencies, but not in preventing the disease emergence that causes emergencies in the first place. In fact, surveillance and response need to go hand in hand. An assessment in 2019 by an international collaboration called the Global Health Security Alliance, aimed at measuring and enabling countries' adherence to the IHR, found that no country is fully prepared for epidemics or pandemics, whether it was rich or poor. Countries were judged on, among other things, whether they could prevent the emergence of pathogens, detect and report epidemics of potential international concern, respond to them, treat the sick, and protect health workers. The results were abysmal. Only 19% of countries got marks over 80% for detection and reporting capabilities, whereas fewer than 5% got top marks for their ability to rapidly respond to and mitigate an epidemic. The overall average in all categories was 40%, rich and poor together, but even rich countries on their own only got an average score of 52%. Pandemic preparedness surged a bit in rich countries after the anthrax attacks of 2001 in the U.S. and after the threat of H5N1 bird flu in 2004. But when the 2009 flu pandemic wasn't apocalyptic, preparedness fell out of favor. Some countries let stockpiles of antiviral drugs for flu lapse, and as far as I have been able to find out, no one renewed pre-orders for pandemic flu vaccines. The UK government held a simulation drill for a flu pandemic in 2016, Exercise Cygnus. Its results have never been published, but participants have let slip that it showed that health services and even morgues would be overwhelmed. That happened with COVID-19, so we can only assume the warning was not adequately acted upon. Activists are launching legal action to compel the release of the results. A similar flu simulation exercise in the U.S. in 2019, called Crimson Contagion, also not released until leaked by the New York Times in March 2020, revealed a confused, underprepared pandemic response that foreshadowed what happened with COVID-19. You would think if any organization was prepared for epidemics and pandemics, it would be the WHO, but its slow response to Ebola in 2014 proved otherwise. That was partly due to undue deference to its own African regional office and local governments, which tried to downplay the outbreak when it still seemed small, and partly, I heard at the time, to a rigid hierarchy that kept its epidemic experts in the field from alerting the leadership to what they knew was coming. That difficult point in an epidemic when it still looks trivial, but isn't. But it was also because the agency simply couldn't raise the cash for an emergency response fast enough. But the WHO adapted fast. During Ebola, we needed to do new things, like recruiting 2,000 people to isolate Ebola cases and their contacts in remote areas, says the WHO's Bruce Aylward, who ramped up the agency's Ebola response in September 2014. The WHO had to bring in new kinds of expertise from disaster response agencies. The learning curve was steep. It's like asking a penguin to fly, he told me later. You throw it off a cliff, and I'm amazed how well the damn thing flew. The WHO emergency response team that grew out of that experience has led the international response to COVID-19. The penguin has grown real wings. But it is supported by voluntary funding from member states, never completely reliable, and repeatedly imperiled, including at the height of the pandemic in April 2020, by threats from the U.S. to pull funding. Yet, to prevent future pandemics, the world needs reliable surveillance and response, and those need to be coordinated globally. The job of the WHO. It will need more funding more reliably to do that. Moreover, with more surveillance, it will need to be able to predict far better than we can now which outbreaks pose a threat and require a response. COVID-19 was not the first unexplained pneumonia in China. Earlier, we saw there were instances reported on ProMed in previous years that seemed to go no further. Which outbreaks have legs, and what might tip us off? There is hope that big data might help, with everything from Google searches for flu to hospitals' anonymized electronic medical records crunched on a large scale to suggest when something serious might be emerging. Ultimately, more research into how viruses damage us and what makes some worse than others should start telling us how to spot the dangerous ones. Systems like China's reporting network, designed to reveal an unexpected cluster of a syndrome in a region before it may be obvious on the ground, might also help here. In March, in a report for the think tank the American Enterprise Institute, scientists called for a permanent National Infectious Disease Forecasting Center in the U.S. to function similarly to the National Weather Service and provide decision support for public health, including what responses are warranted by what kinds of events. The researchers warn, however, that predictions in any complex system are no small undertaking. Weather is a fitting analogy, as the U.S. National Weather Service spends $1 billion a year collecting massive banks of weather data to turn into forecasts. The U.S. CDC spends a quarter of that on analogous data for public health. Local incidences of disease, age-specific death rates, vaccination rates, and has no budget for forecasting, as that has never before been realistic in public health. Of course, We already have one proven crowdsourced worldwide and battle-hardened disease surveillance system, ProMed. It also runs something called EpiCore, aimed at getting around nations' reluctance or inability to report disease. Medical and veterinary workers who know some field epidemiology sign up for it. And then, if ProMed hears a worrying rumor, it can ask them, privately, to check it out using a web platform guaranteeing privacy. If you meet the criteria for membership, you might consider joining. Astonishingly, however, ProMed is supported by a few grants and voluntary donations and can barely cover its costs. Could we maybe find it some independent funding? It is an embarrassment that such a mainstay of the global response to infectious disease has to regularly ask for donations. In April 2020, as COVID-19 raged, we all got emails signed by Marjorie Pollack pleading for readers to maybe pony up $25. Finally, if we're going to take surveillance more seriously, there is one more area besides zoonotic hotspots we need to watch: labs. As we heard in the chapter on flu, research funding agencies in the U.S. and Europe are currently reluctant to permit experiments that, on purpose or not, make pathogens more dangerous, in efforts to find out how much threat they may pose. The scientists argue, though, that we need to know whether some viruses can actually become more dangerous, and if so, what mutations to watch for. The U.S. National Institute of Allergy and Infectious Diseases decided last year to renew funding for studies of coronaviruses at the Wuhan Institute of Virology for just that reason. The dilemma is always that doing the experiments without very tight containment might create the disaster we are trying to avoid. We can do research like that safely. We have been doing it for years. But I would argue that along with more funding for research, we must also fund better containment in labs and more oversight to make sure researchers are working safely and on things that truly warrant the risk. I've heard about too many cavalier experiments or planned experiments with viruses over the years. There was a collective sharp intake of breath from the virology world in 2001 after a colleague on New Scientist broke the news that a lab in Australia had completely inadvertently created an extra-virulent strain of mousepox, a rodent infection related to smallpox, by giving the virus a gene for what they thought was an innocuous immune-modulating substance. Then, in 2003, at a meeting in Geneva, I heard an American scientist describe plans to make an even deadlier version of that virus in a species of pox that humans can theoretically catch, although he was hoping the effect wouldn't manifest in people. The late D.A. Henderson, who led the eradication of smallpox, was still alive then, and he was sitting next to me in the lecture hall, getting perceptibly angrier and angrier. Several other scientists in the room were also looking uneasy. When one asked what the researcher hoped to learn from the experiment to warrant such a risk, a voice in the back said, 9/11. Apparently, we had to do this because terrorists might. I don't know if those experiments happened. One thing we can say about the virus that causes COVID-19, though, is that it was not made in a lab. In February, once they had a chance to look carefully at the virus, Christian Anderson of the Scripps Research Institute in La Jolla, California, and colleagues reported that, basically, virologists simply wouldn't have known enough to make a virus like this. Proteins are strings of hundreds of a smaller kind of molecule called amino acids. The types and order of these amino acids determine the structure of the protein, which in turn determines what it can do. Proteins are basically the tiny machines that do most of the processes of life. One spot on the COVID-19 virus's big external spike protein fits a spot on the ACE2 protein on human cells and binds to it so the virus can infect the cell. The binding site on the virus is a string of amino acids, Anderson admitted, that we wouldn't have predicted could bind to human ACE2. No virologist trying to build an artificial binding site would have chosen those. But it turns out they work just fine. The virus also has some completely novel mutations that would have been unlikely to arise in a lab just trying to study a wild virus, and a viral backbone unlike anything used to study coronaviruses in the lab. In March, an unprecedented statement by 27 of the biggest names in emerging disease ran in the top medical journal, The Lancet. We stand together to strongly condemn conspiracy theories suggesting COVID-19 does not have a natural origin, it said. Scientists from many countries have studied it, and they overwhelmingly conclude that this coronavirus originated in wildlife, calling the efforts of China's scientific community to deal with the outbreak and share their results remarkable. They concluded, "We want you, the science and health professionals of China, to know that we stand with you in your fight against this virus. Stand with our colleagues on the front line." That wouldn't be a bad rallying cry to carry forward into the post-COVID-19 world. There's no point doing all this planning, diagnosis, and surveillance without organizing a global response to whatever we find out is happening. For all of us now, disease anywhere is disease everywhere is no longer a slogan that sounds like it's for some telethon, but a lived reality. But as diseases have emerged, there has been an absence of globally joined-up thinking. Zika took the Americas by surprise in 2015, even though it had already moved eastward into the Pacific from Asia, causing more severe disease than it ever had before, and even though chikungunya, another mosquito-borne virus from Africa, made exactly the same trip in 2013. When virologists in Wuhan and North Carolina found bat coronaviruses that made mice sick and easily infected human cells in 2013, they practically shouted about the pandemic concerns this raised. Scientists also did that in 2004, about the family of swine flu viruses that indeed went pandemic in 2009. Perhaps it's easy to spot that in retrospect. But both times, nothing much seemed to be done. The One Health Platform is an organization of scientists started by virologist Ab Osterhaus and his colleagues that tries to bring together a wide range of researchers in human, animal, and environmental health, and people from governments and international organizations to take a wider look at global health security. It is as good a place as any to start talking about how the world should build operational, day-to-day activities that really address the threat of pandemics, not just spotting novel pathogens, but doing something about them. In a paper ahead of the World One Health Congress in 2020, the organizers say that in peacetime, between pandemics, we need the following: surveillance and diagnosis of disease syndromes in humans and animals, the identification of new pathogens, development of diagnostics and mechanisms for distributing them, research into how new infections cause disease, drugs, vaccines, and communication between scientists, governments, and the public. That last one especially tends too often to be forgotten. But that's a true scientist's list, mostly about finding out, not about taking action. Action, after all, is the job of governments, not scientists. So we might add to that list an authoritative international capability for deciding when all that investigation has, in fact, revealed a potential threat that requires a response. Drug and vaccine development, active monitoring, and making the response happen. Now that it is wartime, maybe governments will start paying attention and paying for that kind of preparedness. It has to be someone's job to organize the response to the warnings we will turn up as we redouble our watch on emerging pathogens. So, about those drugs and vaccines. First, know your enemy. Then, choose your weapons. As of May 2020, CEPI was organizing research and trials on 9 different kinds of candidate COVID-19 vaccines, and the WHO was helping organize trials of existing antiviral drugs to see if they worked on the pandemic virus. This is all essential, and we must be capable of such organization in wartime. But we need to look forward, too, at least after the first rush of R&D for COVID-19 has started bearing fruit, or we will always be playing a deadly game of catch-up. The one vaccine that desperately needs funding is one CEPI doesn't do, but was a priority the GPMB highlighted last year. A universal flu vaccine. You have heard this already, but it cannot be said too often. A flu pandemic is inevitable. A pandemic flu carries novel surface proteins to which many humans have little or no immunity. By definition, we cannot make a vaccine to a pandemic strain in advance, as we have no idea what surface proteins the next one will have. There are endless variations, and immunity to one does not give you immunity to the others. We could cook up a vaccine after the pandemic strain emerges, when we know what it will look like. In fact, this is the current plan, as it is pretty much all we can do. But doing that cannot protect enough people fast enough. The quantities aren't too constraining. The world can make 1.5 billion doses of winter flu vaccines per year, which means that, in theory, it can make 6.4 billion doses of a pandemic vaccine. There are more people in the world, but vaccine experts have told me we are unlikely to reach everyone, even if we make more. Why the difference, though, between ordinary and pandemic vaccine-making capacity? In most seasonal flu vaccines, one dose contains 15 micrograms of the H protein from each of the 3 strains of flu circulating every winter: the H3N2, the H1N1 left over from 2009, and the dominant strain of influenza B. Some vaccines have 4 strains with an extra B. In theory, since a pandemic vaccine is targeted at just the one strain, a pandemic vaccine only needs 15 micrograms of that specific H. So when vaccine production lines switch from seasonal to pandemic vaccine, they are capable, in theory, of churning out enough flu virus for 3 to 4 times more individual shots than normal. However, we might turn out to need far more of the pandemic virus's H protein to goad our immune systems into mounting an immune response, in which case we will be able to make far fewer doses of vaccine. That happened with some experimental vaccines for H5N1 bird flu. Or we may need 2 doses each of the vaccine a month apart to be protected, as younger people who had never encountered the H on the 2009 pandemic virus did. That will take time to administer, and by this point, we will not have enough for everyone. Or the outlook could be sunnier. We might be able to use an immune-stimulating chemical called an adjuvant to make small doses go farther. Several good ones have recently been developed, one of which is being incorporated into candidate COVID-19 vaccines. Vaccine researchers have also studied the possibility of making doses go farther by using tiny microneedles to inject that flu protein into our skin, instead of deep into a muscle as we do now. Skin is crawling with immune cells that can make the most of a tiny amount of vaccine. At least we can now make 4 times more standard flu vaccine than we could in 2006. One reason is because, as concerns over bird flu mounted back then, poor countries worried about their access to vaccines in a pandemic. So in 2006, the WHO launched a campaign to increase vaccine manufacturing capacity and put it in more poor countries. But all of these plants use the standard process for making flu vaccine, growing flu virus in eggs, which takes 6 months to produce enough, and that's if the vaccine virus grows well. In the 2009 pandemic, there was no vaccine available until the end of the autumn wave, partly because the virus initially grew slowly. If that H1N1 had turned extra virulent in the autumn wave like its forebearer in 1918, the fact that vaccines came too late would have been disastrous. So despite all this effort to make more standard vaccine, we still probably can't produce enough, fast enough, to save a lot of people if a really lethal flu hits. There are a few proposals for growing made-to-measure flu vaccines faster, for example, by producing flu proteins from the latest strain in plants. But the holy grail of flu vaccination is a universal flu vaccine. Scientists have been working on this for some 20 years. In theory, we could use bits of the flu virus that do not change, either year to year or between families of the virus, to immunize ourselves to all flu once and for all. Our immune systems mostly ignore these constant regions of the flu virus, seduced into making more antibodies against the big, obvious H protein, which is why flu viruses have it. The hope is that if we were more strongly immunized against these constant regions, our immune systems would attack any flu virus we encounter. We could develop and test it and get people immunized before a pandemic starts, even though we don't know what the exact virus will be. We could even stockpile it for people who hadn't already been vaccinated when the emergency hit. Several candidate vaccines have passed safety tests and seem to induce the right immune reactions. However, only one, made by the Israeli firm BioNTech and containing 9 unvarying stretches of protein from flu, has so far managed to get funding for the expensive, large-scale trial needed to see if it works. That trial is still underway. It has been hard for companies developing these vaccines to find enough funding for the usual reason. It would not be profitable for a company to make such a vaccine, as people would need only one shot or a few shots during the course of their lives. But no one other than the big companies can fund and organize such large-scale trials. The joke for years has been that a universal flu vaccine is always 5 years away. The GPMB called on governments to set a timeline by September 2020 for developing a universal flu vaccine. It didn't hazard a guess as to what that timeline would be, but there has been a steady buzz of low-key research for years, and a universal flu vaccine does seem almost in reach. How soon the world will buckle down on anything but COVID-19, though, is an open question. It seems like all we need to finish the job is an intensive burst of coordinated research, large-scale trials of the best universal vaccine options, and money to build manufacturing plants for the winners. COVID-19 is showing we can do all of this when we need to. The startup companies that develop the vaccines can't do it. If there was ever a case for public spending on a public good, instead of leaving things to a market that simply cannot do this job, universal flu vaccine is it. In fact, that too could be a silver lining to the dark cloud of COVID-19. Public-private partnerships have been starting to work on needed but non-profitable medical technologies like medicines and vaccines ever since big philanthropies like Gates, actually ever since Gates, got involved in R&D for the diseases of poor countries in the 2000s. Now that might accelerate. The press has been awash with commentaries claiming big government is back, as only governments can rescue the various industries that are going under during lockdowns and provide emergency income for people who have lost their jobs to social distancing. A lot may depend on how governments decide to handle the debt that will result, but many voters may prefer their tax money to go to better medicines and pandemic preparation than to some kinds of bailouts. It is accepted that governments invest in public goods, roads, schools, to provide the infrastructure that allows private enterprise to flourish, at least in theory. Market failure means we have no universal flu vaccine or effective antiviral drugs. And we're losing our antibacterial drugs to resistant bacteria. We'll get to that in a moment. If a government really wants to support its industry, there's a case to be made for keeping its workers and consumers alive. Of course, it's not only flu that should worry us. Another useful thing to have, if it is possible, would be a vaccine platform we can use for any virus that emerges. The WHO lists Disease X. One plan is to have an already tested, safe vaccine technology we can customize with a bit of the new virus, so it can be deployed with minimal further testing. There's precedent here. 2 Ebola vaccines were developed amid the burst of anxiety and funding that followed the 2001 anthrax attacks in the U.S., when it was feared Ebola might be used as a bioweapon. Work on them petered out as that burst of anxiety did, along with the funding. Also, with no sizable Ebola outbreak, the vaccines couldn't be tested. Then Ebola struck West Africa in 2014, and big vaccine companies, to their credit, stepped up and organized trials. Similar trials were organized for antiviral drugs, some now being used for COVID-19. One of the vaccines, originally developed by the Public Health Agency of Canada, was 95 to 100% effective at stopping Ebola in contacts of cases. It is now called Ervebo, the first Ebola vaccine ever put on the market. Another vaccine was tested in the 2018 Ebola epidemic in the Democratic Republic of the Congo. The point for future pandemics is that both vaccines consist of benign viruses carrying an Ebola protein. The protein induces immune reactions specific to Ebola, while the virus carrying it, a vaccine platform, gets the immune system's attention. Similar vaccines equipped with COVID-19 protein are now in development. The hope, eventually, is to have just such a tested vaccine platform ready, so we can just drop in a new protein from any surprise virus that emerges and have a vaccine quickly. CEPI wants to develop a safe all-purpose system like this so it can have a vaccine ready for tests in people within 16 weeks of a new pathogen being detected. That is not possible yet. The COVID-19 vaccine candidates that use a similar platform to the Ebola vaccines won't be through trials until the end of 2020. But those tests might bring an all-purpose vaccine platform closer. There's a further complication, though. We can design and test as many vaccines as we like for emerging diseases and for pandemic flu, but it isn't clear where we would make them in the large quantities required. There will never be enough demand for ordinary seasonal flu vaccine, industry insiders admit, to warrant enough manufacturing capacity for all the vaccine that would be needed in a flu pandemic, for example? And how do we become equipped to make vaccines to a threat that has not yet materialized? Bill Gates is funding the construction of 7 different kinds of vaccine manufacturing plants, while candidate COVID-19 vaccines are